Good morning. We will start at 9:30. Thank you, honorable members.
Good morning, Chair.
Recording in progress.
Morning, everyone, and welcome to this meeting, which is a meeting of the Portfolio Committee on Health on the 11th of October 2023. This is the second day I was listening to the entities of the Department of Health on their annual reports. We will be listening today to the OHSC, which is the Office of Health Standard Compliance, followed by the Medical Research Council and then the National Health Laboratory Services. And so today we will be doing this until 7:30 this evening. So I'm really going to ask you to allow us to stay within the time frames which we have put out for the day, so that we can all get through the day very comfortably. Before we continue, I'd like to ask Ms. Majalamba to give me an indication of attendance and apologies.
Good morning, and thank you, Jacobs. Hello, Ahmed, Baba, Morane, Rowane, Shilpa, Amusewa, Ademi. Thank you.
I hope it's not my system, Ms. Majalamba. Cannot hear you anymore.
Hello, Chair.
Yes, we can hear you now. Can you start again, please? Can you hear me?
Yes, I can hear you. Present is Dr. Jacobs, Ms. Stella, Dr. Harvard, Baba, One, Clean, from Sengwa, Ms. Stefan Staden. I've received from Ms.
Thank you very much. So we also welcome everybody who has joined. We welcome our staff. We welcome members of the public, everyone who has joined our meeting this morning. Just before we continue, let us just read the rules of the meeting. This meeting is deemed to be in the precinct of Parliament. And
I'm fine, thanks.
sorry, Ms. Majalamba. We cannot hear you. I cannot hear you. will continue. This constitutes a meeting of the Committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons at the bar at the bottom of the screens, which has an option that allows the member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjection. Now, members, yesterday I noted, and it seems to be continuously so, that some do not switch on your videos when you are expected when you speak. And I don't think that it is correct that you dishonor the platform like that. So I'm going to ask that you do switch on your videos when you speak in this meeting. With that having been said, we will go straight to the OHSC. We're going to receive, I must just give an indication of the times quickly. So 9:35 to 10:30 is the OHSC. Then we'll have discussions to 12 o'clock, and then a briefing by the Health Ombuds on the annual report at 12 to 12:30, discussion for an hour, and then we will have lunch at 13:30 to 1400 hours, and then briefing by the Medical Research Council at 1400 hours to 1500 hours, discussion to 16:30. Then the NHLS on the annual report until from 16:30 to 17:30. And we'll then have discussions of clarity-seeking questions. So with that having said, I'm going to welcome Dr. Simpiwe Mdaweni. And I've not looked at the participants here, to Mr. Julius Mapata. Whoever is going to be doing the introductions, I would think that would be Dr. Mdaweni of the entire team. And then also to continue with the presentation. You're very welcome. Thank you.
Thank you very much, Honorable Chairperson of the Health Portfolio Committee, Dr. Jacobs. At this stage, I would like to first invite the Chairperson of the OHSC Board, Dr. Kinoshi, to do the introductory remarks, and thereafter I will continue with the presentation. Thank you.
Good morning, Honorable Chairperson Dr. Jacobs, and good morning, honorable members of the Health Portfolio Committee. I'm Dr. Ernest Kinoshi, the Chairperson of the board, and we are glad to have been invited by the Portfolio Committee for this briefing on the annual performance report of the OHSC for the year 2022-2023. There are some members of the board who are in attendance, Chair, and we've got with us Ms. Mtunu, we've got Mr. Yawa, Anele Yawa, we've got Mr. Rajesh Mahabir, we've got Professor Lillian Dudley, we've got Professor Morgan Chetty. We also have in the meeting Dr. Gwyn Lawrence. I don't have a confirmation yet of the others who may join us, Chair, but the whole board has been invited to this meeting. We are also joined, as you have heard from the CEO of the OHSC, Dr. Simpiwe Mdaweni, who has got a team of executive managers also in the meeting today. Chair, we are going to let Dr. Mdaweni lead with the presentation, and there will be slides that have been shared already with members of the portfolio committee, honorable members. These slides will be spoken to by the CEO, and we will all participate in responses to questions that members of the portfolio committee may raise hereafter. Thank you, Chair. We will allow Dr. Mdaweni to go ahead when you so allow. Thanks, Chair.
Thank you very much, Dr. Kinoshi. We appreciate you bringing a big team, so we're able to listen to all of you. And so I'll hand straight over to Dr. Mdaweni. Thank you.
Thank you very much to the chairperson of the OHSC board, Dr. Kinoshi. Once again, I extend greetings to the chairperson of the head portfolio committee, Dr. Jacobs, all the honorable members of the portfolio committee, the OHSC board, the executive and the senior management team in the Office of Health Standard Compliance. We bring today to the health portfolio committee the presentation of our performance over 2022-2023. This is the outline that we will follow as we share the information. It is the outline that is in our annual report as submitted. The fiscal year 2022-23 was significant for the Office of Health Standard Compliance as we entered the half mark of the OHSC 2020-2025 strategic plan. The OHSC as a regulator continued to strengthen the activities towards the achievement of what we have set out as our strategic direction in the strategic plan. We are pleased to report to the honorable members that for the fiscal year, our performance was at 65%, which means that we achieved 15 targets out of the 23 planned targets. We fell short with 6 targets, and there are only 2 targets that we were able to partially achieve. We will start by going through some of the strategic overview of the Office of Health Standard Compliance. It is our goal as an entity that all users of our health services should consistently receive safe and quality health care, and that is captured in our vision. And the purpose of the existence of the OHSC is to monitor the safety and quality standards in health establishments, and we do so independently, impartially, and fearlessly on behalf of all the users of the services. We are governed by a number of values which we subscribe to. First and foremost, as a regulator, is to respect the human beings as individuals, those that visit our health establishment. Accountability is key in the work that we do. We take full responsibility for our results and the outcomes of the work that we do. We do so in a transparent way, and we will always create openness between the managers and employees that we interact with. Safety is quite key in the workplace, not only for the users, but also for the healthcare workers. We also subscribe to integrity in that we conduct ourselves with openness, honesty, and respect as we interact with all stakeholders. As members would be aware that the office was established by the amendment of the National Health Act of 2003 in 2013, and this would then establish us as an independent entity to promote and protect the health and safety of the users of our health services. We are governed in our operations by the norms and standards regulations that were promulgated by the Minister of Health in 2018. We also have the procedural regulations that guide the functions of the Office of Health Standard Compliance, as well as the Health Ombuds. Our main objectives and functions, as stipulated in Section 78 of the National Health Act, is to protect and promote their health and safety. We do so by monitoring compliance with the norms and standards. And in instances where there is non-compliance, we then have the powers to enforce compliance through other measures. Members would also be aware that the Health Ombuds is located within the Office of Health Standard Compliance, although independent in his functions. We also then receive all the complaints that are related to the breaches in the norms and standards, which are considered, investigated, and disposed of. And we hope we actually strive to do this in a procedurally fair and expeditious manner. The mandate of the office as it stands, and the OHSC would then say, we have or we are working towards achieving our overall mandate if at some point in our healthcare system, we start to see overall reduction in avoidable mortality and morbidity and harm through receipt of reliable and safe health services by all. We also would want to say we have achieved our mandate when there is improvement in the availability, responsiveness as well as acceptability of health services by the users, so that we can be able to improve patient experience in all those that visit our health establishments. We are governed by a number of policy and legislative mandates, which I'm not going to go through. Key to this is the National Health Insurance Bill, which was passed by the National Assembly in June of this year. These are some of the policy mandates that create an enabling environment for the health reforms and also our work within the health landscape in our country. Our mandate will then imply that as a regulator, we are the champion of the public with regards to restoring credibility and trust. And we want to also push for effectiveness in achieving change in the health system as well as social impacts. We strive for excellence and innovation in some of our operations. And also we want to be truthful, fair, and committed to intellectual honesty as we regulate the healthcare sector. Transparency, respect, and confidentiality in all the information that we come across is key to our operations. Would like to achieve the highest standards of ethical behavior, teamwork and collaboration, and professionalism, compassion, and recognition of diversity and social responsibility would also be the implication of our mandate. The strategic plan of 2020-2025 has 5 outcomes that are aligned to the medium-term strategic framework goals. The first outcome is a fully functional Office of Health Standard Compliance. And in all of these outcomes, we have output indicators that we monitor over the periods. The second outcome is to ascertain that there is compliance with norms and standards, and this compliance is effectively monitored. The third outcome is to ascertain that we facilitate the achievement of these norms and standards regulations in the health establishment by guiding all the entire healthcare sector in how to achieve these norms and standards compliance. The fourth outcome would be the certification of those health establishments that are found to be compliant with the norms and standards. And the fifth one is overall improvement in the quality of healthcare services, which will then allow us as a country to improve our health outcomes. Going to our performance for 2022-2023, we are, as we implement our work, fulfilling the mandate through the 5 programs. The first one, Program 1, Administration, provides leadership and administrative support to the specialized programs, which is Program 2, the Compliance Inspectorate, the biggest program in OHSC that houses the inspectors. We have the third program, Complaints Management and Office of the Health Ombuds. This is where the Health Ombud is located, and mainly oversight is provided by the Health Ombuds. We have Program 4, which is Health Standards Design, Analysis, and Support. And we have Program 5, Certification and Enforcement. As I go through the output indicators, I will go into detail in all these programs. We had a budget of 192 million. Our performance is at 65%, the non-achievement at 26%, and partial achievement at 9%. The overall staff complement for the Office of Health Standard Compliance at the end of the financial year was 123 out of 129 funded posts, with a vacancy rate of 4.6. This slide would show a comparison of how we fared in 2021-22 comparing with 2022-23. And we also show all the indicators per program and the achievement as well as non-achievement. For the fiscal year 2022-23, we were tracking and monitoring 23 targets as in our APP. We achieved the 15. Of the 15, 9 were targets that are within core activities of the OHSC, and 6 were within the support services of the OHSC. When you look at 2021-22, we were tracking 21. We're almost at the same performance rate of 67. And in core programs, we achieved 8 of the 14, and we achieved 6 out of 14 in support services. These slides once again show achievement of the targets that we were monitoring over the entire year per program. And as members would see, the column on the percentage of achievement in the main would indicate how each of the programs has fared. I must indicate, even before we get to the program, that our challenge was in Program 3, which we will then explain what we experienced and what are the mitigating factors that we have put in place as an entity to improve performance. The next couple of slides will go into detail in all of the output indicators per program. The squares, the outer square, the far left, would indicate the 5-year target, which is what we have put in our strategic plan of 2020 to 2025. The outermost far right would then be our performance to date as compared to the targets in the strategic plan. Then in the middle, we'll look at our performance over the years with the focus in the reporting period of 2022-2023. One of the output indicators we monitored was the percentage of vacancies that were filled within 4 months. This is to ascertain that there isn't much time that is spent with positions that are not filled. For 2022-23, we had a target of 90%. That was 9 vacancies. There were 14 vacancies, and 9 of those were filled within 4 months. The reasons were varied in that some of the candidates did not accept the post. We had to re-advertise in some instances, and also there was an issue in one of the positions which ended up as a labor matter. Overall, compared to what we have set out to achieve over the 5-year period of 95%, we are at 64%. We still have time to can make up for this output indicator. The next target in human resources, the percentage vacancy rate per year. We are pleased that we had set a target of at least we should have a 7% vacancy rate or less. We're able to achieve 4.6%, which meant that our out of the 129 posts, only 6 were vacant. Now, this would mean that it would assist, or it assisted us as an entity to ascertain that our operations are actually continuing without any disturbances. The next target would be the number of inspectors that are trained and they complete a training program. We are required by the Act that all the inspectors that are in the employ of OHSC are trained. We have a vigorous program of 45 days of training for the inspectors. During the reporting period, we appointed one inspector. Because this is quite a lengthy and involved training program, the inspector was orientated towards the work of the office, and we waited to have an adequate number of inspectors to train. However, at the end of the financial year, out of the 39 inspectors that are in the employ of OHSC, 38 were trained, and only this one was orientated and would have undergone training in the next fiscal year. The next two targets relate to the ICT, that is information communication availability. We as the OHSC, it's quite important because most of our work is actually automated, the work that is done by the inspectors in facilities. We then monitor the uptime and availability of IT services for the core implementing programs as well as for the support services. We're pleased to announce that we're able to maintain a high performance rate of 99% for the core services and similarly for the support services. This was possible because of constant monitoring and oversight and also scheduling regular maintenance programs for our IT services. The next sub-program in Program 1, Communication and Stakeholder Relations. This program is quite important in assisting the healthcare sector to understand the OHSC mandate as well as the Health Ombuds mandate. And it's also important for us to forge effective stakeholder engagement and profiling of the OHSC and the Health Ombud work. We then had a number of community stakeholder engagements that were meant to raise public awareness on the roles and powers of the OHSC and the Health Ombud. Our target for the year were 12 of such community engagements. We're able to achieve 34. We are well on track in achieving our 5-year targets. And although we had a target of 12, we always responded to the need as we determined in our day-to-day work. We embarked on a number of community radio campaigns where we're profiling the OHSC and the Health Ombuds. We conducted roadshows in rural and local communities. We partnered with some of the regulators in defining and making the communities aware of our work. It is also important to indicate to members that the OHSC board embarked on national roadshows, which were actually led by the board, and the board met with all senior managers, the management teams in all 9 provinces, as well as the senior management teams in the private sector. This would be a depiction of some of the work that we do when we engage communities in the various places. The next target, same as in the public sector, we were monitoring the engagement that we hold with the private sector. We had a target of 8 for the annual, for the reporting period, and we're able to achieve 17. Once again, with this target, we will be able to achieve our overall 5-year target. We conducted a number of advertorials in digital and print medical publications. We also shared a digital external newsletter bulletin, which targeted health establishment as well as the medical professionals. We had quite a number of media engagements. Some would include the media engagements of the Health Ombuds, as well as participation in conferences. And this would be a depiction of some of the national roadshows which were led by the board, and this was with the private sector. Now, the importance of these roadshows was also to receive feedback from various stakeholders with regards to our interactions with them, and also to find out how our work is received by the various stakeholders. This will be our participation in the conferences. As a regulator, it's important that we demonstrate accountability, good governance, and transparency in our financial resources, as well as our program implementation. We are pleased to announce to the honorable members that for the 7th year in succession, the Office of Health Standard Compliance has received an unqualified audit opinion from the external audit by the AG. The next program is Compliance Inspectorate, which is the biggest program in the organization. We tracked a few output indicators. It is important for us to know our output with regards to the inspections that we conduct, both in the public and the private sector. For 2022-23, we had a target of 788 inspections, which we wanted to conduct. We were able to conduct 781. We fell short with 7 inspections. The circumstances were beyond our control. At some point in January of in KwaZulu-Natal, the teams were unable to conduct inspections. And in fact, some of the inspectors were held hostage because of some unrest which they experienced. And there are at times some natural occurrences that we cannot prevent, such as the flooding in Zululand district, which resulted in an inspection being aborted. And in Gauteng, during the March month, there were some unrest which resulted in inspectors not being able to conduct these inspections. Overall, at this stage, we are standing at 1,712 inspections conducted out of 3,741 that appear in our strategic plan document. I must hasten to mention that the 3741 would not be the overall denominator of the health establishments in the country, but it is a target that we had put over a 5-year period. We are well aware of the fact that as an entity, there's much, much more we need to do in terms of increasing the inspection coverage, both in the public and in the private sector. However, in doing so, we would need a serious fund injection in terms of increasing our inspection coverage. This is a breakdown of the inspections conducted in the public sector per province. How we decide on the number of inspections is based on the health facilities in a province, and we then share this as part of our inspection strategy, which is published at the beginning of each financial year. In the past years, when we came to the Head Portfolio Committee, we always reported that we were busy interacting and engaging with the private sector in relation to the development of appropriate tools to inspect the private sector. We are very pleased as an entity that for the first time, we report to the Health Portfolio Committee that the OHSC has started inspections in the private sector in 2022-2023. We had put a target of 52 of these inspections in the private sector. We were able to conduct 51. We fell short with 1 because one private institution, Sunshine Hospital in Ekurhuleni Metro, an inspection was cancelled. The office received late notification that the hospital was closing, and we did not have sufficient time to redirect the inspection to another private hospital. Overall, we have 431 private institutions in our database. I must indicate that this would exclude the private practitioners' rooms. This would only relate to the hospital groups, and this is a target that continues to increase. And for the next financial year, we will report even a bigger target as well as denominator for the private sector. This just shows some of the hospital groups that we inspected that gave us the 51 inspections. And these hospital groups would include clinics, Life Healthcare, Mediclinic, National Hospital Network, as well as Netcare. It's important that I highlight that we have been received very well by the private sector as we conduct these inspections. We are at a stage that the entire healthcare sector is understanding that there is a healthcare regulator that would inspect and monitor compliance with the norms and standards. One of the activities we undertake, once an inspection is conducted, the outcomes would be either we issue a compliance certificate to a health establishment that is found to be compliant with the norms and standards, or we issue a notice of compliance that would detail what the recommendations in terms of what are the breaches in the norms and standards, and for that health establishment to remedy. Those health establishments where we do not issue a compliance certificate are scheduled for a re-inspection. In this output indicator, we then monitor the re-inspections that we conduct in the public and private sector. So these would be institutions that were previously inspected through a routine inspections. Now, our target for 2022-23 was that we wanted to re-inspect all those health establishments that required re-inspection. Out of that, we were able to conduct all 106 re-inspections. Although we report a performance to date of 287, it's important to indicate that we do have quite a huge number of re-inspections that the office needs to conduct. We're also in the process of refining some of our activities to see how best do we conduct these re-inspections so that not all would then be a full re-inspection. However, that remains to be work in progress. We then also show all the provinces in terms of numbers where we conducted the re-inspections. Once we have conducted these inspections, we are then supposed to compile a consolidated report, which we then share, which will then show the trends in the work, in the quality assurance activities in our health establishment. For the reporting period, we were unable to produce this report at the required time because of a number of reasons. One is that we subject these reports, the individual inspection findings reports, to a vigorous quality assurance process internally. We had the last step of an external panel review, which would then look at these reports and ascertain that all the findings that are there would be appropriate and are in line with what the inspection found. We have since re-looked at our processes and have moved some of these re-inspections and some of these review panels to be internal so that we can be able to produce these reports on time. One of the delays is as a result of the information that we wait to receive from the health establishments. Our processes are such that once we have issued a preliminary inspection report to a health establishment, we give them a period of 20 days to interact with the report, and they are allowed to submit some evidence which we then subject to an internal review process. And what we have experienced is that there were delays also in the submission of this information. But as indicated, as an office, we are looking at alternative review mechanism processes to ascertain that we receive these reports on time and that we also release them on time. We are also required to publish information on all the inspections that we have conducted. To that end, we produce two reports biannually. These reports we put in our website, and in these reports, we indicate all the names of the health establishments that have been inspected, their location, and also the names of the provinces and the district, we were able to produce these reports so that the healthcare sector can be able to see which health establishments were inspected by the Office of Health Standard Compliance. We then moved to program 3. This is the program that houses the Health Ombud, Complaints Management, and Office of the Ombuds. The output indicator here, we monitor the percentage of low-risk complaints which are resolved within 25 working days from the lodgement with the call center. For 2022-23, the target was that 80% of these low-risk complaints should be resolved within 25 working days. The program has done very well. The performance is at 93%. Out of the 2,647 low-risk complaints received, 2,476 were resolved within 25 working days. The next indicator will be the percentage of those complaints that are resolved through assessment within 30 working days of receipt of responses from complainants and the health establishment. This indicator, once a complaint is received, there would be additional information required from a health establishment or even from the complainant. Now, within 30 working days, these complaints should be resolved. The performance is at 61%, which is satisfactory out of the target of 65%. One of the challenges experienced by the program here is that health establishments and complainants are given 7 days to respond to the program in relation to the information that is requested. So often there are delays and this information is received beyond the 7th day, which then falls outside of the indicator and the time frame. The next 3 indicators, this is where the program struggled with achieving targets. For 2022-23, for the percentage of complaints that are resolved within a 6-month through investigation. So these would be complaints that are then referred for further investigation. These tend to be complex in nature. They tend to involve more than one health establishment, several service providers, and information must be sought from all various stakeholders. It is also important to highlight that there is a historical backlog of cases. One, in that program 3 was the last program to actually be staffed in the Office of Health Standard Compliance. So when the office started, we did not have staff in complaints and investigations. So, however, during that period, there were cases which were received. Now, although we show that only one investigation was completed within 6 months, there are other investigations that were completed, however, do not fall within the reporting period because they form part of the backlog. One of the serious challenges that was also experienced by the program, as I've indicated, is the shortage of staff in terms of the investigators. The next indicator, same as the previous one, these are complaints that are resolved within a 12-month period, and the program was able to resolve 5 of these complaints. The next one are complaints resolved within 18 months, and only 1 was resolved. The OHSC board reviewed and discussed the performance of program 3 in as far as supporting the health ombud and the team. And I must report that when we come back to the health portfolio committee, we will present a different picture. The board then assisted the health ombud with 5 investigators, and this on a 12-month fixed term contract. And we have seen drastic improvements since the appointment of these investigators. The team also looked at other internal processes in order to achieve efficiencies, such as the revision of protocols and also building capacity within the investigators. So we are, as I've indicated, that as much as the performance looks as though it's bad, there's been quite significant improvement, which will be reported in due course. Here we show where we received the provinces, where complaints were received. In order to interpret this slide, there are a lot of factors that are involved. That Gauteng submit a lot of complaints. It could be the proximity to the OHSC. It could also be the live acid Dimeni case that really brought the profile of the work of the Health Ombuds to the general public. However, more, I think, research needs to be looked into so that we can see what are the reasons with other provinces not submitting the complaints. The next program, that is Program 4, Health Standards Design, Analysis and Support. This is a crucial program for the OHSC that developed the standards and the tools. And this is where there's triangulation of data from various OHSC sources, such as inspection findings, annual returns, early warning systems, so that we can be able to analyze this information, advise the healthcare sector on quality assurance, as well as advise the Minister of Health, and also make recommendations on improvement on quality management systems. For 2022-23, we had a target of 3 reports. I must indicate that it says 3 reports, but to produce one of these reports, this information must be tracked and analyzed over a long period of time, often for the entire year. This information is collected, then analyzed. We were able to produce a report shared with the Limpopo province. The report analyzed the compliance status of the province, and we triangulated information from the media alerts, from the annual returns submitted by the province and the early warning system. Gaps were identified, which could potentially impact on the provincial health system, and recommendations were made on aspects to be addressed to improve performance in Limpopo. We also had a report a national report, and 9 provincial reports on the early warning system. This report outlined the trends in the breaches of the norms and standards related to patient safety and overall health system weaknesses, and we provided recommendations to address these weaknesses. We also had produced 1 national report on annual returns and 9 provincial reports. These reports provide contextual information on the profile of health establishment. So the OHSC collects information which include finances, human resources, and infrastructure. This information is all analyzed, and this information has a direct bearing on the ability of health establishment to provide appropriate and safe quality care, and all these were shared with the provinces and the National Department of Health. It is important that we guide and facilitate the understanding of the norms and standards and the implementation thereof with all our stakeholders. The program conducted guidance workshops, both in the public and private sector, that assisted to implement the norms and standards. For 2022-23, we had a target of 24, and we're able to achieve the target and slightly surpass it. And once again, we are on track in achieving the overall target as set in our 5-year strategic plan. This program, the next program, Program 5, Certification and Enforcement. The program receives recommendations from inspectors to certify health establishment. Once again, this information is further processed and those health establishments that need to be issued with compliance certificates are issued with those within a period of 15 days. We had a planned annual target of 100% because all those health establishments that should receive compliance certificate, the office should ensure or ascertain that they are actually sent to them. And we were able to issue 251 compliance certificates within a period of 15 days. Of the 251, 173 of the compliance certificates were from our routine inspections and 73 were from re-inspections. We also then show the compliance certificates, the 251, and the provincial breakdown of the compliance certificates issued. Indeed, it is always encouraging for health establishments when they receive the compliance certificates, and this motivates other health establishments within provinces once they see that there are others that are complying with the OHSC norms and standards, and various provinces always do take these as a tool to encourage some health establishments as well as the entire province to improve in the provision of quality and safety in health services. In the event there is non-compliance with the norms and standards, which is persistent, we first give an opportunity to health establishments to improve by issuing them a notice of compliance, which will then inform the health establishment the breaches in the norms and standards. Once a reinspection is conducted and we find that the health establishment is still non-compliant, we then have the powers to revoke enforcement action. Now, once we initiate enforcement action, we need to do this within 10 days from the date of issuing a final inspection report. Again, we have a target of 100% because where there is a need to enforce compliance, the office should be able to do so. And during the reporting period, we issued 100 written warnings to health establishments. It's important to indicate that we do receive good response once we start to enforce. However, we want to get to a point where health establishments do the right thing without the OHSC having to take enforcement action. But we have seen quite an encouraging interactions between ourselves and those health establishments where we have issued written warnings. The next output indicator, the number of health establishment compliance status report is published. So we have twice a year, we must publish reports in our website where we indicate all the health establishments that have received compliance certificates and also all health establishments where we have taken enforcement action, and we were able to do so over the reporting period and reach the target. Now, coming to human resource management, as indicated previously, we have 129 funded posts. By the end of the reporting period, 123 posts were filled with 6 vacant. And in terms of the breakdown of the employees by age, the majority are between the ages of 36 to 54. And the gender, we have 64% female as well as 36 male. We still have to do a lot more in terms of persons living with a disability. 50% of our employees are women in senior management positions. And also we have 9.7% of youth employees. I want to indicate to the portfolio committee that although we have 129 funded posts, these posts fall far short of what we need as an office to achieve our mandate. There is a revised structure which has in excess of 300 posts. Most of the posts in the revised structure are not funded. We are aware that we need to expand our inspection coverage. One of the critical inputs would be the decentralization model approach in terms of the work that we do. Currently, as the office, we have all our inspectors located in a central office. They then move to provinces from the central office. Working with the board, we have a decentralized model approach that would then expand the work of the office to be located in the provinces. However, for the office to be able to do so, we do require the funds. And also importantly, we must increase the inspectors in terms of numbers as well as the investigators. Now, this is important for the committee to be aware of, that until there is a change in terms of our staff complement and our service platform delivery model, we are going to be hamstrung in terms of increasing our coverage, which would adversely affect our mandate. I will, in the later slides, discuss some of the activities that the board has embarked on in terms of improving this. However, this is an area of concern to the Office of Health Standard Compliance. I'm going to request my colleague, Mr. Mapata, our Chief Financial Officer, to go through the couple of slides, and I will come to do the last few slides.
Thank you, CEO, and good morning to Honorable Chair, Dr. Jacobs, and all the honorable members of the Portfolio Committee, board members, and colleagues in management. I will take the committee through a few slides in terms of the finances as contained in the annual report. We may go to the next slide. On this slide, we will see that in terms of total revenue, the OHSC's position did not change significantly from 2021-22 to 2022-23. The total revenue was 160 million, whereas expenditure increased from 149 million to 187 million. And the deficit there was funded largely from the surplus from the prior years as approved by the National Treasury. And the reasons will be indicated in the next slide. The CEO has already indicated in terms of audit outcomes, the OHSC once again achieved a clean audit. And the main source of our funding is National Treasury. And with the easing of lockdown restrictions, we have seen an increase in traveling, which also led to an increase in traveling costs because in the previous 2 years, prior to 2022-23, there were those COVID restrictions, which hampered a lot of our activities in terms of inspections. Next slide, please. And we had the surplus, which currently has been approved by the National Treasury, largely originated from commitments on short-term employment contracts, which overlapped into the 2023-24. We are currently using that, as well as additional revenue of just over 3 million that we generated from interest. Next slide. Here we are trying to show the impact of COVID in terms of the OHSC spending. In 2019-20, before the outbreak of the COVID, our total expenditure was 158 million. And in subsequent 2 years, 2020-21 and 2021-22, we saw a decrease respectively of 135 million and also 152. Now, in the previous financial year, the one we are presenting now, expenditure increased quite significantly to 192 million, and also because there were more facilities that were inspected compared to the prior years. Thank you. Next slide. And here we're just showing the impact of COVID in terms of travel. Just prior to the outbreak of COVID in 2019-20, we're sitting at 11 million in terms of traveling. And with the easing of lockdown restrictions in 22-23, that increased by 10 million to 21 million rand. Next slide. And the surplus plan, I've already alluded to that we have got short-term employment contracts in the programs that have been highlighted here, as well as the cost of living adjustments as approved by the DPSA. So the OHSC uses the same salary scales as those communicated and published by the DPSA, and also wanted to cover additional travel for inspections and investigations. The CEO has already indicated that we have got additional investigators, so that will also be covered by the surplus plan that we have in terms of their traveling. Next slide. In this slide is just a breakdown of the expenditure per division. The inspectorate at 53%, just over half of the entire expenditure was in terms of the inspectorate. Next slide. And this slide shows that 40% of our expenditure was in support functions, whereas 60% was in core functions. Next slide. In terms of compensation costs, 62% of total compensation was in terms of levels 10 and 11, then that's where the majority of the inspectors are. So there is a strong bias towards the employees in the core functions of the OHSC. Next slide, please. In terms of distribution, staff complement, we're at 28% in support functions and 72% in core functions. Next slide. Thank you, CEO. I'll pause there. Thank you.
Thank you very much, Mr. Mapata. Looking at our challenges as the OHSC, given the scope of our mandate, particularly in relation to the National Health Insurance, which then says all the health establishments that are going to participate in the NHI fund prior to being accredited need to be certified by the Office of Health Standard Compliance. So the current funding is not sufficient to enable us to achieve those plans. Also, the current operational model, which is centralized, will not enable us to achieve this. There's pressure on the OHSC to increase both inspections and also the certification of health establishment. We're quite concerned that the compliance rate overall is very low. And we can only certify more if we inspect more. But there is also another input in terms of asserting that the findings of the Office of Health Standard Compliance are acted on not only by the health establishment that we inspect, but also by the district and the provinces. And to that end, we do share our findings with the provinces and the districts. One other challenge we are facing is that as an office, most of the work that we do is very specialized. So it does take a long time for us to get the requisite technical skills, particularly in the program of health standards development, which is a science on its own. We're very worried also with the runaway legal costs on litigation of inspections, as well as the health ombuds reports. Any of our work can be subjected to litigation. There are also other challenges that are more around the facilities themselves in terms of their response to our interactions, as well as the health ombud on the information that is required, and also to sustain the improvements where they have been realized. The board has deliberated at length with some of these challenges, and there is quite a lot of work that is currently being done. As much as we are saying to the Health Portfolio Committee, there is a need for funding injection to increase our staff complement in various programs, as well as to implement the centralized model of operations. The OHSC has developed an OHSC business case And this business case is a framework that looks at various scenarios, the organizational design, and also the accompanying human resources, and also the forecast of what we need in the next couple of years. The OHSC board is very eager to finalize a revenue generation model, working with the management team. The board is spending considerable amount of time in providing strategic guidance to the management team on the revenue generation model. It is our hope that in the nearest future, we will be able to have this implemented so that this can supplement our funding at the moment. However, we do realize that in the nearest future, we do or would require more funds in order to be able to undertake our work and to expand. Our information technology infrastructure is still at its nascent phase. There's a lot that we still need to do, and we are working on the analytical business intelligence capability, which needs to be aligned to the needs of the organization in future, as well as the national health insurance. The OHSC currently, as we conclude, is in a process of reviewing its operational model with a clear intent to address formidable strategic challenges facing the OHSC in order to realize efficiencies in operations and to progress in fulfilling our mandate. We have embarked to that end on a process of reconfiguration of the structure and functions to streamline our services and also the interdependence amongst the programs so that we can be even more ready in preparation of the national health insurance, but most importantly, beyond the national health insurance, as our mandate is beyond what we are required to do or what would be prescribed by the National Health Insurance Bill. The operational processes that are currently being reviewed will assist us to improve our effectiveness and efficiencies in taking into consideration the needs of the current health system, as well as the future needs of the organization. And in that, I would like to thank all the members, and that would be our offering on the 2022-23 annual report. Thank you, Chair.
Thank you very much, Dr. Kanoshi, Dr. Daweni, Mr. Mapa, and your entire team for this presentation. It is quite a good presentation, quite a long presentation. I'm sure the members would like to interact with it and raise some points of clarity or any questions. I would also raise a few points, but more towards the end. So I'm going to give the members an opportunity first, the other members. I already see the hand of Honorable Clark. I just need to go to participants. Right, so Honorable Clark, Van Staden, Eklund, Chirwa, Gela, Kaba, Harvard, Morowane, no, Slengwa first, Slengwa, Morowane, Harvard, and then myself. I'm going to repeat that order, members. It's Clark, Van Staden, Eklund, Chirwa, Gela, Kaba, Slengwa, Morowane, and Harvard, in that order. Thank you.
Thank you, Chairperson. Good morning to everybody, and thank you very much for the presentation. And, also to the OHS for always giving us a really good presentation and being very honest with us in terms of their staff shortages around what they need to achieve. The following questions. What are the reasons for the high numbers of complaints in Gauteng? Can you indicate which facilities they receive the most complaints, and can you indicate the type of complaints that are most prevalent? Regarding the Rahima Musa and Tembisa, has the Ombudsman been back to check on the implementation of the recommendations? How many staff are needed and in what capacity? Please indicate the problems with the current office space and what steps have been done to address this. What 6 targets did you fail to meet, and what are you putting in place to mitigate that? I note that you have 39 inspections, but would this be enough to do what your mandate is in terms of ensuring that all our public hospitals comply to the ideal clinics? And how will you address the long outstanding cases? As I've asked, what length of time would it take to address these investigations of I think there were 136 of them that's been outstanding, I think, since for quite some time, and what is the time frame for that? And would you be ready for all our facilities to be compliant in line with what the NHI bill requires? Thank you.
Thank you, Honourable Chairperson. Good morning to all the members and to all our visitors from the OHSC office. Thank you for your presentation and in the good manner that you are bringing it to us every year. It's really a pleasure to receive your report every year. I just have a few questions. Most of my questions were answered during the presentation. I just want to know that if it's possible to provide this committee with a list of those facilities that was inspected in the private as well as in the public sector. I just want to make sure to get clarity. Do you have now 38 or 39 inspectors in total? And then my third question is, what is the number of inspectors needed to carry out inspections at all health facilities across South Africa? So what will be the ideal total of inspectors be at the end of the day? I can see that the budget of this office is not adequate to perform its duties and to run this office efficiently. So in your view, what would you say would be an efficient budget allocated to your office? And I see that you have only 123 staff, 6 still vacant posts, and I just want to know what is the number of staff also needed to let this office perform efficiently. I hope it makes sense, and if you don't understand, I can redress it again. Thank you, Chairperson.
Thank you so much, Chair, and thank you for the presentation. Leading on directly from Honourable van Staden, the number of staff that are staff vacancies or posts that are vacant, to what extent is this hampering your operations? I noticed that in Programme 2, the compliance, the number or the percentage of public healthcare facilities that are being inspected has declined from 21% in 2023-24 to 18% over the MTF. This is very, very concerning, particularly if one is considering the implementation of the National Health Insurance. And I think that that is the biggest area of concern that I have. A second area of concern is the cost implications of labour unrest. Has this been implemented? Has it been evaluated in terms of your budgetary requirements? And what measures are in place to deal with unrest in the long term? The next question that I have looks at overspending on program 1 to date. What is the reason for this, and how are you going to remedy this? To what extent has violence and unrest affected your inspections, and what can you do to remedy that? How have you been able to address this, and what measures do you have in place to address it in the future? And then the others have been covered by Honourable Clark and Honourable van Staden. I will leave it there. Thank you so much, Chair, and thank you to the OHSC. Thank you so much for your presentation.
Thank you very much, Chairperson. My questions have been partly covered. There's just one question that I have for the OHSC, and it's in relation to litigation cases that relate to obstetric violence, infant mortality in hospitals. I think the Ministry of Health and Housing raised something that really is concerning. I think we should look at it in much more detail than we currently are. Where she notes that 700 newborns died in Gauteng, I think in the past year, 788. I'm certain of the precise numbers, but it's 700 plus. And noting that the causes of such things, you know, is hypoxia and different other things, right? Now, we know that C-sections are carried more out in private facilities as compared to the public healthcare sector. And now I don't know the science of how much this is particularly needed, but my assumption is that there is a very close link, especially because I've had a similar experience in relation to hypoxia when I gave birth in a public hospital in 2016, and my son suffered hypoxia. And that was also because there wasn't enough equipment in the facility to process numerous C-sections at a go. So people are on a waiting list for C-sections and then end up giving birth by force or, you know, in a negligent manner, not because the nurses or the staff are negligent, but because there isn't enough capacity to facilitate C-sections. And these repercussions, I think at this point is just, it's a human rights issue at this point. The fact that children are growing up with permanent disabilities because public healthcare facilities can't carry out C-sections in a number or the ratio that is required in most public healthcare facilities. This is in Eastern Cape, it's in Gauteng, it's across all big hospitals that are supposed to be capacitated to do C-sections. And I want to know on a systemic level how the OHSC can intervene in this particular thing, because it's something that is not necessarily noted in the standards and whatever, because then you go and you research the standard of the facility, and it reaches the standard, but cannot carry out the requirements of what now the country today looks like and what is required during the birthing process. So I want to find out from the OHSC what kind of systemic changes, can we move forward? Because obviously we'll ask the minister to increase capacity and whatever, but on your side as well, like how do you make it a systemic thing to be able to look at such things as well and to also infiltrate them in how you intervene and look at these particular issues? Because sexual reproductive health rights is something that is most of the time is put on the side burners in public facilities, and which I think I also note that particular thing as a form of GBV. In actual fact, that there's so much obstetric violence in our healthcare facilities is something that can't go on forever, and we can't ignore the fact that so many children are growing up with permanent disabilities, cerebral palsy, neurological delays, and all those things that could have been avoided. People have good pregnancies, and then in the final moment when they're giving birth, then they have to suffer such things because the facility couldn't process the C-section in time. That is my particular question to the OHS. I think all the technical other things have been asked or are going to be asked. Because I also wanted to ask about. Actually, let me just ask it. Actually, now you do note the fact that you've got issues with resources, right, to accommodate increasing your workforce. Now on obviously creating, in our aspiration of creating independence in the entities of the NDOH, and looking at the fact that the NHI is coming into fruition, which is going to leave you at a furthermore setback in terms of how the department is able to cater for the needs of these particular entities. We have to look at how you as an entity are starting to think of ways to maximize your own resources to accommodate your aspirations. And I want to ask a question in that particular, like, what are the things or the alternatives you've considered in increasing your own or maximizing your own resources to accommodate your increasing your workforce capacity aspiration? Sorry for my camera being off, Chairperson. I am still in hospital now. I'm admitted now with my son as well. Thank you.
Thank you very much, Chairperson. Chair, I'm not going to switch on my camera due to network connection, Chairperson. Chair, let me first welcome the presentation from OHSC, Chairperson. I think in their introduction, they highlighted their target and also why they did not achieve the target, Chairperson, particularly in program of not achieving output indicators in program 1, Chairperson. But I think, Chairperson, what I like is that they also have plans, future plans on their challenges. The key issue, Chairperson, is the issue of funding. Maybe if we can engage, maybe they will tell us, Chairperson, in terms of the assistance that they want us to do as a committee to assist, because really it's frustrating the issue of financial constraints that they have, because they couldn't even fill some of the vacancies that they have, Chairperson. But my observation, Chair, is that the entity received an unqualified audit. The entity's performance is relatively concerning, with a target attainment of 65%, meaning 35% of the targets were not attained as planned. As I indicated, Chairperson, that a critical concern is that the performance is mainly in the complaint, which is program 1, and management, and the Office of the Ombuds program with 60% underachieved, Chairperson. Coming to my issue or the questions that I want to ask, Chair, I've got only one question for them, Chairperson, that what mechanism or balance is made when the entity undertakes a private healthcare routine inspections per hospital group, as most of the inspections were in Gauteng with 19 visits, while Northwest had only one visit, but Northern Cape had 3 visits. What is the contribution criteria for that, Chairperson? So I think, Chairperson, some of the issues I've raised in terms of the OHSC challenges, the insufficient funding that make them not to achieve their objectives as planned. But also what I like is that they have a future plan of addressing their challenges, which will monitor and make sure that at least we also intervene, because we are still going to have a meeting with the Department of Health. But also, I think, Chair, it's good that they also highlight the issue of NHI. But I want to say, Chair, with the challenges that they have, I think, Honorable Chirwa, I'm not responding to you, but just to say that they will achieve, actually. I don't think there will be more debt on their side, because NHI is trying to address imbalance health system in South Africa, which is going to assist all South Africans in terms of making sure that we get same services throughout, and also all of us, we get equal share, unlike now, as we know that the majority of budget, what is happening. So I think even you know that when you have medical aid at a certain time, you'll be told that your medical fund is exhausted, and some of the services you must pay out of pocket, you know. So I think NHI is going to address many challenges that we are facing as a country, and we are looking forward to make sure that it's been implemented in South Africa. Thank you very much, Chairperson.
Bakaba.
Thank you, Chair. Chair, I think Honorable Gela had really assisted us in her questions. But Chair, my question will relate to the following: that what is the view of the entity on the skilled reporting being concentrated in Gauteng, and is the entity optimally utilized by the public, noting that multiple challenges impacting the health system? I must also say, Chair, in welcoming their presentation, we may also recommend that they really develop a digital strategy which increases the reach of entity, and also have an equitable approach to visit in the provinces. Otherwise, Chair, their presentation is welcome, and I agree that the NHI is to resolve many of their bottlenecks that the Parliament currently is interrogating and aims to pass as into law. Thank you, Chair.
Thank you, Chairperson. Let me switch off my video because of the unstable network. Chairperson, first of all, let me welcome the presentation. It was such a long presentation, and interesting one, and informative one. Mine is a more or less question or clarity seeking question, because I have been covered partly by Honorable van Staden and Honorable Chirwa. And Gela too, but I have a concern of KZN, why KZN was not included. Because they have reasons of some shortage of money, but do visit the KZN. I'm not saying there are a lot of things in KZN, but in KZN we do need such visits so that all of us will be on foot. My question is on the Office of Health Ombuds office. early last year, or if it was not late 2021, there are complaints or cases were submitted hoping that it's going to be attended to, but not yet attended. If the Office of HSC or the Office of Ombuds needed to be resubmitted of those cases because it was in Gauteng, Endeavour Hospital, it was there. We need those cases were submitted to be attended to because it was a very touching cases and a very sensitive cases. If it is need to be resubmitted, I will be contacted and resubmit that case alone because it was a very touching case. Thank you.
Thank you very much, Honorable Chairperson. I've also realized that I've got a challenge with regard to network. Therefore, I will also switch off my video. I believe you accept that. Chairperson, I want to welcome the presentation that has been presented before the Portfolio Committee. And I have been covered by Honorable Gela and Honorable Taba in most of what they have also deliberated and asked about. I've got only one question, Chair, that I will want to pose. What is the extent of response and intervention on the early warning system reports? Because we expect the entity to be proactive, not to react, to be at an alert. So the question that I'm asking is what is the extent of the response and the intervention on the early warning system reports? And has the entity observed improvement on matters raised in the report they presented? Thank you so much. Thank you, Chair. I'm done.
Thank you very much, Honorable Harvard. Honorable Harvard. Honorable Clark and Slengwa, I would assume that those are your hands you have not lowered yet. If you may please do that.
No, Chair, I wanted to ask you something. That's why I raised my hand.
Honorable Harvard, are you there? Honorable Harvard is not there. Honorable Clark, I'm going to give this one chance. You should ask your questions beforehand, all of you. We need to follow up.
Thank you very much, Chair. I really appreciate it. I actually this morning, you can call me blonde. I asked my ombuds questions instead of my OHSC questions because I had them together on the screen on the side. So I have posted them in the group if you would just take note of them. Thank you, Chairperson.
Thank you. Yeah, I think you can just raise it now. I wouldn't be able to do that. I'm sitting on 3-4 gadgets. So you can just ask us.
Would you allow me to ask them again, Chair?
Yes, as long as not another Bible as yesterday. But
no, it's not the long Bible, Chair, that I can guarantee you. Okay, the following is just which posts still need to be filled and what is the impact of the vacancies? Of the facilities inspected, how many currently comply with the ideal clinics norms and standards? How many staff are needed to ensure that complaints are resolved within the prescribed time? Without the inclusion of the 135 cases dating back to 2017, what was the percentage of the complaints resolved within 6 months? And then when does the OHSC foresee its new business model being implemented? And will this address the problems of the centralized model? And if so, in what way? what does the OHSC recommend in terms of the lack of health establishments to provide evidence of having addressed areas of non-compliance after receiving preliminary reports following a routine inspection? I thank you, Chair, for allowing me to do that.
Thank you. So now more hands are going up. Honorable Slengwa, is that your previous hand? Can you lower it if it's not anything new? And Honorable Gela, there's a new hand. Honorable Slengwa, if you haven't lowered them, I guess you have.
Chairperson, I'm trying to lower it.
Okay. Honorable Gela?
Chair, Honorable Harvard is having a problem of network. So she sent me the question that she wanted to ask to the presenter. Okay. The question is that what mechanisms are required to expedite the complaints management process? That is the question from Honorable Harvard. Thank you, Chair.
Thank you. Thank you, honorable members, for interacting with the members of the OHSC. A number of things which have been raised, so I'm just going to mention a few. One is the concern with the target which you reached of 65%. We need to congratulate you on receiving another unqualified audit. Well done. We're always very happy to hear that. And of course, you have raised a couple of issues, and those issues we see in terms of the inspections and the re-inspections and the compliance by facilities. When you do issue them concerns which you have in order for you to then be able or be put into a position where you'll be able to certify, give them a good certificate of compliance. So those are really worrisome things, and you raised it yourself, because we are looking forward to the implementation of the National Health Insurance, and we understand that all facilities need to be certified. So additionally, you've also raised the question of insufficient funding. But I also remember that last year you had raised the same case of revenue generation models, and we're in the same position. And I'd like to know from you, what do those models look like? Can you give us a glimpse of those models? I think I asked exactly the same question last year. And the question following would be, of course, by when would you be able to then have those models or have it operational that you'll be able to generate funding? And what do you think is the manner in which you'll be able to generate such funding as the OHSC? And your main concerns on the certification challenge, coming back to it, is I'm asking you, what are the main contributors to your main concerns on causes for the low compliance by facilities or the managers of facilities, so that you sit in the position where you have to do repeat inspections, and you would, of course, know that those things are quite expensive. And then very concerning is the new one you've raised of litigation and the cost of litigation on inspections and also on the health ombud reports. So it's something that we need to highlight and take forward, and for you to put a costing with that. Additionally, I have a few more things to speak to. And that's on the one that was raised already by Honorable Kaba on the utilization of digital platforms. And if you at some stage will be able to give us an introduction to your digital platforms so that we see what your progress is. It's been raised by the AG. I have raised it many times. I'm raising it as the portfolio committee chair, that in this time of digitalization, we should get all of the department and all of the entities to move towards it, and should also ensure that we have one uniform platform for departments, for the sectors, and for the entities, and that this should not really be done in silos, And I'm going to really advocate, and I am advocating for that, so that we advance in terms of the technology that is available. And then lastly is the question of your monitoring and how you're actually doing that, and what do you think you could do to improve or to develop collaborations in terms of the monitoring for improvement of your functions and your mandate. I think before I allow you to answer any of those things, I have this morning neglected to welcome the members of the department who are present. And so I would like to welcome Dr. Pillay and who else is with Dr. Pillay on the group? I just need to make sure. And so my apology for not mentioning you, but you are being mentioned, Ms. Mashwana. You are being mentioned now, and thank you for your presence and listening to the presentations and also to the questions and concerns raised by the members and also the responses by the members of the OHSC. So I'm going to hand back to you, Dr. Kenoshi and Dr. Daweni and Mr. Mapata to raise these points. And also, I need to welcome Professor Chaule Mokoena, who will be presenting after this. We have not met yet. You have not met the portfolio committee yet, since you're a new appointment from 1st of June, but I'll give a bit of introduction of who you are when it is your turn to present to us after this answering session. Thank you. Over to you, Dr. Kenoshi.
Thank you very much, Chair, Dr. Jacobs, Honorable Chair. Actually, I'm glad you've welcomed the Health Ombuds. I had noticed him and communicated with him earlier during the meeting. He joined us earlier in the meeting, and I was going to alert you to the fact that he has been part of most of this meeting so far. And I welcome Professor Mokoena. Chair, we will share the questions as a team. I may take a bite at one or two and then hand over to either some of my board members, but also the CEO and the CFO and the executive as determined by the CEO who will answer which questions. There are quite a number of questions. I think I got most of them, but not all, I must say. Or some were said so fast that I hope that my colleagues have managed to get them. But just on the issue of Gauteng, quite a number of honorable members mentioned Gauteng, and Honorable Member Clark asked what is the reason for the high number of complaints from Gauteng and received from Gauteng, but also Honorable Member Keller asked why the inspections were mainly in Gauteng, but also I think Honorable Member Gaba said why was most activity concentrated in Gauteng. And I'm bringing this up, Chair, because that is the reason why the board and the executive management of OHSC have decided on the policy of and the project of decentralization of the office. The office, when it was established in 2015, was established in Tshwane, in Pretoria. And it has been in Pretoria only, its presence, that is, a physical presence since then. And I think this has an effect on the effectiveness of the office, but also on its efficiency, as in cost of traveling and accommodation of inspectors whenever they go to other provinces as well. But it also has an effect that members of the public can't reach OHSC because it's not everyone who is clear and has means of communicating. So the reasons for Gauteng is that, first of all, the office is situated in the province, but also some members of the public actually walk into the office as well to either lay complaints, ask questions, and so on. So that is the reason why there are so many complaints, such activity around Gauteng. But the one question about Gauteng, I think it was from I think it was I can't remember who. I think it was member Tlenga. Why? No, not Tlenga. Why there was it was why there were so many inspections of private health establishments from Gauteng. But I think that one is because of the number of private establishments. Gauteng has the highest concentration of private hospitals, followed by Western Cape and then KZN. And I think that is the reason why also, if you look at the private health care facilities, most of them were on that slide. Most of them were the Gauteng ones who were inspected during the 2022-2023 financial year, followed by KZN and Western Cape. I think it's also because of the number of this. But also there was a question about from member Shira about obstetrics, adverse events in obstetrics, and also the issue of hypoxia and its consequences, especially on the babies born out of the including litigations. The question was, how can the OHSC intervene? I think if we look at the inspection tools for all hospitals, private and public, there is a section that deals specifically with the maternity wards and the labor wards, and make sure that there are adequate equipment, but also staffing and facilities to ensure that mothers and babies are in a safe space as far as birthing is concerned, including emergency trolleys and other things that may be needed to avoid adverse events. But also the OHSC reacts whenever they are using the early warnings system, to which I think the CEO will respond more on. On the question of revenue management, including increasing the resources that OHSC has over and above what it gets as an allocation. I think that question was asked by Honorable Member Chiro, but also by the chair. For the Office of OHSC, or Office of Health Standards Compliance, to start charging fees for its services, just like the other government departments do. For your passports, for your IDs, for even the SIU charges government departments for doing investigations in those departments. But for traffic, driver's licenses and so on, the OHSC also needs to charge services charge for services it provides. But we need the approval of the Department of Health, and we also need the approval of Treasury. Processes have started in that direction to obtain the necessary approvals, and also the determination of the actual fees still has to be done. Our chair of ARF, Mr. Mahabiri, is in the meeting, and he is leading the committee that is dealing with that. working closely with the National Department of Health. Chair, if I may hand over to the CEO at this stage to assist with the leading the responses to the other questions asked by honorable members. Dr. Mdaweni.
Thank you very much, Chair. And thanks to the questions and the comments posed by the honorable members. I will be assisted by colleagues whom I'll call at the end of the ones that I will respond to. This honorable clerk asked about the 6 targets which we did not meet, and what mitigation measures do we have in place. The targets that we did not achieve were in the program Human Resources, where we're unable to fill the post within 4 months of the post being vacant. We are trying to advertise the post immediately after they are vacant. But one of the challenges around this is when we do not get suitable candidates. So that would be an external factor that we do not have a control over. However, we have seen improvement in the current financial year in terms of the posts that are filled within 4 months. The other program would be the 3 targets around the investigations which are not completed within the 6, 12, 18 months period in program 3. And we indicated that the OHSC supported the program with 5 additional investigators, and the picture currently looks different. Later on, Dr. Jacobs, my colleague, will discuss some of the measures they have in place with regards to dealing with the backlog cases. The other question by Honorable Clerk was whether will the OHSC be ready to certify health establishment as compliant for the NHI. The NHI bill passed in June mentioned that it would be in phases, and then the focus will be on primary health care. In fact, that aligns with what we are currently doing, because our approach as well was that we will start with the development of tools in primary health care. So in as far as the OHSC is concerned, we already have tools for primary health care. However, it would be a matter of maybe reviewing or refining the tools that we have if needs be, and informed by implementation. So when we ask whether we are ready, in as far as conducting the inspections, the apparatus we do have. However, as we have mentioned earlier, the issue would be our service delivery model, which needs to be decentralized, as the chairperson, Dr. Kinoshi, has said, and also increasing the inspectorate coverage so that we are able to conduct more inspections. Now, the certification of health establishment is dependent on a few factors. One, that the more we inspect, the more we'll certify. However, there's another critical input, that is the adherence to what we recommend in our inspection findings. So the quality improvement processes in the provinces need to be strengthened, so that when we have conducted inspections in a particular area in a province, the findings should not only be looked at as relating to that particular health establishment, but the province and the district need to act on our findings, so that even the other health establishments that are not inspected could then look into some of those things that would have picked up during our inspection findings. And that, in as far as we're concerned, would mean that we need to intensify our interaction with our stakeholders post the inspection period. Honorable Hecklin requested a list of facilities that are inspected in the public and private sector, and those that were found to be compliant. We will make this list available. It is in our website, but we will also subsequently submit it formally. Honorable Hecklin also asked about the decline in inspections. For the reporting period 2022-2023, our target was 788, and as indicated that we achieved 781. We do agree that this is not sufficient for the healthcare sector, bearing in mind that we have not even factored in inspections that must be conducted in general in GP practices. So again, this is it's a funding issue, but it's also an operational issue in terms of how do we then reach out to those. Now, as we look into other measures in terms of how do we realize efficiencies within our operations, yes, we might be able to increase inspections, but the human capital factor is a factor that would definitely need us to receive or to generate funds, to receive funds, so that we're able to increase the inspections. I think the chair responded to the to Honorable Chira. How can we intervene in the systemic changes so that we bring about in the systemic challenges so that we bring about changes? One of the things that we are doing in as far as recommendations on quality assurance to the healthcare sector is to start to develop certain concept documents that highlight deficiencies, as well as how some of those deficiencies can be mitigated. The office has worked on a concept on maternal services, which we hope that we will release to the healthcare sector, so that we look into some of the systemic challenges that have been identified through our inspectorate work. Honorable Gela wanted to know how the OHSC or how the committee, the Health Portfolio Committee, can assist the OHSC. It would be greatly appreciated if the committee could also assist us in advocating for more resources, so that we're able to meet the demands of conducting more inspections, but also so that we are ready for the NHI. As much as we can try very hard to refine our processes, we can only go thus far, but it is very important that at least during this financial year, we're able to implement the decentralization model. So it would be greatly appreciated if the committee could assist us in advocacy in that regard. The question by, I think, Honorable Baba, the chairperson responded to, on the concentration of complaints in Gauteng province. We welcome the suggestion of developing a digital strategy and also to increase our reach, Honorable Baba. One of the things that we are doing as an office is to interact with the National Health Insurance with regards to interoperability of the systems. So this is work in progress. However, there is a need to build capacity as well as to improve our information communication technology infrastructure within the office itself. Honorable Hlengwa requested that we also include KwaZulu Natal. We did inspect we conducted inspections in KwaZulu Natal. However, the cases that you said could be resubmitted, would greatly welcome that, so that we can be able to determine whether it is a case that came to our attention as the office, and we'll take it from there. We will definitely welcome that. Honorable Mororwane wanted to know whether, as the OHSC, we have observed improvements on the reports that are presented to health establishments. It would be fair to indicate that when we conduct re-inspections, there are facilities that then become compliant after re-inspections. For the financial year, of the health establishment that were found to be compliant, 73 of those were from re-inspections. As much as we would want that facilities are compliant the first time around, but we do actually have observed and realized that there are health establishments that actually do work on these reports. Having said so, this is still an area that needs great improvement at facility level, so that health establishments do take cognizance of the matters that we raise in our findings and they act on them. So this is still an area for improvement, even though we have observed that there are pockets of improvement in some of the provinces. Honorable Clerk asked about the health establishment that comply with the ideal clinic framework. Perhaps to make the distinction here that we as the OHSC come in as a quality assurer, the ideal clinic would then be a quality improvement process, meaning that it will be more detailed in terms of what is looked into. So our findings, our work should also then feed into some of the quality improvement plans that are developed in the provinces, so that our findings are incorporated in the quality improvement plans generally. When do we think or foresee that we'll be able to implement the business model? This is work in progress. Some elements would be refining of our internal operations, but there are some elements that certainly require external intervention, such as a funding injection. And I'm referring to the decentralization model. So all this would be dependent as to and the revenue generation, as the chairperson has indicated. So this will be dependent on some of those processes unfolding first. Dr. Jacobs raised concerns about the target of 65%. Whilst we regard this as satisfactory, but we do agree that there is room for improvement. And with the improvement in our human capital and also our inspectorate model, we do think that we will be able to improve on 65%. And with the contract workers that are assisting Program 3, the Health Ombuds, with the disposal of investigations, we should be able to improve. However, I must indicate that the investigators in Program 3 are on 12-month contract, and some of the contracts will be coming to an end soon. So we will be engaging further in terms of at least retaining some of the contractual staff that the OHSC and the Health Ombud has, in order to be able to improve or to maintain our operations. We also welcome the suggestion on the digital platforms and improvements in technology, as indicated that we are working on plans to improve our internal IT infrastructure. Again, it is an element or activity that would be dependent on funds. We'll also be going out to engage other non-government organizations in terms of the support that we can get to undertake some of these activities. I'm going to request, or there was a question on the recommendation on the Rahima Musa recommendations and the Health Ombud. The recommendations of the reports, or contained in the reports by the Health Ombud, are monitored by the OHSC. As of September 2023, there's been quite a number of reports and engagements with Rahima Musa. At some point, we submitted where we were in terms of monitoring the recommendations. There are some activities or recommendations that have been attended, but there are some that would require more time, like the infrastructure. But we do have a report, and these are being monitored by the OHSC. At this stage, Honorable Chair, I'm going to request my colleagues in this order to assist with some of the questions that I did not touch on, mainly around the inspections, the unrest, the early warning system, the HR issues, and some of the finance questions that were posed. In this order, I'm going to request Mr. Mapata, followed by Dr. Jacobs, then Mr. Piri, then Mr. Mohulula, and Ms. Moleko. Thank you, Chair. Thanks, colleagues.
Thanks, CEO. Thanks, Honorable Chair, Dr. Jacobs. There was a question by Honorable Hicklin in terms of the cost implications of labor unrest. So the impact which the OHSC will normally have, for example, is in situations where the teams are already on the ground in a particular area or a province, and labor unrest happens in that place, which then hampers their ability to continue either with an investigation or an inspection. And the teams then are forced to return back to the office. So we have not really quantified the implications of the entire labor unrest if it were to happen in a bigger geographical area. But the impact currently is if we're already on the ground and we can't proceed with the work that we had intended to undertake in that particular area. And there was also a question by Honorable Hicklin in terms of overspending on Program 1, and I think this applies to other programs as well. So in terms of the template that we use from the National Treasury, it limits us to comparing the actual and the budget. However, in those programs, in the narrative, we've indicated that the overexpenditure has been funded by prior year surpluses that have been approved by the National Treasury. Unfortunately, the template does not provide a space there where we can insert the surpluses so that it can indicate that that overspending is actually covered by the surplus. So effectively, that overspending is dealt with by the surpluses that we had. And there was also a question by the Honorable Chair, Dr. Jacobs, which the chairperson of the OHSC board has responded to in terms of the revenue. There are a number of activities that have been identified to generate revenue. The Act allows us to charge fees for services rendered, and some of those will be conducting inspections. And also the Act allows the OHSC to impose a fine for persistent non-compliance. Now, in terms of the fines, a proposal was made to the NDOH in 2019, and also the OHSC was invited to present the proposal at the NHC Tech in terms of the possible fines that can be imposed. So the OHSC is still in discussions with the NDOH on such aspects. And also a proposal was made to the NDOH in around 2020 in terms of some of the amounts that can be charged for services rendered in terms of inspections. So, and also the provision of guidance and support. We did receive a legal opinion from the state law advisors, which indicated that we cannot differentiate when we charge a fee between a public and a private health establishment, because the current setup of legislation will not allow that. So we're looking at a uniform charging of the fees. There was also a question that was raised on the adequacy of the budget. I think that was Honorable Van Staden. When we presented the APP early this year, in terms of the number of facilities, the estimate there was about just over 4,000, both private and public. But the reality on the ground is that the number of health establishments in the country far exceeds what we normally indicate in the APP. In fact, indications are that there could even be more than 50,000. I think the NDOH and a team from the OHSC, they're still working on the actual numbers of facility health establishments in the country as defined in the National Health Act. And now, on a conservative estimate for now, we're looking at about 15,000. that we could work on. And currently, the estimates that we did, based on inspecting 15,000 facilities, which include GPs, is that we'll need about 800 million, with a total staff complement exceeding 700. We also looked at the CQC, which was a model against which the OHSC was benchmarked, and they have about more than 3,000 staff members, and they do in excess of 17,000 facilities in a year. So those are the numbers that we are looking at. As I said, the number of staff, the CEO alluded to this in terms of 323 staff members, but that was based on also looking at the number of 4,000 facilities that needed to be inspected. But the actual reality on the ground far exceeds the 4,000, 15,000 that we have estimated. Thank you, CEO. Thank you, Chair.
Good morning, Chair. Good morning, members. Good morning, colleagues. May I go ahead, Dr. Jacobs?
Yes, please do.
Thank you so much. I would like to respond to the questions from Honourable Clark first, in terms of some of the issues within the complaints management program. I will not address some of the questions that my colleagues have already addressed in terms of the reasons for complaints within Gauteng province, as well as the implementation of recommendations within Raima Musa and Tembisa Hospital. I will, though, look at the question around the facilities that complaints come from within Gauteng, and I can tell you that we do have an even spread of complaints within the province. Of course, within the tertiary hospitals like Rahima Musa, Tembisa, Charlotte Maxeke, we do have more complaints coming from those, but those complaints are higher risk rated, so they may be high or extremely high risk rated complaints. But overall, we do have an even spread within the province. In terms of the number of complaints overall, 98% of all the complaints we receive every year are low risk rated complaints. So we have less than 1% that are high or extremely high risk rated complaints. In terms of the staff that are needed and the categories, currently the complaints management program has a staff complement of 31 staff. Of these, 21 staff are permanent and 10 staff are on a temporary or contract basis. And as the CEO indicated, the temporary staff are on 12-month contracts and their contracts are soon going to lapse. Therefore, we will once again have staff shortages. We have been motivating for an additional 20 staff, as well as the conversion of the 10 temporary posts to become permanent posts. So I think if we're able to have that additional capacity, then the unit would be well endowed to continue with its mandate. There was a question raised about the targets that have failed, the 6 targets that were not achieved, and 3 of those come from the complaints management program, mainly pertaining to the complaints investigation of high and extreme risk complaints. And the reason for that is we only have 3 permanent investigators. And prior to April of this year, we only had 3 investigators. So it was not possible for us to achieve the targets. However, as CEO has also mentioned, given the intervention of the board in providing additional contract investigators, we have already seen good progress with resolution of complaints, and I'm sure that we will report a different picture at the next meeting. I'd like to also address the question about the long outstanding cases, or what we refer to as the backlog cases of 136. These cases have been outstanding since 2017-2018. And of course, the reason that they are outstanding is very much because of staff capacity and the fact that we need more investigators. The investigations themselves are very complex. They involve multiple facilities, multiple witness interviews, visits to the sites, as well as documentation of auditory and visual evidence. We, as a unit, have been developing and have presented to the board of the OHSC, as well as the Health Ombud, a backlog reduction pathway, where we have actually analyzed each of the cases that are outstanding and developed a plan to address each of these cases. The backlog cases are being monitored closely by the Health Ombud on a weekly basis and by the chairperson of the CC committee of the OHSC board on a quarterly basis. So it is something that is receiving a lot of attention. It is a priority, and we really are, as a unit, trying to address that in the most expeditious manner possible. In terms of the issue raised by Honorable Flengwa about the complaint at Vaal Hospital, ma'am, the complaint that you raised at the last meeting and you escalated to Prof. Makgoba is receiving attention. It's in the process of investigation, and I'm sure that it will be resolved. We can liaise on that outside of this meeting. In terms of the issue raised by Honorable Harvard, what do we need to expedite the complaints management processes? At pains of repeating myself, I will say that we mainly need staff in terms of the actual people that are available, trained, qualified, and skilled to investigate our complaints. But of course, with the staff come issues outside of just paying their salaries, the related costs such as travel, tools of the trade, training, etc. So I think I will end there. Thank you, CEO. Thank you, Dr. Jacobs.
Thank you, Dr. Jacobs. Mr. Piri, then Ms. Muliko.
Thank you, CEO, and good morning to honorable members of the Portfolio Committee and members of OHSC board. I think CEO requested me to respond to the question of mitigation for the unrest that we come across when we conduct the inspections. And I must say from the onset that it's a difficult task to do from our side because of this unrest mushroom all over and as you go along. But what we have since the experience of KZN, we implemented a strategy of early notification of the HOD of the provinces. So as we speak, all of the HODs of the provinces know that at which part of the quarter of the financial year, when are we going to be in their provinces, which district and sub-district would we be inspecting in that. Then we are opening the communication between ourselves and them to notify us when there are those incidents or potential incidents of unrest that might happen in particular areas. We have also then further seen that strategy working, particularly where if we look at Gauteng, where we could not or averted traveling because the Gauteng province knew that we are coming at which particular time, and they alerted us of the state on the ground. And we therefore then had to stop the inspectors from going out on the field. But furthermore, also then as part of our preparation for inspections, also we searched through the internet for potential hotspots across the country, particularly where we will be going, to make sure that we are alert of those areas, and where we find that there are hotspots, then we may contact also them with the local police just to confirm if there are those potential eruption of unrest. We were at some stage also Chair advised to see how then can we liaise with the security clusters to see if they cannot also provide us with some information as and when they get this intelligence. It's an avenue also that we need to also explore as an institution to see if it could not also assist us to avert what we have experienced in the previous financial year. Thank you, CEO. I guess that was the question you wanted me to respond to.
Thank you,
CEO.
Mr. Thank you, Mr. Piri. It will then be Ms. Moleko, and I think that would be the last colleague.
Good morning, members of the Portfolio Health Committee, Dr. Kinoshi, Dr. Mdaweni. I am going to be responding to the question related to early warning system and also on the issue of integration. With regards to early warning system, as the office, we are expected to monitor indicators of risk related to serious breaches of norms and standards. And currently, what we are expecting from the health establishment is to self-report the incidences that have occurred. And the response is not what we have been expecting, but I must also indicate that once we have interacted with the health establishment that have responded, then we are able to work with them to prevent any recurrence of such incidences. And we also get other sources of information from media alerts, and we also respond to those media alerts. And the process is proactive, but in terms of us being reactive, one of the mechanisms that we are using is through the inspections. Because when we conduct the inspections, we always make sure that, we identify the things that will make or put patients under risk. And one of the Portfolio Health Committee members were talking about equipments that are not there. And those are some of the things that we are looking for, and things like oxygen cylinders, and it's about preventive measures. And I must also indicate that we are in discussion with the National Department of Health to come up with other mechanisms that we can use to ensure that our early warning system is reactive. Now, the other question was related to integration of information. I must indicate that with the early warning system, we interact with complaints unit to ensure that we are able to triangulate our information. And we do this through our early warning system forum, where we check any indicators of risk that have been reported either by health establishment or media alerts, and also the complaints that we have received as an office, and act on that through investigation or inspections. Thank you.
Thank you very much, colleagues. And that would be all from our side, Honorable Chair. Thank you.
Thank you very much, Dr. Mdaweni, Mr. Mapata, the whole team, Dr. Jacobs, Dr. Kanobi, all of you. I think this is thinking by myself that over the past few years between this portfolio committee and your entity, there's been a lot of I think greater improved presentations and discussions, and for South Africa, if we are able to maintain our discussions on the level which we are currently doing. So I really want to thank you for this thorough presentation, and also my members, fellow members, for the great questions of clarity and discussions which they raise with you. So we've come to the end now of your, maybe if Dr. Kinoshi maybe wants to give a final word for 30 seconds or so, I would then afterwards go to the Health Ombudsman.
Thank you very much, Chair. And
or even yourself, Dr.
Okay, thank you. Thank you very much, Chair. And we, as the board of OHSC and
okay, Dr. Kinoshi.
Yes, I hope you can hear me now. I'm unmuted, Chair. Chair, can you hear me?
I can hear you well, thank you.
Okay, thank you very much. Yes, I was saying myself as Chair and members of the board and also the members of the executive team in OHSC always welcome these invitations from the Parliamentary Portfolio Committee on Health. And I think we do enjoy interacting with you, the support that we get from you, but also the opportunity to share with yourselves and indeed with the people of South Africa, because if we share with Parliament, it's same as sharing with members of the public, people of South Africa, what the OHSC is about, what it does, and what it is confronted with, and what it's how it is managing its work up to now, its challenges, but also what plans it has to meet those challenges. Thank you very much for this opportunity, Chair. Thank you.
Thank you. Indeed, you've said it correctly. It's about the members of the public, the South Africans who are able to watch this and see what the different entities and the departments actually do. So thank you very much. I'm sure you're going to stay on because the Health Ombudsman is part of your department at this point in time, or part of your entity at this point in time. Now, Professor Chaule Mokoena, we welcome you to the meeting. We know you've been appointed since the 1st of June. You're an esteemed academic, good medical doctor, previous head of surgery at UP. It's not my position to introduce you like this and the Steve Biko Academic Hospital, but it's because we appreciate what you have done for the people of South Africa in the past and what you continue to do through this appointment going into the future for the next 7 years. You're obviously filling big shoes with Professor Malechapuru Makgoba. We had a great relationship with him. He's done a lot of good work to advance improved outcomes for South Africans, and we are sure you are going to do exactly that, if not even more. So very welcome. You can introduce yourself and your team further, and then also go directly after that to your presentation. Thank you.
Thank you very much, Chair. And I should greet you and your committee, and also greet Dr. Kinoshi.
Sorry, if you can switch your camera on, wherever you in the media.
Okay, I've got my camera on now. Am I in sight? I was greeting and
no, you're not.
I'm not in sight. I can see myself.
No, it's just a blank screen. You can see yourself.
I can see myself.
From the members, can you see, Prof?
Yes, Chair, we can see, Prof.
Ah, we see you. Yes,
I'm glad.
They can see you, Prof. I've just seen you. So you can continue. Thank you. You can switch off afterwards if you can activity.
Thank you very much. I will switch off because the bandwidth is not very good here. But I was thanking you and the members of your committee, as well as thanking Dr. Kinoshi and the board, and also greeting everybody, including the members of staff of OHSC, and the Office of the Ombud. I will show a few slides, but most of the information that is on my slides has already been flighted by the CEO of the OHSC, Dr. Mdaweni. So much of it will be repetition, and I'll try to repeat as little as possible. Although as a teacher, I know that repetition doesn't kill, but it emphasizes. Maybe I should flight some slides, and then I'll go through them very quickly. With your permission, Chair. Now I'm going to be talking about the program, which is the Ombuds Office for the financial year that passed. I don't need to tell the committee about the structure and the building blocks that much. Already you've heard something about that. However, I'm going to highlight some of the challenges that we've seen. You've heard many of them already. And then some of the key interventions that we plan to undertake, as well as the innovations and improvements that are needed. At the same time, there are some matters that require urgent attention that I'm going to close off by telling you about, or indicating about that. Now, the purpose of the Office of the Ombud is legislated by yourselves under the National Health Act, and I don't have to go through that. Only suffice to say that we receive complaints as well as indications in the media and other platforms of instances where the health establishments have had infractions with norms and standards of healthcare. Now, this slide is rather busy, but I'll go through it nonetheless to show how the program of the Office of the Health Ombud is structured. From the outset, I need to say that all the staff within the complaints management program, which is the Office of the Ombud, are seconded from the Office of Health Standard Compliance. There's only one member that's not seconded. That's the Health Ombud himself. The rest are secondment. So the Health Ombud works without any staff of his own. The way the program is arranged is that it's arranged in three components. One is the call center, which receives complaints, and the other is the complaints assessment unit, and then lastly the investigation unit. Most of the complaints get settled at the call center, and only the medium to high risk complaints are escalated further. Now, from the period under review, which we extended backwards to 2020, is that we received just over 11,000 complaints, And of these, 96% were resolved within 25 days, which is our service level target. And 55 were medium risk, and they were resolved within the required time. And 68 were high to extreme risk investigations, which were resolved within 24 months. You've already heard that the high risk and the extreme risk investigations, they take a long time, and that they involve a lot of health establishments and many health professionals. And as such, we need to undertake not only one, but a number of trips to the area where the complaint emanates. Next. Now, this slide here shows the distribution of the complaints over the time that we've been working on from the financial year of 2019-2020 up to the year of reporting. You will notice that there's increment of the complaints. This can be explained partly by the population becoming aware of the Office of the Ombuds, as well as the increase in population. I don't want to believe that it is because of increasing recklessness of the healthcare establishments. This pie chart indicates what you have already been told, that most of the complaints emanate from Gauteng, and that Northern Cape has got the least complaints. It bears noting, therefore, that Northern Cape has got although it is the largest surface area province, it has got the least population. And contrary-wise, Gauteng has got the smallest area, but has got the largest population in the country. And therefore, it is not surprising that the numbers reflect the population size of the different provinces. Next. The slide just shows how much we have achieved and over the period, and we've achieved nearly 80% of resolutions of which are within our target over the periods. Now this next slide is important to the extent that it shows the resolution of cases within 30 days through the assessment unit, and it is clear that the trajectory shows an improvement over time, and part of this is not only because people are becoming more familiar with their work, but latterly we've had increased staff. Lest you think that our staff is enough, but the complexity of the cases is increasing. Now, this slide here shows the more complicated cases which took longer to resolve. The green bar there with the red arrow on top indicates what we are achieving currently. And this is just to pat ourselves in the back, and this is what the population thinks about us. And it's not terribly important to you. It's important only to us. And this just shows that the throughput that the office, these are the annual reports, culminating with the annual report that you now have in your hands. And we reach nearly 25% of the population in the country. And there are serious problems within the program, and at pains of boring the members here, it is important to emphasize the lack of staff. That the staff works very hard, but they are overstretched, and one fears that they will suffer from burnout sooner than later. We've already spoken about the backlog, and part of it you were told, and I want to reemphasize that the backlog came about when there were no staff at all in the Office of the Ombud. Now, with the increasing complaints being received, together with the complaints that were not addressed to before the staff was there's been backlog, and the backlog is increasing. Now, there are other lessons that were learned, and that we need to redefine our targets according to the ability to reach them. Partly, before we set the targets, we did not appreciate the complexity of the work that needs to be done. Remember that the complexity that is not only inherent in the cases themselves, but also in the ability or lack of the health establishments and the professionals to respond and feed in information that is required to progress the investigations. Now, all this work needs skilled and qualified staff, and that takes a lot of effort to retool and skill people in the investigation, which is novel within our country. There are other issues that I need to bring to the portfolio committee's attention, and that is while by legislation we need to investigate the complaints as independent as possible. You, the legislators, you put the Office of the Ombud within the Office of Health Standard Compliance, and you did not give the Ombud any human or other resources, and therefore the office is dependent on the Office of the Health Standard Compliance, and that is inimical to independence. I'm glad to say that that can be remedied by putting the health ombud into an independent entity, which the new or the draft health ombud bill seeks to do. Maybe I should just say that once the Health Ombuds Office is independent, we're going to restructure the organogram and among others to include a medical legal review and assessment of all reports. And this is to make sure that the reports, when they come out, they're not, well, maybe I shouldn't say not, that there will be less grounds to take them on appeal. Likewise, the language should be of a standard and nature that they are not to be misinterpreted, and therefore creating ambiguities that open the ombud for appeal. I will skip this particular slide, and then I'll just address some of the issues that need urgent attention. It bears repeating once again that if you do not offer resources, you cannot hope that work is going to be done. So the Office of the Ombud needs financial resources, human resources. You need the library, access to the library services, so that we can, they can look at cases, similar cases that have been dealt with in the past, not only from our jurisdiction, i.e. our country, but also in other countries across the globe. And while we are waiting for the health ombud bill, we need to take steps to make the Office of the Health Ombud more independent, autonomous, and that could be created by creating an independent, quasi-autonomous environment where there are shared services. This is not our idea. This is the idea that we got from Treasury. And then lastly, the office space where the health ombud works is not fit for human habitation. The offices were previous storerooms for all the ombud himself, the senior staff within the ombud's office, and the junior staff. They are working in an open space where there's no privacy, and it's noisy, that get distracted. It's altogether unbearable. I wonder how, for the past 7 years, they managed to survive and do as much work as they did. But I do want to enlist the portfolio, the health portfolio, to assist us to get resources so that we can relocate to better offices with better staff. Thank you very much.
Thank you, Professor, for this great presentation. You've given us a great insight into what's really happening in the office. Not that some of these we've not heard from your predecessor, but also in your presentation, you've given us an idea of what it is that we can do to assist you further so that you're able to provide better services to the people of South Africa. So, Prof. Mokoena, that was now your initiation into the portfolio committee. And I hope they're going to ask some very good questions to you and really raise some very good discussions with you. But I think I'm going to start first. I normally give my members an opportunity, but I have a number of things which I want to raise. I think central to what you've been speaking about is this thing of the Health Ombuds Bill, which is when it started, the discussions around it, this portfolio committee was involved and were really supporting the forward movement or the development of and the pitching thereof of the Health Ombudsman, Health Ombud Bill to the minister, and then of course it must go through the process. So first thing I want to ask you is, what is the reason? And you caused it slow, and I was going to ask you what is the progress, but then you quantified it by saying it is, or qualified it by saying it is slow. And if this is passed, does it address this very second last slide and last slide of yours about the concerns or the challenges which were raised, like inadequate resources, office space, etc. in the bill? Because we've not really seen the bill yet, or if I had, I can't recall having seen it, but I don't think I've seen it, or the draft bill, or the bill in progress, or the work in progress, whatever it is called, and you'll be able to tell us what that is called. But we have not seen it, and I would like to know whether it will address the issues of financial challenges, HR, legal, just the appointment of people in the office with legal people, lack of library services, for example, which I have some questions for you about with regards to that, and the independence and autonomous Office of the Health Standard of the Health Ombud. So, you know, in the end, when everybody's done, all of my members have done, so we do have a couple of recommendations that we want to make as the portfolio committee towards the end. But I wanted to start there and just raise this so that when the members speak, they would talk probably about the same things. But I think central to that would be the answer of whether these matters are contained within the Health Ombud Bill. And if you can maybe speak to that. If you're able to speak to it now, I'd appreciate it. If you'd want to wait for all of the questions to be asked, that's also good enough for me. We can't hear you, Prof.
I said I can
Here
speak
we
to it. We just call it the Health Ombuds Bill. It's a draft, and I don't think that it has gone anywhere near Parliament yet, because this is my understanding, is that after it had been panel beaten within the Department of Health and other related departments, when it got to Treasury, Treasury said that they do not entertain creation of new entities, but rather they would rather decrease new entities because there's no money. This is my understanding. I've never seen that written anywhere. It's what I understand when talking to both my predecessor as well as officials from Treasury. You are asking if the draft bill will address the shortcomings of of the resources as we had outlined? The answer is yes, because it addresses, it creates a freestanding entity, public entity with all the necessary facilities within that, including human resource, the different facets within human resource, being investigations and the legal support and so forth. The finance, we can't say it will address the finance, but like all entities, it will require a budget, and then it is up to Treasury to give the budget. So in itself, it cannot. Now, during the previous session with the OHSC, there was an issue about other forms of funding. In other words, how OHSC can derive a different or additional revenue stream. Perhaps the Office of the Health Ombuds could also have a revenue stream that derives from the investigation that it would be doing. But we haven't thought about that very seriously. There may be legal and other ethical constraints for the Office of the Ombud to levy fees for investigation of complaints, remembering that most complaints are from poor people who have got very limited resources. I think regarding the library, we don't actually require a big library, but we do require a library of key references. But we would need the office to affiliate one of the international or public libraries, so that they can get articles and publications that would assist in their work. I don't know if that suffices.
Yes, thank you very much, Professor. You've done very well. Appreciate it. There are a couple of members who want to raise some questions and discussions with you. I'll give the order. It's Gela, Clark, Van Staden, Heatland. Any others? Gela, Clark, Van Staden, Heatland, Kaba.
Please note my hand as well, Chairperson. Sorry, I can't raise it on the platform.
Chirwa, Morovane. I'm going to repeat. It's Gela, Clark, Van Staden, Heatland, Kaba, Chirwa, Morovane. Thank you very much. In that order.
Thank you very much, Chairperson. Let me join you by welcoming the presentation from Professor. Chair, indeed, you have touched the issue of the office space, which is a matter of concern that need to be addressed because they've been complaining about the office space since the past 4 years, Chairperson. So we need to intervene as matter of agency, as portfolio committee. Chairperson, my questions regarding the presentation. One, Prof, what mechanism can enhance the ombudsman to be accessible to the public? 2, what innovation is currently undertaken within the organization to enhance its capability and impact? My last question, what is the extent of the backlog and what type of matters are delayed? Thank you very much, Chairperson.
Member Clark.
Thank you, Chairperson. Yes, it's very concerning to listen to the exact same constraints that we heard last year in terms of the office space, and that's been raised. And I am very happy, Dr. Jacobs, that you have raised the issue of the bill, because the Ombudsman for a long time has been speaking about its independence and what should be done. But obviously, you know, in terms of funding, it has just not realized that outcome. So what I would like to ask is if a report could be submitted to our committee in terms of the cases that are still outstanding, or cases that have been worked on, but certain parts are still outstanding because of certain constraints, because that could give us a very good indication as to what the Ombudsman is grappling with, and what kind of staff component would they need in terms of being capacitated. So that, and then also, you know, what would the legal office compliance, what would the budget be for that? Because certainly they can't do their work without some legal guidance in terms of cases. And I mean, we see this, you know, the Ombudsman and the OHSC being really overrun with work, because our hospitals are in a terrible state, and I get complaints daily about issues. And I must say, when I do send it to the Ombudsman's office and to the OHSC, they do respond immediately. But, you know, you never know how long it takes for these cases to be sorted out. And many of these cases are people that have died in hospital or could have died because X, Y, and Z was not done. So I think it's important for us to see that report, so that we can get a clear understanding in terms of that. And also, what kind of process would the Ombudsman put in place in order to recruit skilled and qualified personnel to make it attractive for that kind of person to come and work in the Ombudsman's office, because we need that, you know, in terms of resources. And then my last question to Professor Mukuna, and welcome to our portfolio for the first time. Last year, when we had a presentation from the Ombudsman, Professor Makgoba had said to us outright that the hospitals in this country will never, ever comply to what is needed in terms of the NHI. Can I have your response to that comment as well? Thank you very much.
Thank you, Chairperson. Honourable Member Clark took all the questions out of my mouth, but I still have one left. So I was covered by Member Clark. Actually, no, Professor Makuna, welcome to this committee. It's very nice to meet you. It's just a pity it's not in person, but I think it will happen soon. So I'm looking forward to working in the future with you also. Just one question on the number of complaints you have received. You said in your presentation over the 11,100. Can you just indicate to this committee, out of those 11,100, how many was regarding the public health facilities and how many was regarding the private health facilities? Thank you, Chairperson.
Thank you, Chair, and good afternoon, Professor. Like you, I am also very new in this portfolio. I noticed in the presentation that we got that this is the 5th year in which 4 vacancies remain in the Office of the Ombud. The Director of Complaints, 2 inspectors, and 1 director in legal. And my question is, to what extent is this hampering you doing your functions mandated that by the legislation that you are mandated by? How is this affecting your efficiency as an entity? That's question number 1. Number 2, the backlog in cases, the serious staffing shortages, the extreme budget constraints, and the governance challenges by your not being totally independent and you're not being totally able to stand on your own 2 feet, so to speak, are very serious. What plans do you have in place to actually mitigate against this? With regards to the complaints that you received, did any of the complaints relate to adverse effects in terms of COVID-19 vaccines? And if you did receive complaints with regards to adverse effects with COVID-19 vaccines, how has this been addressed? Thank you so much, sir.
Thank you, Chair. Chair, maybe if I may have to start with the list, just to indicate that one was available in a meeting when Professor Mokova, the incumbent before Mr. Kwena, addressed us. His utterances were clear with regard to the support of the NHLS. So perhaps even if we can go to the Hansard, that will be very much cleared. I thought maybe that must be put on record. The other thing, Chair, which I wanted to ask is that what problem statement with the Health Ombuds Bill address? What is the problem statement with the Health Ombuds Bill address? What does it address? 2, Chair, in relation to independent and autonomous OHO, what instances or acts have threatened its independence? And what is the overall compliance and progress of reports of investigations by the Ombuds since 2019? But Chair, we will not throw in only questions here. Maybe we must also throw in some recommendations because we are this committee that builds. My recommendations, which I will propose, Chair, will be if the department increases the budget allocation for the entity to increase its staff complement. That is very key. And the entity must finalize its bill to enable discussion on its content. It's very important. The entity must research how it harnesses digital technology, such as artificial intelligence and machine learning, as this can reduce the processing of reports and matters and issues such as language proof of reports and other functions. Last recommendations, Chair, could be the entity should affiliate with digital libraries and work with the higher education institutions to increase access to library services. So I submit, Chair. Thank you.
Thank you very much, Chairperson, and thank you to the Ombudsman for the presentation as well. It's fairly a new term for the Ombudsman. So I really just want to start with the ground level questions just to fundamentally understand the strategic plan of the Ombudsman. Firstly, with finding out what the priorities of the Ombudsman in the coming 7 years will be, what the focus areas will be, and the overall intention of the term, outside of what the aims and the obligations of the entity is, or rather, if I may, how he plans on implementing the aims and objectives of the Office of the Ombudsman. And second, I think the issue of of access was addressed, but more over than just asking plainly the question of the issue of access, I want to find out from the ombudsman if things like, for instance, a WhatsApp number for the public can be made available to just make it easier to address the issue of access, social media pages and stuff like that, just to be made more accessible and to be put out there more than they currently are. Because the issue of access is a real one. And how we see that it's a real one is the number of litigation cases against the NGOH in contrast to the cases that the Ombudsman is investigating. The fact that people are opting for the courts should really be an indictment on the Office of the Ombudsman, Health Ombudsman, more than anything. Not saying that the court system should be a second or afterthought, but the fact that there is an entity that exists for this particular purpose and is not as utilized as much as the alternatives is a big indictment on the Office of the Health Ombudsman. So I'm speaking on top of that. And thirdly, I want to find out from the Ombudsman how he feels about the concerns that were raised about his appointment. The issue of the conflict of interest, political allegiance, not taking away from the historical context of the work that the Ombudsman has done before. Don't get me wrong, I just want to understand from your point of view, because some of those concerns are valid. I think the Ombudsman will agree on this particular one, on the issue of conflict of interest. But I think I want the Ombudsman to just expound for us on how he perceives these particular concerns that were raised in relation to his appointment. And lastly, and I think I'm going to be asking this to all the entities that we are going to be engaging with today, on the issue of obstetric violence. Ombudsman, I don't know, I feel like we are not having enough of a woman-centered or justice around the justice of women and the healthcare sector and the public healthcare sector than we should, especially in a country where we are still having cases of sterilizations. For example, in South Africa, a democratic country, having issues that people had during the days of slavery in the West against Black women, against HIV positive Black women, where we have issues of children dying, of children getting to live with permanent disabilities because of hypoxia, because of the incapacity of the public sector to facilitate a C-section and stuff like that. That is excessive. What is happening in the public sector at this point is a big human rights issue, but we're not having enough eyes to point it out as such and to deal with it as such. And that is a big problem for me, because it means one way or another, it's either we're failing in our oversight capacity, or we are also failing even in holding the department accountable, or to take the department in the right direction. It cannot be that things that are avoidable of this nature keep increasing with every waking year, despite there being knowledge and research and all of those things to capacitate the department. And it's being done even in the private sector. If you are outside of the conversation, you'll think that the private sector is money focused on increasing C-sections, until you find out the real reason to the fact that they're actually avoiding things that are happening in the public sector. And this may be a big jump, but I really want to find out from the Ombudsman, how do we plan to tackle this particular on a systemic level? What are the intervention strategies that the Ombudsman is able to generate regarding this, regarding obstetric violence, different kinds of obstetric violence, different kinds of issues of quality healthcare for infants coming into the world through the public healthcare sector or the public healthcare system. At this point, it is a big concern for me. because most of the cases that I particularly get is in relation to this, and there isn't even a proper systemic method of dealing with. Like the department is able to get away with most of these cases just by the way, because the tick boxes are being ticked, and then second to that, there's lack of information. So people who have children who suffer from hypoxia don't immediately think that the problem was the department or how they gave birth in a hospital. They think it's something that happened supernaturally from God or whatever. So even the education level of dealing with obstetric violence is an issue, and that is particularly why, even for example, in the for sterilizations was such an issue, because people were lodging cases more than 3 years after the violence took place, because they did not have the knowledge to deal with this particular thing. So I want to hear from the ombudsman, beyond just cases being lodged in your office, there's this particular thing of obstetric violence and the other things I'm referring to in relation to children. How do we deal with this particular thing beyond just dealing with case-to-case basis if you get them, because at this point it's a systemic thing and it's growing. It's growing. Thank you, Chairperson.
Thank you very much, Chairperson, and also appreciate the profiling, the brief profiling, because I've heard that it was just brief in terms of the prof rich history, in terms of experience, and that in itself made me to realize that we have the perfect, excellent candidate for the work that is ahead. I have got only 2 questions, Chair. The first one that I want to pose to the Prof and the Ombuds is, what is the profile of the complaints and what weaknesses do they reflect in our health system? That is the first question. The second question, which performance indicators will be then the ombudsman review to ensure an outcome-based indicator? With regard to the other question, I've been covered by Honorable Geller, because I also wanted to ask about the extent of the backlog and what type of matters are delayed. Thank you very much, Chair.
Thank you very much, honorable members. So, Prof, I also have 1 or 2 case questions I want to ask you. The one is with regards to what you mentioned about the complexity of cases which are increasing. I think it would be a natural evolution that the more people are aware of their recourse of being able to lodge complaints with you, the more difficult the cases will become. So the question is, and it's aligned again to what we spoke about earlier of the bill, but now I don't want to reference the bill, but really about the filling of those posts and what are the expertise that people would be required to have if you had to fill those posts. Because you spoke about retooling and reskilling the staff, and I think that at the level of where you're functioning, the kind of people that you would require would be people who would be multi-skilled, with experiences in many facets of life, whether it's academically, experience, expertise, knowledge, having read wide or participated in many different programs, etc. And the other question is, of course, in terms of the people you require who are legally qualified, what percentage of that would really be needed as these cases become more complex? And then we have a challenge with medical legal cases in South Africa. We had a presentation from the AG yesterday, which showed that our current caseload or monetary value is at 67 billion rand. It's a major, major concern. And so the question is, in your observation, do you have any key recommendations at this point in time for the department, for ourselves, things which we can pick up to try to reduce these claims. And then most of these claims, and you've mentioned it, and we've seen it from the OHSC's presentation, is focused on the Gauteng province, and it mainly emanates from the Gauteng province. So is this a reflection of awareness on the role of the ombudsman? And how does the ombud ensure that they are accessible to the poor and the needy? And we've heard that there are many, many challenges, and we'd obviously want to see how those can be addressed as we go forward. So there are a lot of questions being asked to you now. Prof. Mokoena, we know you are not that long in office, but I would also think, and I think that is what the members were thinking, that when one enters the office, one sits and thinks about what it is that you want to achieve in the short term, medium term, longer term. And I'm sure these questions must have crossed your mind, and we'd be interested in you sharing any of those with us here. It was specifically mentioned by Honorable Chirwa as strategic plans, but it is actually what we're asking of you. So just to get us a timeline here, honorable members, we're supposed to finish at 13:30 for lunch, break for lunch. If we finish earlier, we'll just take a little bit of a longer lunch, and we will come back afterwards to get our first presentation after lunch from the MRC. So back to you, Prof. Mokoena. Thank you.
Thank you, Chair. In difference to your position, I'll start by answering your question. You're asking about the complexity of cases. It is not easy to answer this question. I can only indicate by way of example of one of the cases that that we've been engaged with. You would find that by the time the case gets reported or where the complaints comes, which is at the tertiary referral institution, it started at the primary level, and then it gets from primary to secondary, which is district hospital, and then it goes to a regional hospital, and ultimately it gets to the tertiary hospital. At the tertiary hospital, not to say that at other levels, it didn't happen. It gets addressed by different specialties. Being a surgeon, I'll say outright, there are surgeons involved, there are anesthetists involved, there are intensivists that are involved, there are radiologists. So that's the kind of complexity we're talking about. So when we investigate it, you have to investigate every facet, starting from where it emanated, that is at the primary level. And in that regard, then you ask what kind of expertise one needs of the investigators. You suggested that we need a multi-skilled person, but not many people can walk on the sea. So we need a team. We don't need a one individual. We need a team that understands the practice at these different levels that I've just indicated now. And you would not know that you needed them until the leader in the investigating team points the investigation to another direction. Now, I've just said that this is within the healthcare system, but it can go outside the healthcare system, such as I think there's a case that was referred by Honorable Clark, which involved not only the healthcare institution but also the police department. So, in other words, the cases are varied. They cover a number of levels within the healthcare system, referral system. They also involve organizations outside healthcare. You're asking what percentage of legally qualified people would we need? I can't give you the number outright, but I would say that each team, we have sub-teams here, about investigating team, about 3 currently. Each team should have a legally qualified person, but not only a legally qualified person, but a person who has got medical, legal qualifications or background. And then you ask about how could we reduce medical legal cases, which are costing us billions. The short answer there is that we should change our legal system in the manner that I'm going to describe now. Currently, lawyers can work on risk, and the result of that is that the hospitals are full of touts that are touting for cases in the hospitals. Indeed, you find lawyers' cars with stickers at their back. They say, "Do you have a problem with your doctor? If so, come to us." So one of the things that would reduce the medical legal expense is to do away with at-risk cases, because most of them are actually quite trivial. When I say trivial, I don't mean that they're not important to the individuals that are affected, but in the greater scheme of things, there are things that are inherent in the process of living, and that no healthcare practitioner can avoid. But by the time it has gone through the legal system, it has cost not just the individual, but the system and the population a lot of money. You are asking about the increased number of cases in Gauteng. It has been my issue that we should investigate this scientifically. The colleagues from the OHSC, they have suggested a number of possibilities, one of which I'm not going to repeat, but I'm going to put another possible explanation, and that is 40% of healthcare is consumed in Gauteng. So it's not surprising that more than 50% of complaints emanate from Gauteng, because that's where most of the healthcare provision is happening. A lot of patients whose problems started elsewhere, not only problems, but also their healthcare delivery started elsewhere. Because of the complexity of the problem, they end up in Gauteng, which has got more than 60% specialist, highly specialist healthcare provision. But this is just my thinking. We plan to investigate that scientifically. And then you ask about the access of health ombud to the poor. I think the access is free and available. What is important is that we, by we now is not only the health ombud, but all of us, the community, is to publicize the fact that there is a health ombud who I view as I don't want to say that is an arbitrator, but rather also as I'll remember the word now, but advocate for healthcare for everyone, including the poor. I think those are the issues that I noted from you, Chair, and then I can look at the others in sequence if I can remember it. I don't recall everybody's name now, but the question of increasing, I think it was Honorable Gela, increasing accessibility. The increase of accessibility is perhaps embodied in increasing the awareness, because otherwise people can write to us, they can email us, they can walk in, they can telephone, and the telephone is it's a toll-free, so that makes it available and accessible. Of course, those that are around Gauteng, they can walk in. And there was a question about the use of, I think this came from Honorable Chirawa, that we could use social media platforms to increase accessibility. It's something that we could look at. However, we should be careful not to create too much noise in the system, such that people with more serious complaints and problems get drowned out. But we'll look at that going forward. And then there was an issue of increasing the impact. I think increase of impact goes along with efficiency of solving the problems that we do have. And if we solve the problems that we do have, address the problems that we do have, the impact will be great. And we've already indicated that we have the wherewithal, except that we don't have the resources to solve these problems expeditiously, as we are enjoined by the Act. The backlog will give the committee the list of the backlog and the nature, but most of them are high risk and extreme high risk cases. But because they are a backlog, we haven't started investigating them, so we can't unpack them for you. We can only give you what the complainants are complaining about. And then Honorable Clerk, you wanted a report, which I've just said now about the outstanding cases are a backlog. So we've answered that. The staff complement that's necessary. I answered partly about that part by saying that we need people that are familiar and have got experience in the different facets of healthcare. That will include nurses, doctors, and lawyers. And about legal compliance, we've already addressed that we need more medical legally qualified people, so that our reports comply with the law, not only with the law, but also they are couched in such a manner that they cannot be misinterpreted. Recruitment of staff, of course, we use the available outlets for recruitment of staff. However, in order to attract the people that are suitably qualified, the rewards, both the monetary as well as what we call the environment. The environment must be attractive for people to want to work here, and there should be enough incentives, both monetarily and non-monetarily, monetary ones, in order to recruit staff. People must feel that it's a nice place to work at. And then Honorable van Staden, you wanted a breakdown between public and private, and currently we have 20% private and 80% public. But this is also a reflection of the of more or less the proportion of healthcare divisions according to public and private, although the expenditure is the reverse. The private sector provides for 15% of the population, and we have 20% of complaints emanating from there. So it's proportional to their workload, not necessarily from the for the financial consumption. But we can provide the exact numbers if Honorable van Staden requires them. And going back to Honorable Chirwa about the strategic plan and the priorities, the strategic plan is essentially to undertake our mandate in the most expeditious manner that we can, and then the priorities they derive from the severity of the cases that we do receive. However, we are in the process of trying to prioritize, not only in terms of our. Before I tell you, I talk about prioritizing. We must at all times remember that according to the standards and the regulations, we need to address each and every case within a certain given period. And that's not defined by us. It's defined by the regulations. So within that, we can prioritize certain cases. For instance, those that have got a high impact to the population. In other words, where there's a mass occurrence as distinct from individual occurrence. I don't know if that would satisfy Honorable Chira. The resorting to the courts, we can't stop people from resorting to the courts. However, from my submission earlier about the lawyers touting within the floors of the hospitals, you'll realize that there's a very strong push and movement and pull by the lawyers to go to the courts for obvious reasons. Now, the issue of obstetrics, it is said that the system, as in healthcare system, should fail the mothers the way that Honorable Chira is referring to. Now, the question of the rate of cesarean section, an increased cesarean section does not necessarily mean better practice. It's got other implications that are medically and technically more complex than what we can address in the short period that we have here. Needless to say that the obstetrician resort to C-section, not necessarily because of money in their pockets, but as a means of avoiding litigation. A lot of mothers, if their children are not achieving at school, they go back and look at what the obstetrician did and try to pursue them for the low performance of their children. Of course, as I said, that the issue is more complex than that. It is true that the public health system is overwhelmed. It cannot cope with the load that it gets. And because people are overworked, it takes them a long time. There's a lot of work for with a shortage of staff and facilities. What's the word? Errors happen, and sometimes with very serious consequences. I'm not going to address the question of forced sterilization. That is criminal, and other organs of state should pursue that. If Honorable Chira knows any cases, they should go to the door of the public of the national prosecuting authorities, and then maybe I will address Honorable Chira about conflict of interest towards the close of my conversation with her now. The profile of complaints and what weaknesses do they feel on the healthcare system, that I think that was from Honorable Murwane. We cannot give you that off the bat. We would have to go and investigate them. in detail. However, I can tell you that the high in the list are obstetrics and neonatal, followed by surgical, and then the rest would constitute in the order of 60%, but 40% are from these two general general areas. But we'll provide the exact details at an appropriate later time. And I can't remember who asked the question about COVID. So far, we haven't had any cases about COVID vaccine complaints. And then the constraints about non-independence, I think it was from the same member, is that the issue about independence is important, and not only because it is legislated, but also it must be seen to be independent, because our findings will find wrongs across the healthcare system, not only private versus public, but also by the regulators within the healthcare system, including the Office of the Health Standards Compliance, within which we are squatting at the moment. And then the issue about IT, the use of artificial intelligence, I think that came from Honorable Baba. That's an important facet. We are looking at that. However, I must just say that because of the complexity of the cases in the manner that I've briefly sketched, it is not going to be easy to find an IA that will solve this. You need human eyes, human nose to smell, human ears to listen when you investigate. What gets inputted into a questionnaire, which is what AI would do, and what is on the ground is very different. So it's unlikely that we'll ever do away with the human senses. However, AI can expedite some of the facets of our investigation, and we're looking at that. And then I'm running out of enough saliva, so I'll address the issue of conflict. Ms. Klaba, not Ms. Klaba, Chirwa. I should start by saying that I don't know if what is looked at as conflict, I don't know where it derives from. However, I heard on the at one of the television programs another esteemed professor saying that because I come from a background of a political party, which is not a secret, but I'm not going to mention it now. I won't be able to execute my my mandate objectively. Now, what I usually say, people who do say that are people who are one, not professionals, and two, who don't know this individual, which is Mokoena. As a professional, I do my work unflinchingly and as honestly as I can within the resources that I do have. And the reflection of that is that in my more than 40 years career, I've never been taken to task about failure to manage my patient. I've been a teacher for a long time. At no point have I been ever been found to have been less than fair across the gender and color line. If anything, in my department, people of color and women, they have been made to thrive. And then lastly, whoever knows me will know me that I have a singularly independent. I fear no one. In fact, I fear nothing on earth, and nothing would influence me to do my work any way other than how I should. And those people that know me, they know this. And I don't know if this will satisfy Honorable Shira, but Honorable Shira looks young enough. She will still be here when I finish here. Then she should ask me this question on the last day of my work here. Thank you very much, Chair. I'll get my colleagues to fill in where I have left out.
Thanks, Prof. If they don't have, it's also good. Anything from them?
They're telling me that they've had enough.
Thanks, Prof. No, you have answered like a true professional, ethical man who's been doing your work for many, many years. We really look forward to working with you. Well, listening to you, I was amazed by your knowledge, your skills, and your expertise. You actually told the public today how difficult it is to do work in South Africa as a medical professional, having to be ethical, morally correct, and professional about what you do, and how one has to separate that from the other things, whether it's your things at home, whether it's how you drive your car or somebody else drives their car to affect the outcome of the patient, or whether it has to do with politics or anything else. So I am so excited that today somebody has come and said that in South Africa, and I think indeed in the world, there is this thing called medicine, which is being professionally driven by people who are trained to do it, and that it is a very specialized domain, and that many people try to be doctors. Everybody wants to be a doctor, but when it comes to that obs-gynae, that surgery, that work that needs to be performed, need a professional, because that's essentially what we do. Thanks, Prof. So I wanted to close with that, but I also want another impression today, which I like so much. You said that because most of the services are rendered in the public healthcare sector, we should expect most of the complaints to come from the public health sector, and that makes absolute sense. I really wrote that down. I really like the fact that you opened one's eyes about the challenges which we're having, that the public health system is overwhelmed, that it is challenging, for doctors, nurses, other professionals and staff to work in a system that is challenging. So additionally to that, you use the word, you say touting, and I went to look up what does it mean touting, and I want to read this because we are actually on a platform where it's good for education of our people. It says, it's an unethical and at times illegal practice within the legal fraternity whereby someone tries to solicit work from a potential client. Now, you said the only way it's going to change if there is change to our legal system. And I fully agree with you. So I think at some point we need to have a discussion, and this needs to be provoked as to how do we actually change the legal system. My experience is that if you have money in South Africa, you can do a lot of things. And when you do those things, you even do harm to those who don't have money, because you go to court, you perform a lot of things in court, and the court or the judicial system look at it within the context of the law and not necessarily within the context of our social problems. And so that, I think, is also skewed in the sense where it favors those who have money, but it also that you have people who are in a particular profession go around looking for other people from whom they can source or instigate to bring particular cases and then source work from them. So it is something that I would like for us to continue discussing which I would have an interest in. So, Prof, you said there are wrongs across the entire healthcare system. I agree. And those wrongs are actually what we are about as a portfolio committee on health. I said earlier to the OHSC, I have seen the growth of this portfolio committee. And I would hope that after the elections, whoever is there would continue to keep this standard and this bar at the level where it is now and improve on it. And not for us to go back to a lower level of functioning, but to be able to hold the executive and the department and the entities to account. And hopefully raise what we're doing to as I said, to a higher bar where we'd be able to have the kind of discussions that we have just had with you. So thank you very much for this. Thank you to our members. We're just about on time to have lunch. Please enjoy your lunch. Prof, if you want to say something lastly, 30 seconds.
No. Committee and yourself, and the invitation that we should engage more, maybe with yourself as an individual, but also with your committee, is very welcome, and I'm ready to take you and your committee on that. Thank you very much.
Thank you, Prof. We're looking very much forward to it. Yes, myself and also my committee, and also individually myself within the authority that I have as a chairperson too. So, honorable members, we're going to break for lunch, and please do not switch off your devices or your gadgets. And when we return, we will continue with the presentation from the MRC. And you're welcome, Prof, to stay, and the OHSC members to stay if they wish to. We can all just learn from what is really happening out there, but through these presentations on the annual performance plans or the annual reports. Thank you. Have a good lunch.
Thank you.
Good afternoon.
Good afternoon, honorable members. Can you hear us?
Yes, we can hear you. Your name is SAMRC.
Yes, Chair. Can we please ask the Secretariat to allow us to share the document because it says the host disabled participant sharing screen.
All right, so our host, I'm sure they can hear you. It's Ms. Majalamba and Ms. Ngomane. Oh, she's made right now co-host. Who else? Is that fine? Oh, you want who is SAMRC? Is that
It is us,
oh, that's
Chair.
yourselves.
Yes.
Mongesi, we just can't see the slides. You need to
Yes.
share the slides.
We're waiting for the host to allow us to share the slides.
All right. There we go. Co-host, you know, co-host.
Great. We can see it. That's great.
But we're ready to start if when you are.
We're ready to start. Honorable Chair, do you want us to, we have our board members also joining. There's some board members that are joining. Can I introduce them?
Yeah, just give me a moment. I want to make certain that my members are here. I would assume it is 2 o'clock, and just for me to do the formalities. Let me make certain that all my members are here, and to remind everyone, this is a continuation of a meeting of this morning, that all the rules which I had read apply in this meeting, since it is a continuation, and the rules of virtual sittings will therefore, and virtual meetings will therefore apply. So I would then hand over to you, and thank you for the presentation that was forwarded by our very capable officials to us and staff. And so with that having been said, I will hand over to you, Prof. Gray. You can continue with the introductions and go straight to your presentation.
Thanks, Chair. I just want to introduce the members of the board that are able to be here. We've got 6 members that are on. Doris, who is the head of our audit and risk. Doris, if you can just show your face. If you're on. I can't see. If you're on, I can't seem to see. But we have Doris.
I am on.
Doris, maybe just show us your face if you're able to, so that the parliamentary committee can see you. Okay, I don't think we're able to show your face, Doris. Tim Tucker, are you on, Tim?
I am, and I think the members will be able to see me.
So Tim Tucker is the head of our HR committee. We have Mzi. I saw you come in, Mzi. Can you just show your face? No, not you. I'm not this Mzi, the other Mzi. Yeah. Okay, I did see him come on, but I think we might have lost him. Emmanuel, are you on? They may be coming on still, Chair. And then Dorothy Koza, are you on? And Tahir Pillay. So I'm not sure if they probably will be coming on during the course. Some of them said that they may be a little bit delayed, but those are our board members. And Chair, as you can see, we have our EMC room and we have some of the other executive management committee members on screen because we're always worried about failure to be able to do this sometimes when our EMC room fails. I'm actually at Curtis Ski Hospital today, so that's why I'm not with the team at the EMC. So I'm very excited to present our annual report of 2022-2023. If you can have the next slide, Mongezi. So first of all, the MRC does have a history and health statement. We were established in 1969 and during apartheid, and so we want to know that the MRC does recognize the catastrophic and persisting consequences of colonialism and apartheid, and acknowledging our historical role and silence during apartheid, we commit our capacities and resources to the continued promotion of justice and dignity in health research in South Africa. And you will see throughout our presentation that we hold ourselves true to this health statement. Can I have the next slide? So we're going to have 5 parts to this presentation. I'm going to do the first 2 parts. I'm going to hand over to Mongezi to do performance, and then over to Philip to do the financial information, and then we'll finish on the stakeholder engagement. So can I have the next slide? So all of you know our job is to improve the health and quality of life in South Africa, and we do this through health research, development, and tech transfer. We want to advance our nation's health and quality of life and address the inequality by conducting relevant and responsive research, as well as addressing capacity development, innovation, and research translation. Our values are pioneering, excellent, respect, partnering, integrity, and citizenship. We have the next slide. This is our board member.
Wait just a moment. My bandwidth seems to be low. I've been reminded if I do get cut off, Honorable Gela will just take over and I'll come back, but hopefully I don't, just to inform you.
You want me to take off my video? Will that help?
That will help, yes. I think you should.
I'll do that. So this, okay, maybe everyone put off their videos so that we can see this. So this chair is the span of our our financial year. These were our board members that ended on the 31st of October 2020. And on the right, you can see our new board members, some of which are online. Can we have the next slide? This is our Executive Management Committee. I'm the CEO and chair of the EMC. I have Liesel Zuke, who is the vice president, Mongezi, who is our chief operating officer, Michelle, who's in Senegal, who's head of JIPID, and Torza Baum, who is our HR executive, Nick, who is being replaced by Wizi. Is he here? Sibu, are you here?
Yeah, yes.
Okay, I will introduce you later to him. Z, right at the back there in the EMC room, and Angela, who's our transformation director. We just want to thank the minister for sending us a letter to acknowledge our clean audit. And we're really grateful for the support that we get from the NDOH and the Parliamentary Committee. So I'm now going to go to human resources. So this is the profile of our organization. We have 718 people, of which the majority are African, 21% are colored, 11%, just under 12% are white, are Indian, and under 8% are white, and we have about 3.5% foreign nationals. Next slide. Most of our employees are women. And you can see the next slide, Mongezi. And this is our senior management by race over a 3-year period. And you can see that our senior management profile has changed over time, and it reflects the transformation of our organization. And you can see nice representation. A fair split between males and females in the senior management. Next slide. And then this, by looking at our executive management period, you can see the split over time from 2020 to 2021, and now quite a nice and diverse EMC that we see currently. Can we have the next slide? And then also by gender, you can see that the women predominate in the executive management, which is a very good sign that senior levels having more women. I'm talking a little bit about transformation of the MRC. Can we have the next slide? Starting at the board, you can see in 1969, you can see what we look like as an organization. And then in 1988, transformation starts to occur. And now you can see currently what our board looks like at this moment in time. Next slide, Mongezi. And also looking at our senior management executive committee, you can see that in 2014, there were 67% white EMC members and 17% Black Africans with 33% women. And just moving forward over time, you can see that we've transitioned to around 63% of our executive management committee being women, 25% white, 25% colored, and 50% Black African. So a lovely story of transformation since 2014, since I started at the MRC. Looking at our extramural units, can you move on? You can see that we've also managed to diversify our extramural units. We made a special call for female unit directors to address the issue of lack of women representation in senior leadership. And then again in 2021, 2022, we had a specific call for Black African extramural units, and we've been able to increase the diversity of our extramural units at the universities, and also increase the representation of our provinces in the extramural unit space. Can I have the next slide? This just shows you the expansion from what we saw in 2014, 4 extramural units, to 2024, 14, and the representation of the various entities from the University of Venda, right down to CPUT and the University of Fort Hare, which was our first extramural unit in a historically disadvantaged institution. Can I have the next slide? Yeah, we just see the EMUs by province, noting that Free State and the Northern Cape don't yet have extramural units. Can we have the next slide? And then just shows you the increase of our extramural units at historically disadvantaged institutions, showing our commitment over a 10-year period to the establishment of research capacity in HDIs. Next slide, Mongezi. And this just shows you our publications. Both intramural units and extramural units are very prolific and contribute more or less equally to the amount of publications that we have per annum. But you can see since the time of 2014, when I started, to 2021, 2022, you can see a huge increase in the amount of research output by our extramural units. Just beautiful to see. Thanks very much, Mongezi. Next slide. Just a picture of us launching our 4 new extramural units last year, this is when we had the specific call for Black African research units that were established. Next slide. Looking at our transformation in the distribution of scholarships and research grants, can we have the next slide? We have a research capacity development program that gives both scholarships and research grants. And in terms of our scholarships, we have both the Bongani Mayosi National Health Scholarships Program, the Clinical Researcher Program, and the MRC Internship Scholarship Program. And this, as well as a Researcher Development Program and a program that has specialized training in vaccinology. Our research grants include intramural postdoc programs, clinician postdoc career development, mid-career scientist program. And here we try and also ensure that we develop early career scientists. We have special initiatives for historically disadvantaged institutions. And we also have a nested program at 2 universities, a MD, PhD program that we run to try and increase the number of clinician scientists. This shows the increase in research funding allocation over a 10-year period, and shows you the amount that we've given out to institutions and grantees from around 10 million at 2.5 million 2.5 million for 10 recipients to 35.7 million and 73 recipients for for research growth. Next slide. This just shows you the scholarship recipients by population group. So we spent a lot of time looking at who we fund, where we fund, and yeah, you can see the growth over a 10-year period of Black African scientists receiving grants as compared to white people receiving grants in the MRC. Next slide. And this shows you the number of recipients of research granting funding, again, by population group. And you can see a 230% increase in Black Africans receiving research grant funding. Thanks. Next slide. And this just shows you the gender. We are female predominant, but that reflects the health sector, which is mostly female in profile. Next slide. This shows you our expansion from 2014 to 2024. You can see we've expanded from 4 institutions to 15 over this 10-year period. Next slide. And then just in the institutional recipients, you can see the geographical representation that has grown quite remarkably from 2014 to 2023, showing much more geographic representation. This shows our overall distribution of MRC scholarships by ethnic group and gender. Again, showing you the predominance of women who receive our grants, but also showing the increase in Black Africans receiving grants over time. Thanks. Next slide. This shows the distribution of MRC scholarships by institutions, showing that UCT still gets the lion's share of awards, but that we are seeing the emergence of new entities like Univen, University of Limpopo, University of Johannesburg, Northwest, and TUT. Can we have the next slide? Looking at performance allocation, I'm going to now hand you over to Mongezi to do the performance information.
Thank you, the President, and thank you, Chair, and the honorable members. Just quickly to take you through the audit report that we see from the Auditor General, looking at 4 areas. One is the financial statements, where they indicated that they obtained sufficient and appropriate evidence in terms of the opinion that we got a clean audit, and they looked also at the annual performance in terms of the predetermined objectives, and they also could not find any material findings. Similarly, on the compliance with legislation, as well as the internal control and deficiencies. So quickly to take you through our strategic plan and annual performance plan, we have 5 programs, which ranges from administration, leading generation of new knowledge, innovation, capacity development, as well as research translation. I'm happy to state that under administration, we managed to get a successive clean audit, the 1st one. It's the 4th one during the planning period. So we are going on to 24-25, and we're also hoping to get a clean audit as well for 2023-24, as well as 24-25. Similarly, in terms of our outputs, the President has indicated that the output has increased. I'm happy to indicate to the Portfolio Committee that we have exceeded the targets that we had for Program 2. Similarly, for Program 3, there's only one area where we met the target we did not exceed. That's the 3rd indicator on disclosures. So we had a target of 1, and we did get 1 disclosure. On the capacity development, which is a Program 4, we have achieved, we have about 5 indicators there. So we managed to exceed the targets for 4 indicators out of 5. And the 5th one is all about the HDIs, and we've been struggling to get to meet the target. This is the 2nd successive year that we haven't met the target. And the board asked us to do a SWOT analysis on this one, and we've done the SWOT analysis. And the idea, as the President indicated, is to increase the number of HDIs receiving grants from the MRC. The research translation, Chair, we also exceeded the targets that we set for the research translation, which is Program 5. Not only do we go with the publications and don't make sure that the publication is easily accessible, we have subscribed to an open access, a coalition S. So we make sure that the publications that we put out in the public, they are available. So we can see, Chair and honorable members, that we have an increase in the open access publications that we do. So we do set aside a money funding our researchers to publish on open access journals. And then not only do we look at the publications, but we also have to look at the impact in terms of policy. In some instances, our outputs do not have an immediate policy impact. However, they do contribute to the policy impact. So you will see that we've got about 3 slides where we're indicating the impact that our publications have. This one where the publications from the Office of the President and Vice President, we've got 2 publications there. The second one is our Ashabi Madi that you've seen a lot quite during COVID, that vaccine and infectious. The third one is our Cochrane, which is doing rapid reviews, which was quite helpful during the COVID. The fourth one is our burden of disease that they are doing. They're looking at excess deaths that also happened during COVID. And then HIV and TB pathogenesis. You would note, Chair, that during COVID, HIV and TB treatment, it became quite a little bit of a neglected diseases, and the President will present something later on around HIV grant that we received. And then also looking at the TB, we have our Center of TB that's in conjunction with MRC and University of Stellenbosch, and also not forgetting the non-communicable diseases. So we have to look at the intersection between communicable diseases and non-communicable diseases. So, Chair, I'll hand over back to the President to continue with the funding.
Thank you. So this just shows you the complexity of our funding programs in both in grants and innovation. We have strategic projects. We have MRC grant programs. We have good partnerships, and we also have a generous grant from the DSI that helps us do innovation. And we're just happy to say that DSI has just renewed their grant from us. We take commercialization and access very seriously, looking at tech transfer as well as expansion into digital health and our Global Health Innovator Accelerator, where we work with TIA to do this program. Can I have the next slide? So I mentioned SHIP before. SHIP has been generously funded by the DSI, and that this partnership helps us facilitate and support health innovation, which addresses the national priorities and enables the national system of innovation more broadly. It spans a portfolio of over 50 projects, and this is TB, HIV, maternal and child health, malaria, antimicrobial resistance, COVID-19, and non-communicable diseases. There are 18 female-led projects and over 50 postgraduate students that are supported. And DSI has also contributed to the funding of our mRNA hub, where we're trying to develop a vaccine technology and through our SHIP program. And we manage all the funds and projects by the MRC, and we have DSI represented on our executive management steering committee on this. The projects that are funded through SHIP focus everything from treatment, diagnosis, prevention, digital health, and precision medicine. And in all these areas, as I've mentioned before, from HIV to non-communicable diseases to COVID-19. Can we have the next slide? Our other programs include TB implementation, the MRC TS Seed Fund that I spoke about, Project Gradient, when we're looking at genetic diversity in Africa and its effect on drugs for TB and malaria. We have a big grand challenge program with the Bill and Melinda Gates Foundation, and we have just launched a new core for climate and health that's going out this week. We have some strategic projects, one looking at hypoxic ischemic encephalopathy in infants born in South Africa. We're looking at traumatic brain injury as well, and endogenous medicine-based medicines, as well as this multi-country Healthy Life Trajectories initiative that looks at innovations to prevent childhood obesity across India, China, South Africa, and Canada. COVID, we've done a lot of work in wastewater surveillance and looking at pandemic preparedness, as well as COVID clinical studies, vaccines, therapeutics, surveillance, and epidemiology. We helped with rapid COVID diagnostics, and we've invested heavily in the basic science, community engagement, and lately the mRNA vaccine development and manufacturing capability in our country with Afrigen. Can we have the next slide? These are our strategic research initiatives. We work with the NIH, where we have a program to do joint collaboration between US and South African scientists. We have the global development for antimicrobial to develop antimicrobial drugs for antimicrobial resistance. We have the BRICS collaboration, where we look at antimicrobial resistance as well as TB. We have we co-host a program with EDCTP, and we do co-funding with malaria and HIV. We have a partnership with India on HIV and TB, a partnership with Sweden on the inequalities of health systems and health policy and health systems policy. With Global R, it's a new collaboration on a pandemic preparedness, and with the Secretariat for Africa. The Global Alliance for Chronic Disease is important for implementation science on chronic diseases. We have a relationship with BGI to do genomic sequencing in South Africa, and also an EU-African partnership where we look at personalized medicine for Africa. Can we have the next slide? Thank you. Thank you. So I've mentioned this already, our innovation programs together with TIER, where we're trying to commercialize our intellectual property, looking at digital health, and also working with PATH to have diagnostics. And then this program, as I've mentioned before, funded by TIER and DSI, where we're looking at medical devices and diagnostics in South Africa. Next slide. So looking at our research and its impact at a glance, just quickly, we're going to go through this. As you know, we have 4 intersecting or colliding epidemics in South Africa: a non-communicable disease, a communicable disease, and a still childhood and infant deaths and maternal deaths, as well as violence and injury. So we focus on these intersecting epidemics, and we look at population health systems, research setting health systems, as well as disease and disease mechanisms in order to address this quadruple burden of disease. We've spread out to make sure that we're covering everything. We have 10 units on health promotion and disease prevention, 4 units on maternal, child, and women's health, 4 units on HIV, TB, and other communicable diseases, 6 units on health strengthening, 4 units on public health innovation, and 9 units in biomedical research. Can we have the next slide? And this shows you the spread across the whole country. 11 intramural units that focus on causes of death, our platforms at our animal facility, our biomedical facility that's looking at drug discovery, our genomics center, our malaria research group, our extramural units that I've already spoken about at various universities, our strategic research initiatives that we work with partnerships in, our grants and innovation, and our research capacity development. So we're trying to span the whole area of medical research and capacity development and all the entities and all the issues that we face. I wanted to highlight some important programs which will move forward into pandemic preparedness. And the one is the wastewater surveillance that we established during COVID and our expansion to the various provinces. This has worked very well. It served as an early warning system during COVID. We continue to do surveillance, looking at new variants, as well as extending our remit for pandemic preparedness, looking at other pathogens like cholera, polio, measles, antimicrobial resistance, and looking at specific surveillance in hospitals as well. So this just shows you the kind of work we've done and the ability to work as an early warning system for COVID in the past, and also now looking at cholera and other issues. So just a shout out for them. A lot of research that we were able to do, and we were able to look at variants of concern. We were able to use PCR genotyping, and we were able to get results in 24 hours. We were able to detect the beta variant, the emergence of Delta, and also the emergence of Omicron. Next slide. In terms of going forward, we recognize the lack of vaccine manufacturing on the continent, and we've been able to collaborate with the World Health Organization to support an mRNA vaccine platform in South Africa, together with WHO, the Medicines Patent Pool, and COVAX. And we're working with Afrigen, who are establishing the innovation and will transfer the tech to BioVac once we have our mRNA. This Afrigen serves as a program to support other mRNA platforms throughout the world. Can you have the next slide? We also found when we were establishing these vaccine programs that there was a lack of vaccine manufacturing capability in South Africa. And so we approached the Patrick Soon-Shiong family foundation, who've given us a 100 million rand to develop capability in vaccine manufacturing, studentships, internships, scholarships, and fellowships. And we've been able to train about 150 to 200 undergrads. We're supporting 20 to 30 MSc PhDs and 1 to 5 postdocs. The good thing about this program is that it also has allowed for people to become employed in the vaccine manufacturing and drug manufacturing systems in our country, like BioVac and Aspen. I'm going to go to the next slide. As I've mentioned, this is a commitment of 100 million rand, and we've started this training already in February 2023, and things are going very well. Can we have the next slide? In addition to the WHO and the Patrick Soon-Shiong support, we also have the support of KfW to produce vaccines in South Africa. So this is a 20 million euro grant allocated by the German government to South Africa. And we're able to focus on 4 areas. One is the financing of the 2 pilot plants for the production of mRNA-based vaccines and non-mRNA-based vaccines. Focal area 2 is financing vaccine technology training. Focal area 3 is the financing of lab equipment and research facilities for vaccine development and related infrastructure. And the focal area 4 is the digitalization through IT infrastructure and software. So you can see a great expansion of innovation, particularly in the area of manufacturing with KfW. We've been chosen to be the project execution agency because of our clean audits and our ability to manage big funding, and we will support the R&D infrastructure for vaccines in South Africa together with the DSI. And it's a very exciting program, and we hope to be able to report on it in the next year. Can we have the next slide? And then I just wanted to also acknowledge the Network for Genomic Surveillance, which was established during COVID, supported with the Department of Science and Innovation to monitor the emergence and spread of SARS-CoV-2 variants and to enable a response. We've been able to work with immunologists to help us with understanding the neutralization escape, to help us work on a vaccine approach. And this network has advanced scientific excellence, has done a lot of publication, has supported the work throughout the region, outside South Africa, and is going to be involved in future pandemic preparedness. Just recently, we were awarded a big grant from USAID for HIV innovation. We call it the Brilliant Consortium, which is bringing innovation and clinical and laboratory research and to end HIV in Africa through new vaccine technology. And this is a very ambitious program where we are going to identify immunogens, identify adequate vaccine platforms and adjuvants to manufacture HIV vaccines, to evaluate in the preclinical and the clinical region. This is worth about R1 billion, 46 million US dollars over a 5-year period. And we will lead this program, and we have partners in Nigeria, Uganda, Kenya, Tanzania, Zimbabwe, Zambia, and Mozambique. Can we have the next slide? I'm going to move over to Philip, who's going to take us through our financial information. Philip, over to you.
Hi, thank you, Glenda. Good afternoon, honorable members. I'll take you through the financial information. Our statement of financial performance for the period ending 31 March 2023. For the financial year 22-23, our revenue increased by a very low percentage of 0.2% from 1.267 billion to 1.270 billion. And that is mainly due to the low increase or the decrease of our baseline allocation for 22-23. Other income increased substantially by 59.1% from 17.6 billion to 28 million. And that's mainly due to increase in our forex gains for the financial year due to the depreciation of our currency. That then leads to operating expenses of 1.333 billion. That's an increase of 2.1% on prior year, with an operating deficit of 34.3 million. Investment income increased substantially from 25.7 million to 42.5 million due to the higher interest rates that we're currently experiencing. And then there was a fair value adjustment of other assets of 367,000, finance cost of 293. That gives us a surplus for the 22-23 financial year of 7.5 million versus a surplus of 6 million in the prior financial year. Now, if we look at the variances, our total income increased by 2.19% to 1.341 million. And that's made up of our baseline that decreased by 8.48% to 677 million. Our contract revenue increased substantially by 12% to 593 million. Rental income decreased, and our investment income, as previously indicated, increased by 65.4% to 42.3 million. And the reason for that growth in our contract revenue can be accounted to the value of new contract that we signed for the financial year, and that came to about 678 million for the current financial year. Our expenditure increased by 2%. That's more or less in line with our revenue to 1.333 million. And the big ticket items there will be, there's a slight increase in our collaborative research, but you can see that post-COVID, our travel costs increased by 81% to 45 million. And this is not just flights, but this is the increase in research activities, as well as you get participant expenditure that's also allocated under the travel costs. Lab costs decreased by 4%. Our staff costs increased by 10% due that can be linked to an increase in our contract revenue. And then consulting costs decreased, as well as our audit fees. Now, this graph shows us how we track our revenue and expenditure. And as you can see, over the 6 year period, it actually tracked each other very closely. As you see, for the past 2 years, we're almost on a break-even point. That leads to a 7 million surplus for the current 22-23 financial year. Now, our revenue growth. The baseline, that is the blue line right on top, you will see from 2019-20, there was an increase to 2021, and that was due to a once-off allocation from National Treasury for COVID. This is during the COVID period of 150 million. In the 2021-22 financial year, there was another once-off allocation of 100 million from National Treasury for COVID studies. So that those allocations didn't pull right through our baseline allocation. And for 22-23, there's a drop in our baseline allocation. Now, if you look at for the same period, our contract revenue in 2020-21, there was a decrease in our contract revenue, and that's mainly due to the reduced activities of research during the COVID period. That was right at the start of the of COVID. And since then, over the past 2 years, there was a steep increase in our contract research. So over that 3-year period, our baseline grew by 13%. That's at an average of 4% per annum, whereas our contract revenue grew by 19%. So that's an average of 6% per annum. So if we compare our baseline versus contract in 2022-23, the baseline constitute about 53% of our main revenue and contract revenue 47%. As you can see, it's actually getting closer to each other. The next slide shows our baseline allocation grants excluding VAT over a couple of years. And if you look at the 22-23 financial year, there was a drop from 740 million to 677 million, with an increase in the 22-23 financial 23-24 financial year to 692 million. As you are aware, that National Treasury is currently looking at budget cuts, and it seems to me that our budget cut is confirmed for the current financial year to reduce our budget by 33 million. That's a 4.8% budget cut to 659 million. And then for 2024-25, the original budget allocation was 724 million. Based on information we've received, we may get a budget cut of 10%, which will reduce our baseline allocation to 652 million, which is lower than the revised budget for 2023-24. Now, this downward trend for the baseline is definitely not a healthy situation for the MRC. This means that contract research can dictate our research agenda. Although contract research is a very important source of revenue for the MRC, it assists with the generation of new knowledge. It funds about over 300 posts at the moment, but we feel that it's the government subsidies should dictate our research through adequate funding allocation for priority research areas. So this budget cut may even impact our strategic research initiatives that Professor Gray previously mentioned, with different partners and initiatives throughout the international community. Thank you.
Back to you.
Okay, so I just want to show you, as part of our objectives is research translation, which and part of the indicators is our stakeholder engagement and social responsibility. So we are involved in various corporate social responsibilities and campaigns that we have, where we've donated laboratory equipment, where we've been able to give furniture to schools, and we've been able to climate proof some of the schools, and we'll show you pictures of those. Next slide. This shows you our campaign for a food drive during Mandela month, for Mandela Day, and this was a month drive where we collected food for various communities. Next slide. We obviously are concerned about climate change and the impact of pollution on our environment, and this is just shows where we were able to volunteer on International World Environment Day. Next slide. This shows you our commitment to growing the next generation scientists, and we have a Youth Month generation program where we bring young people interested in having a science degree to come and learn about lab methods and about science. And here you can see them engaging with our postdocs and with Rob Warren, who is the head of our TB program. Can I have the next slide? And this is the World Diabetes Day and an awareness walk to try and raise awareness around non-communicable diseases, particularly diabetes. Next slide. And then I mentioned our program to climate-proof schools, Yeah, you can see we've installed special water drinking areas far away from the toilet area, and also operated by using your feet. You don't have to use your hands to get the water, as well as shading areas for kids that they can sit under during lunch, and also you can have your classes outside without it being rained on. Next slide. And then obviously we always commemorate World AIDS Day, and this is just a program that we had last year on the 1st of December at the MRC around World AIDS Day, highlighting the issue that HIV is not yet under control in our country. And then other stakeholder engagements with various countries, trying to facilitate bilateral programs to do research in all parts of the world, from Africa to Europe and to our BRICS countries. Next slide. Our Heritage Day, we celebrated Heritage Day as a way of supporting our internal values, and also to create a feeling of belonging in our organization. Next slide. We've had, we've tried to increase our bandwidth on digital platforms with 135 million hits this financial year, 120,000 hits on Facebook, 280,000 hits on Twitter, ex-Twitter, and 760,000 hits on LinkedIn. Next slide. And then just to say, as you know, I've done 2 terms as the president of the MRC. It's been a wonderful opportunity to serve my country. And after my term ends at the end of March next year, and I'm stepping down, we're advertising for a new president in October this year. We hope to be able to name this person at the end of October, early November. And I just want to thank the South Africa, the Department of Health, the Portfolio Committee on Health, my board, the EMC, the research bodies, our regulatory authorities, and everyone we've worked with. And just to know that I won't be leaving the MRC. I'm going to focus my efforts on HIV vaccines, on vaccinology, and working in the HIV program. So it's been a wonderful journey, and I just want to appreciate the trust that's been given to me to lead this wonderful organization, the MRC. Thank you very much. Just to acknowledge the passing of Jerry Kuvadia. He was a pediatrician like myself. I've known him since the mid-90s, and I was fortunate enough to be able to give him an award in 2014, and this is just to acknowledge him and to commemorate what a great scientist he was, and a dear friend and partner of the MRC.
Thank you very much, Professor Gray.
And then just to wish the rugby players luck on Sunday. And one more slide. Where's our slide? Our last slide. And just to thank everybody. And we're happy to take questions on this APP.
So my very first question would be, did you give the Springbok players some performance-enhancing drugs? Because surely it's a trick question. Don't answer that question. We seem to have even having challenges with the WADA, World Anti-Doping Agency, and questions around our participation at an international level. So please don't put your foot into that one. Thank you very much for the time, Prof. Gray, that we've been able to spend with you while you were president of the SAMRC. And it's always been wonderful to listen to the SAMRC, not meaning that everything that you have said we always agree with. I'll tell you where I don't agree with you later on. But We wish you well in your search for a successor, and we hope that that successor will be able to do what you have done over the number of years. And also good to know that you will stay within what you like best, which is the research environment, and that you would be able to continue to contribute to research in South Africa. And to your team also, I see them over there. I don't know whether any of them had won any grant or scholarship to go and watch the quarterfinals and hopefully the semifinals and the finals. Because I was looking in your presentation, but I don't see it. And I definitely don't see my name as one of the grant recipients to go and watch the rugby in France. But I understand why I shouldn't get it. I will leave over to the members to raise some discussion points and questions with you. And then I also have a number of things which I would like to raise. And I'll take the order now. It's honorable members Gela, Clark, Hitland, Kaba, Chirwa. Gela, Clark, Hitland, Kaba, Chirwa, Harvard. Anybody else? Any other members who want to ask any questions? Have I missed out anybody? I'm just double checking. No. Maruwane. In that order, thank you, honorable members. Please proceed.
Thank you very much, Chairperson. Let me welcome the presentation from MRC. Indeed, Chairperson, we worked very well with MRC. And really, when the president is saying that is serving the last term as a president and the term of office is ending next year, March, it's sad news, I must say, but we understand, Chairperson, that there is that time, but we hope that we'll get a good person in that position as a president. But really, it was good to work with the MRC, especially Dr. Linda Gray. Chair, coming to my observation, Chair, is that we see that they got unqualified audit outcomes, which is a clean audit. We really welcome that as a portfolio committee. And 78% of staff are female, and 55 of the staff members are Black. The entity has a diversity bias in senior management with more women, but a slow growth of the historically disadvantaged. This indicates, Chair, the need for continuing effort to ring-fence appointments of historically disadvantaged persons, recognizing the equity which prioritizes Africans. The executive management is relatively representative, as reported in the previous audit, with the majority being females. The grant allocation and recipients receipts have increased, and the number of recipients has decreased or declined, which can be caused by various factors, as grant amount requested here. Welcome that the majority of grants are allocated to female accepted or published outputs by SAMRC affiliated and funded authors outcomes has more than a double than target from 700 to an achievement of 1,455. The entity's actually performance exceeds set targets in main indicators, questioning the credibility of planning whether entities set soft landing targets or not. This chair is worsening by the fact that the targets are less than those of the year before the review period. Now, Chairperson, as I've raised my observation, but also we are proud that this entity gave women an opportunity to lead. And really, we are saying that it's a good story to tell that this entity has done. And we really appreciate that, Chairperson. But coming to the questions that I want to raise, Chair, which are very key. One is that the COVID-19 pandemic has demonstrated that disaster readiness is a critical capability the state should have. And the MRC played a critical role in shaping the disaster response of South Africa. My second question, what work has the MRC done to strengthen the country's capability to respond to pandemics? My last question, Chair, noting and welcoming the increase in a scholarship for African to 77.44%, but we are concerned about the decline of colored, currently at 9.18%. What is the ideal equitable distribution, and why has there been a decrease in the number of students who are colored? Those are the questions that, Chairperson, I'm submitting. Thank you very much, Chairperson.
Thank you, Chairperson. Yes, I want to echo Member Gela and the Chairperson's congratulations to Prof. Gray and her team. I always look forward to this presentation because of the good work that is done by your team. And we wish you well in your new endeavors. And thank you for your great leadership during this period of time. A couple of questions I would like to ask. I would like to know if the MRC is at all involved in the WH and the AMA treaties, and if so, could you just give us some background on that? And then also to ask, could you share the study outcomes by the burden of disease research unit on the excess deaths versus confirmed COVID-19 fatalities? And if any investigated claims in terms of COVID vaccines causing adverse effects in some people have been done, and what are those outcomes? And then amongst the non-communicable various cancers are alarming, and what interventions is the MRC making in this regard? Then just in terms of your grant recipients, how many people, how many of these students are absorbed by your organization once They finalized their training. And then just to ask you, have you done any investigation in terms of the health risks around tobacco products versus e-cigarettes and vaping? Because we're busy with the tobacco bill at the moment. It'd be very interesting if your organization, if the MRC organization has done any comparatives in terms of the health risks. Thank you very much.
Thank you so much, Chair. Professor Gray, it's many, many years since I last saw you. I think the last time I saw you, my son was 18 months old. He's 32 today, 33. So it's wonderful to make contact again. Congratulations on a sterling report. And I'm sorry that as I join the Health Committee, you are going to be leaving as president of MRC, but I hope that we will still continue to do some work together. One thing I wanted to highlight from the SWOT analysis that I read was a funding threat for research, especially research qualified as low priority on the political agenda. As Professor Zulke will let you know, I'm no doubt, I have an absolute passion about RHD, rheumatic heart disease. And this seems to be a low priority on the political agenda. And how are we going to address that as the portfolio committee? It's something I'm very passionate about and something I really want to address, particularly with pediatric cardiac interventions. Continuing on to your publications and journal articles, there seems to be a drop in the number of published articles and in the number of accepted and published articles and authors. Do you have any reason, do you know any reason why people are not asking or not publishing journals or journal articles? Going on to your financials, how are you going to mitigate the baseline grant decrease? What mitigation structures or what mitigation measures do you have? Another question, the private labs that were used during COVID or during any other studies that you have done, why did you not use the NHLS? They are part of the same family, so to speak, the Department of Health. One last question, are you working on any skills transfer that is going to happen between the partnerships that you have with international organizations and the MRC to ensure that should those partnerships end, a lot of the skills that you are getting from them remain within the MRC and then get translated and are absorbed in South Africa, other than through the bursaries and scholarships that you sponsor? Thank you so much. I will leave it there, Chair. Thank you.
Thank you, Chair. Chair, I think I'm joining Honorable Geller in commending the President, I think, upon the women majority composite of the MRC. I think that is welcomed and indeed commended. You know, in the revolutionary word of all that encompasses all, one could say Malibongwe. And then in continuing, Chair, just a few comments on that. I think the MRC will also want to acknowledge, I may have yet also, Honorable Clark, having to mention that we may have had our public hearings on tobacco bill and so on. You know, I want to commend the MRC participation, though representatives came individually, but they were proud to mention they are from MRC and their contribution had content. That was clarity and welcoming and education to our nation. And we are still going forward. I look forward to more comments of you on that matter. Chair, just to ask my question, to say that why does the NTT not have scholarship allocation for University of Free State, and it is not being part of the pool of institutional recipients. You know, I'm from Free State, but I serve my country and I serve all my people. From the exposure of the MRC, what is the level of digital transformation in our health system, and can digitization play a critical role in reducing the healthcare demand in our healthcare centers, recognizing the demand-supply gap? What are the outcomes of various partnerships with countries in Africa? And does MRC leadership think the entity is optimally playing a role in the continent, noting out the challenges confronting our continent? COVID-19 has demonstrated the importance of collaboration with global linkages and continental linkages relative to the COVID-19 period. Can the MRC reflect on whether the collaboration drive has increased relative to the COVID-19 period? I submit, Chair. Thank you.
Thank you very much, Chairperson, and thank you to the MRC for their presentation. I have two main questions that also come with commentary. The 43% by people in senior management can't be noted as transformation, you know, because by definition, transformation means a dramatic change. And there is no dramatic change in the transformation, especially because the SAMRC is able to give us a historical context of why this is the case, right? It is by design, it is by apartheid design that senior management looks as it does or looks as it did, and that there's even an aspect of having to address the issue of transformation. Therefore, there should also be a democratic or post-apartheid design that is done by the SAMRC that takes shape as dramatically, if not as radically as the apartheid one. You know, the apartheid didn't even negotiate. They just did that. They placed their regime, and aesthetically it represented what the government at the time looked like and what their aspirations were. And yet we must still battle with comments of 43% of people being in senior management being termed as transformation. Like, it's manipulative, it's provocative. You know, that this is the case, especially in a country where, for the very same white people make up just the 9% of the population, of the demographics. And I'm speaking about this because you put it in the presentation, right? So it's something that you want to address, but it can be addressed with little steps. And I'll give an example of why this is not transformation as well. Because, for instance, we've got it will, with the current trajectory of addressing transformation in senior management, it will take the entity, with the current trajectory being repetitive and going on as it does, it will take the entity 15 years plus just to get to 50-50 representation. 50-50 representation, right? And we're not even talking about the evolving dynamics of the political climate in the country. We're not even talking about queer people as yet. There's still a binary that we're addressing with the entity. In 2023, we have to accept that we're being told in Parliament that 43% of white people in senior management is transformation, or is what transformation looks like in a government entity. Like, this is not it's not a private entity we're speaking about. We're speaking about something that is representative of our people, in this country. It's not even a favor. You're not doing anybody a favor by having the demographics of senior management reflect the demographics of the country. It is justice. And you know it is justice because you give us the historical context and you've got the understanding of why this needs to happen. But the pace at which you are doing it at shows that there is no political will to address it. Like if we were to compare the current leadership on transformation, on radical, transformation that represents the aspirations of government, and the apartheid government beats you guys 100 mil. It beat you 100 mil because they didn't even negotiate. They just put their white people, their white men in power, and they moved on in senior management. And it's 30 years in. We're talking about 43%. Really, it's taking 30 years to get to 43%. of still having white people in senior management, 30 years. It can't be accepted as a conversation around transformation, honestly. Please, can the next time we talk about the issue of transformation, it's either you say that, no, we need intervention, because this is also a repetitive issue that comes in and year out. In regards to the SAMRC only, out of all the 5 entities, that's by the way, this is an issue that only the SAMRC is facing, of just not doing it right, of just delaying, right? And it's not an issue of competence. So I don't want us to have a conversation of competence, because with political will comes the radical intention to make sure that competence reflects in what your intention is as an entity. And also competence number 2 is not an issue of race. So we can't say, because in this particular department, only white people, in relation to senior management, only white people can manage the entity. If other entities have been able to do transformation over the past 3 decades, surely you guys can do it as well. If you're not doing it, then you must put in more work and make sure that this happens. It's unacceptable. Honestly, we're having this conversation and then being told that this is transformation. Guys, honestly, I don't accept this as what the SAMRC is achieving as transformation. For the past, this whole administration, when the SAMRC comes in with this particular aspect of dealing with this particular thing in the committee, the issue of transformation has to come up. The issue of transformation has to come up. And now we can't even look at the positive side, because now, well, this is provocative. If we can get the women thing right, why can't you get the race thing right? Yes, exactly. If you can get the woman thing right, why can't you get the race thing right? Right? And then second to that, on the issue of women, because I don't want us to denigrate to making the issue of representation being the overall, right? If we're going to acknowledge that women are, that we should put them in position of leadership and all of those things that you guys are doing quite well, it should also be reflective also in the work output that comes out from the entity, right? Especially in relation to the research based aspect of the entity. Issues like obstetric violence, prevention, education should be prioritized by the SAMRC, especially because the representation compound is as it looks like, right? And the majority of people that access public health care, as is today, are women and children. So even the work output that is done should be reflective of the issues that are centralized around those vulnerable groups that remain vulnerable and that are most experiencing the harshness of the public healthcare sector, for example. And this is reflective in litigation cases, it's reflective in how obstetric violence keeps on going up, it's reflective in how, for instance, issues of infant mortality, on issues that can be avoided. The fact that our children are still dying because of hypoxia in public hospitals because there is no facilities or capacity to increase C-sections and stuff like that. And I've been speaking about this the whole day because it's now a human rights issue that women go back home without children or with permanently disabled children because the public healthcare sector does not have enough capacity to carry out what it needs to do, as opposed to the private sector. And in the same conversation, we even look down on the private sector and say they're prioritizing profit, which is not wrong. But in relation to the issue of C-sections, for example, there is something that I think the research compound can come in with to tell us, no, but this is now a requirement, or there's a growing need of these particular, I don't know how to term it, these particular procedures, right? Because of 1, 2, 3, and 4. We should be getting answers from you guys on why that as other parts of the health sector is improving or maybe remaining stagnant, why this part is regressing and getting worse and worse, even in cosmopolitan areas, in Gauteng, even in places that have the eye of the NDOH, where they've prioritized intervention strategies. And why is it still a problem that cannot be solved and keeps getting worse? You guys must give us those answers. And tell us, no, it's because 1, 2, 3, and 4 scientific answers to scientific questions that we want, that are centralized around the issues of women, of girls and children, especially because your work personnel looks as it does. So because then there's no benefit to the general population if you've got 90% of women in your work personnel, and yet none of the issues that affect women who make up the majority of accessing public health care or having health needs is addressed in what your research output is. And I really am saying this with the utmost genuineness and utmost humility, because it's something that I think we should really look into, because we really term this as a human rights issue that should be looked into, especially because the knowledge and the prevention methods around that are not highlighted, are not hyper visible. And the SAMRC, and maybe you have done work like that, you can appraise us on how you prioritize majority of your work output on this particular aspect. You can appraise the committees. Just I didn't pick that up in the presentation that you gave today. And I'm putting this particular pressure because I'm aware that the SAMRC is able to respond around the clock, right? So if there's a pressing issue, if we're dealing with COVID, you're able to say no, but this is how we were catalysts. This is how we were visionaries. This is how we were able to go, beyond the call of duty. This is how we were able to improve the conversation. This is how we contributed to the scientific development of knowledge, right? Even on a global scale, on a global level, right? But this is not reflected in issues that I'm talking about right now. And especially because you look the way you do. If you're going to have women, please, let's see the impact of having women leadership. Let's see the impact of having majority of women being your personnel, because the women of this country, they need it. We've got women who are still forcefully sterilized in this country, in South Africa today, because they are Black and because they're HIV positive. That is the reality. That is the reality that we are living with. And the SAMRC should be coming up and telling us, this is why, this is what's happening, this must change. And then we can also start pushing those kinds of solutions that you're bringing us or bringing forth to us, and that is obviously up to you on what you prioritize, even as what you bring into the portfolio committee of health to say, okay, but these particular issues should also be spearheaded beyond just representation or aesthetic representation. There should be a grounded foundational representation as well, because the people of this country need it. Thank you, Chairperson.
Thank you, Honorable Chair. I just firstly welcome the full representation from MRC. Also, congratulations on the current President's wonderful leadership. Wish her all the best for next year. Today, I just have two questions. First one, in relation to the training of health practitioners, has the MRC conducted research which assesses the curriculum and the training of health practitioners? Second question, how has the entity institutionalized lessons from its approach during the COVID-19 pandemic? I thank you.
Thank you. Thank you very much, Chairperson, and also would like to welcome the presentation from the MRC, which was comprehensive. Chairperson, I've got few questions that I will want to ask. The first question I'm posing, what led to the doubling of accepted or published outputs and for accepted or published outputs by MRC grant holders, acknowledging the fact of MRC as presented, and why did the entity materially under target? What are the determinants of targeting for this performance indicator? That was my first question. The second question that I have, what led to an increase in MRC's new innovation technology projects, and what funding increased the number of projects from a target of 4 to an achievement of 20? The next question, Has the decline of the revenue impacted the performance of the entity, recognizing a number of overachieved due to lower targets? The question, what lessons has the entity learned in the year under review in relation to optimizing budget allocation and leveraging research contract income? And my last question, Chairperson, that I want to pose, what is the projected impact of the possible cost containment and the declined budget allocation? And will the department's plan be implemented negatively? Thank you very much, Chairperson.
Thank you very much, honorable members. Yeah, there was a bit of a strong sentiments expressed, and I also sentiments which I want to express. But at some time, these topics need to be raised so that we are able to move forward. Now, the Freedom Charter says that everybody, South Africa belongs to all who live in it. And at some stage, we can see when people express their views, and now I'm not referring to anyone in particular. One can see the anger and emotional and mental challenge, and it also is reflected in the physical harm which people had suffered within South Africa. Many of us carry the scars for many things which were done to many of us. And the question then is, when I look at the slides which are presented, and so many of these slides, and I'm going to agree with Honorable Chirwa, was about transformation. And when I look at all of those number of slides, I ask myself, is it really necessary that we speak so much of transformation 27 years into the democracy? And what necessitates it for us to have this kind of discussion? Because you are the SA Medical Research Council, and your mandate is, of course, to ensure good quality research is performed within South Africa and collaboration with internal and external partners. But I want to tell you a short story, and I want to take this bit of time. When I was a fifth-year medical student, there was a particular professor, and he was a professor of forensic medicine, who insisted that I use a terminology which at that time I was, and in fact even today, when it is used, I cringe. When somebody uses the word colored, I cringe. Because it is something through which we have learned through the Black consciousness movement that we were going to do away with this thing called race in South Africa, and that we were going to have an opportunity for everybody to be able to prosper and advance in a free South Africa. Now, unfortunately, it doesn't work that way. Because we know, firstly, there's this huge economic inequality. We have people who are devastated and struggling to make a living. And so is that the necessity of, the real necessity why it's needed for this to be discussed at such length? And you would remember I've touched on this last year, and in fact, the last two presentations, I keep asking the same question. And I'm going to ask this question again. And I'm going to put it differently. In fact, I want to complete what the professor did to me. So bones were found in the forest in Knysna, was brought to the medical school, and then we had to examine the bones, as you know what we do in forensic pathology. And then the professor asked, what race do we think this person is? And the answer was colored. And I refused to answer that. And I was put out of the class. So I took a punishment, a very bad punishment. It was not a good thing. It was not a good experience, but I was put out of the class because at that time I refused to speak in these terms. Because at what stage are we going to advance? Now, it brings me to what has been presented. At what stage will these young people who are born after the Immorality Act has been cancelled. What is the word? There's another word for it. Has been made null and void. There are kids who are born through multiracial sexual relations. And then these kids are immediately disadvantaged because they fall into a race category, whatever that race category might be, Indian or colored or whatever. They are disadvantaged before they are even born. So we continuation this thing of this. We are continuing this thing of disadvantaging people on the basis of race. And you would remember that I raised this before, and I'm hoping that as we come back next year, early next year, for more presentations, that we're going to start to look at this differently. It's a difficult point to raise, and I'm strong enough to raise it on this platform. I don't have a challenge to raise this, because at some stage we need to be able to look very clearly at what we're doing in terms of disadvantaging people who shouldn't be disadvantaged in this democratic South Africa. And then we shouldn't say it so brazenly so that it looks like it's okay. It's not okay. So that brings me back to the slides on transformation in the distribution of scholarships and research grants. A couple of slides there, research capacity. My question is, should we not talk next time more about these things and less about the other things? Maybe just shortly mention those advances which we're making. But I think at some stage we need to look at what is the impact on our society of what we decide to do and what we do and what we implement. Because our society is really struggling at the moment. What are the causes of gender-based violence? What is really happening in our country in terms of the transformation? Whether that transformation, as it was mentioned, in staff, senior management, scholarships, research, grants, gender, whatever it's based upon, but at some stage, we need to be able to ask very important questions. How do these things impact on South Africa and its people? I don't have the answers for those things, but I think it's a very serious discussion that we ought to have. Expansion of pool of institutional recipients of SAMRC grants. I noticed that and it was raised, I think, by Honorable Kaba, the University of Free State is, for example, not mentioned. And how are these decisions taken to have partnerships with institutions of learning and other institutions, research institutions, global institutions, South African-based institutions, African-based institutions? How are these decisions taken? I think in the future, I'm just saying that because I was going to say this and Honorable Chairman went ahead also spoke about the same matter. So I like and I am saying this because I am affected. There are people I know who are affected by this thing of decrease in allocation of grants and scholarships to certain people. We must find a way that we are able to address it. This thing of race, this thing of black and white. The colored people, Indian people, and African people are black people. We should classify it like that. We should continue to work like that because that's why the people cringe. That's why there are people who had fought in this liberation struggle are not happy when these terminologies are used. Then secondly, the MRC should develop a relationship with the University of Free State, which I've mentioned. They do have an established health faculty, and I think it should be just right that there is fairness in every dispensation. And just maybe to also in the future have a talk about preventative health strategies and the work we should do in terms of research and grant allocations, etc. I know there's a lot of work going on, but maybe a slide on that would really assist. There's this challenge of obesity, hypertension, communicable diseases, processed foods, sugar and sin taxes which have been raised. Maybe we should also have a slide on those and what the SAMRC thinks should happen with regards to this challenge of people now using or eating only processed foods, if it's going to be KFC or Nando's or a can of peas or a can of beans or a can of pilchards. Maybe we need to be able to also highlight what it is that our people ought to do, especially platforms like these, to be able to exercise measures in order to enhance their. This is the third time I mention it, and it could be strange, but I can tell you how it feels for myself, having come where I've come from and having had such great difficulties to become who I am today. It was not an easy road, it was a very difficult road. We didn't have the opportunity and we had to fight for that opportunity. We didn't have the money, we had to fight for that money. We didn't have the scholarships, so we had to fight to get to where we are. And I wouldn't like to see anybody having to put up the kind of fight that many of us had to do at that time prior to and for it to still happen today. Thank you very much. You are welcome to answer all of these points.
Thanks, honourable members and honourable chair. So I'll start and then I'll hand over to the rest of the team to take specific questions. But maybe let me start with the honourable chair, if you don't mind, just to respond to some of the questions. And so we do have a relationship with the University of Free State. They're part of our wastewater surveillance program. In terms of our calls, any institution and any researcher from any part of the country can apply. So it's basically whoever applies is a function of who applies and the merits of the application. So I think what we can do is we can show you one of our problems is that some institutions don't apply, and that's why they're not represented. So I'm very happy to share, who's applying and who gets funded, and by institution and by other demographics. So it's not a decrease in the recipients by demographics, but it's more a function of who does apply and who doesn't apply. So I think we can address that going forward. We do a lot of work with Free State, so we can also show you the kind of work. But when I talked about Free State, they don't have an extramural unit, and that is one of the things that one needs to address is the issue of extramural research units. We do a lot of work on obesity. And we're doing this intervention across 4 countries, looking at interventions pre-conception and during the early childhood to impact on obesity. We do a lot of work in non-communicable diseases, so which the rest of the group can talk about. And we have been involved in trying to evaluate the value of the sin taxes. So none of the sin tax money comes to research. They go to other entities, but it's an important thing to do. So I just wanted to just address the issue around the Free State. We have been to the Free State. We went and visited the Free State, and we spent a day with the senior research director to discuss how to increase participation of UFS in MRC programs, just to make sure that to understand why they're not applying for this. So I'm going to carry on with the questions. So one of the questions that member Geller asked was about disaster readiness, what the MRC did to strengthen the country capability to respond to future pandemics. So I'm going to address that. In terms of disaster readiness, so we are involved at a country level with the NDOH and the presidential compact on supporting future pandemic preparedness and strengthening the capability of our country to respond. And we have worked with the NDOH to make certain recommendations. And a lot of the recommendations are around continued surveillance, the importance of vital statistics like excess deaths, and the issue of hospital surveillance and continuing the kind of sentinel surveillance we do with flu and other entities. So we are working with that and trying to make sure that whatever surveillance we funded, we can continue to fund that. I'm going to talk about the issue around health risks of tobacco and e-cigarettes, but other people will also talk about it further. And just to say that e-cigarettes don't get away from nicotine addiction. So we have to realize is that nicotine is a highly addictive drug. And whether you use tobacco or e-cigarettes, it doesn't take away your nicotine addiction. And so I think we have to understand that the health risks of nicotine addiction are not good. And therefore one should try and minimize access to both tobacco and e-cigarettes, because we don't want to have people addicted to nicotine, because it does have adverse health effects. So that's just an issue that's important. In terms of excess deaths, Member Clark asked about study outcomes and about excess deaths. So we continue to monitor excess deaths in the MRC. We still see a lot of volatility, and so in terms of if you go into our website every week, we publish our excess deaths, and you can still see we are still tracking above the baseline where we expect to be, and a lot of volatility. We just recently had a lot of deaths in the over 80 group, and that could be due to influenza. And so in terms of COVID vaccines, around 39 million vaccines have been given in South Africa. Our side effects from the vaccines are no different to anywhere else in the world, and we still see them as rare events, or the adverse effects we see in the same kind of proportion as you see in the rest of the world. And so some of those adverse effects are Guillain-Barré syndrome and myocarditis and some of the thrombocytopenia that we saw. So those are no different to what we saw in other parts of the world. I'm going to just go on to Liesl will talk about the rheumatic heart disease. In terms of around the funding, what is seen as low priority, I think we look at the diseases that affect South Africans both in the present, the past, and also the future, and make sure that we are funding all diseases that affect South Africans, because that's our mandate, and to make sure we address all of these issues. There was a question about using private labs and NHLS. NHLS is a very important partner. We use them a lot, as well as other private labs. During COVID, there was a capability. NHLS was scaling up capability, and when they were scaling up capability, we did use private labs. And Professor Pillay can also add from the board, can add to that. And we use private labs in research where certain diagnostics have been validated for and assays have been validated for research issues. So that's one of the reasons why we do use private labs. But NHLS also is a recipient of our funding, and we collaborate very closely on many science projects, and we do use them a lot. In terms of mitigating our baseline decrease, we have been working a lot. We are diversing our funding stream. We've just been discussing with the NDOH and Treasury about getting an MRC foundation that will try and increase funding, and we can use and the commercialization that we have from our products can go into the foundation to diversify this baseline decrease. So it is a huge concern, and we are obviously looking at external grants and trying to find other ways of commercialization so that we can make sure that the baseline decrease isn't catastrophic. In terms of skills transfer, we work very closely with all our partners to support the tech transfer and skills transfer, so that South Africans are not left behind when these partnerships disappear. And so we work both receiving skills transfer and tech transfer, as well as supporting capacity development on the continent. And we did this in collaboration with the Africa CDC and the AU, and we continue to do this to capacitate other laboratories and clinical trial infrastructure on the African continent. I've mentioned, Member Zaba asked about the tobacco. So I think nicotine is still a drug. And we need to make sure that we mitigate the effects of e-cigarettes and vaping, because this doesn't deal with nicotine addiction, and that's also a health problem. In terms of Free State, I think we've spoken about the University of Free State. Whoever gets the scholarship is a function of who applies. We're interested in digitalization, and we have a call that's going out today, I think, or tomorrow, early tomorrow morning, on artificial intelligence and using AI to do the last mile in healthcare. So artificial intelligence is going to be very important in enabling us to deliver the last mile to people that are most disadvantaged in health. And we're looking at things like, drone delivery of medicines and vaccines, to innovation with Zoom and other functions on cell phones to enable consultations that can occur, as well as language issues and diagnostic issues like cough, being able to use cough innovation, people coughing onto a cell phone to decipher what is wrong in the lungs, whether do they have pneumonia or TB. So a lot of work in AI, machine learning, digital pathology, we're working with, as well as other innovations in delivering the last mile in care, as well as distal consultations, and we can go further into that. We play a big role on the continent, and we do a lot of collaboration. Our collaboration is increasing substantially, as I've mentioned, with the Brilliant collaboration. We also collaborate with Science for with the African Foundation on the global challenges. We've just set up a grand challenge in Malawi. We have an Africa's Funders Forum to increase relationships with the African funders and to enhance our bilateral relationships. We just have some conversations with South Sudan to develop some kind of relationship in terms of pandemic preparedness, and with our GLOPID, our regional hub, it allows us to extend our program to the rest of Africa. In terms of Member Chirwa's issue around transformation and the design of the organization, and in terms of the issues around delaying transformation, I think that you will see that the MRC has changed and is going to change drastically in the next 1 to 2 years, and we can share those issues. One of the issues we've had was an aging white demographic that are retiring and who were on permanent posts, who will be leaving the organization in the next year, which will rapidly change the demographics of senior management. But I would ask our HR person to talk further on that. In terms of gender-based violence, so in terms of gender, the reason why we have so many women in our organization is a reflection of our sector. There are more women in health than anywhere else, and so the fact that's one of the reasons why we have a great representation of women, because women do work in the health sector. We are the leaders in gender-based violence, and we support both mechanistic and intervention in gender-based violence and infanticide, and we collaborate with many people across the globe on interventions for GBV, and how to address these issues, this violence against women and children. It's one of our key projects, and I think we've presented this a lot of times, and often people like Naima Abrams and Rachel Dukes present to Parliament on the role of our gender-based violence and the programs that we're doing. So it's front and foremost in our organization, and we are using these interventions across Africa and across the region to develop interventions that can minimize intimate partner violence and gender-based violence. In terms of the question for Member Harvard, Dr. Zilka will talk about the curriculum on health practitioners. In terms of lessons learned from COVID-19, we've learned a lot. One is around the importance of surveillance and vital statistics. It's important to know the vital statistics and who's dying from what, where, and how, so you can interact. The importance of hospital surveillance, sentinel surveillance sites. The importance of research infrastructure, both clinical research and immunological. The importance of investing in rapid diagnostics, which we did. The importance of collaboration on the continent, which we did with genomic surveillance, and the importance that we found that the lack of manufacturing capability on our continent, which we are addressing. So a lot of lessons that we've learned, which we are applying in real time in the MRC and with our collaborators. In terms of I'll ask Mongezi to talk about the publication records. I think, Mongezi, the issues around the indicators, if you can just talk about the change, the delta change in target. So why did we have 4, the number that I mentioned in the beginning was we saw an increase in funding. So over the last 10 years, we've had increase in funding, which has allowed us to increase the number of grants that we give. We are looking at the impact of the cost containment. It's a huge problem for us. Losing 34 million rand is something that we have to address, and we've trying to find ways to diversify our funding, but that does have a knock-on effect on everything we do going forward. I think that I'm going to hand over to the other members that are there who can answer some specific questions around some of the questions that I've missed. But maybe let's start. Shall we start with Liesel? And you can take on from me, and then we can have HR and Angie, and then Mongezi and others who can add to what I've missed out.
Yeah, thank you, Professor Gray. Thank you, honourable members and chair. I'm just going to add on to a few things that Professor Gray mentioned. Most of these are from the research perspective. Honourable Member Gila asked about cancers. We're very much involved in multiple aspects of cancer. We're involved in several parts of our units are involved in active cancer surveillance, both in the Western Cape, Eastern Cape, and KZN. We're also involved in cancer centres in both Gauteng as well as the Western Cape, and a particular strength there is the work that we've done on HPV as a cancer, as the risk factor for cervical cancer. That has also been looking at HPV vaccines, administering them, making sure the registration, screening, as well as surveillance ultimately. There's also quite a lot of work done in cancers in our extramural units, which includes precision medicine. So again, all the way from cancers related to obstetrics and other areas as well. So that has been a very important part of what we've been doing. That's also been a multidisciplinary effort. So it's come from our burden of disease unit that's doing the cancer registries. It's our extramural unit, our strategic research units, as well as the non-communicable diseases unit. Then just an additional data point for the Honourable Member Clark. So far in the world, 306 billion doses of vaccine has been administered. This is COVID-19 vaccines, all of them together. And so far, the adverse rate is about 0.1%, and the South African rate is noted at 0.09%. And so this obviously relates to notification as well, but that concurs with what Professor Gray mentioned, that it is in the same realm as the global results. Honourable Member Hicklin, very good to see you on the call. We've collaborated and talked about rheumatic heart disease many times before. You may have noticed slide 54 was the New England Journal of Medicine paper that I was involved in, a first randomized controlled trial in over 38,000 patients with rheumatic heart disease, many of whom are on the continent and in other low and middle income countries. We've just put in a huge grant now with collaborators within and without the MRC, looking at surveillance sites for Strep A, ARF and RHD. So certainly looking at that area, and I really appreciate your interest in this area. Obviously, it's an interest of mine. So that is really good. And then if you also look at slide 53, you will notice that the papers that we have published over the last 2 years, we went from 1,047 and then 387, that's 1,434 in the period 2021 to 22, and in the next period was actually 1,900. So we did actually increase the amount of publications from last year period to this year period. Just in addition also to the comments from Professor Gray about artificial intelligence, one of the most important areas in terms of artificial intelligence is actually how we look at data, rather than things like ChatGPT that people are aware of. So a lot of the global burden of disease data comes from a Department of Statistics, and these need to be cleaned and verified. So, for example, prostate cancer in a woman or cervical cancer in a man is put through multiple artificial intelligence interfaces to be able to clean those data. And that is actually how we get very much more accurate data in terms of burden of disease. And they also use artificial intelligence in terms of death certification and verifying what we call nonsense data. This is, for example, if you have heart failure in a 2-year-old, you need to go into those data to understand what the true causes were and then reallocate. And we use artificial intelligence programs to do that. In our EMUs, various EMUs use artificial intelligence and digitalization differently. Just very recently, I was in Agincourt, and in rural Mpumalanga, they use echocardiography and portable ultrasounds to make the diagnosis of pneumonia versus perfusions, for example, in children in rural settings as a point of care device. And I spoke to them, Honourable Member Hicklin, about the new WHF echo criteria for rheumatic heart disease that will come up, that's going to be published very soon, and how we could utilize those in rural Mpumalanga. Honourable Member Chirwa, you spoke about obstetric violence and interpersonal violence. I know Professor Gray has mentioned that. I just want to mention 1 or 2 other points. One is the work and the funding we do in terms of our mid-career scientists awards. One of them was to Professor Salome Maswime and her work in global surgery, which is focused quite strongly on obstetric violence, on maternal mortality, and immediate postpartum mortality. Recently won an award for that. But that is a work that we have been intimately involved in. The AmbiFlow, which we presented, I think, at the last session, also spoke to that. And we also have multiple maternal and infant health strategies across virtually all of our units. Another very interesting element, and I know sometimes this may not sound popular, is that one of the most vulnerable populations in terms of longevity in this country are men. They have between a 15 and 25-year less lifespan. That relates to injury, to violence, to suicide, and we are exploring those and the reasons why men become perpetrators, both in our intramural and our extramural units. So there's also work going on there. Honourable Member Harvard asked about curriculum training. So we are involved with SACOMD. This is the South African Council of Medical Deans. And a very important part there is the Deputy Deans of Teaching and Training across the country, where we've had input and discussion about the curriculum change, the decolonization of the medical curriculum across the board. This is apparently going to be ratified next year, our official role in that capacity, which will also be with the deans of dental schools. As the Vice President I visit the extramural units on a regular basis and interface with the deputy vice chancellors and deputy deans at that particular forum, and we have very robust discussions about curriculum and training in that regard. We are an incredible resource for training in many areas. I mentioned our burden of disease research unit works on training about death certifications. Our research and integrity office does incredible work in training in terms of GCP as well as ethics training, and those are open for not just for MRC employees, but are also focused at HDIs. The final thing I just wanted to address are some of the chair's comments about prevention health strategies. Our health promotion and disease prevention working group, as well as our environmental health research group, are very involved in these processes, both internal to the MRC and external to the MRC. We've just put in, I just saw the notification now, we put in a grant for the polypill for hypertension, focus on primary care, especially in our vulnerable age groups, which is really from 45 and above. The other very important group that we look at is children that are malnourished, and by malnourished we mean undernutrition as well as obesity, and there's a lot of work going on in that. Our extramural unit priceless based at WITS has been intricately involved in the various syntaxes. They've assessed and done the health economic assessment for sodium, for sugar laden beverages, as well as for the various alcohol increases or just the syntaxes generally, either on alcohol or in tobacco. And then the other thing that we were, can't remember now if it was the Honourable Member Jacobs that raised it, about I think it was around healthy eating strategies. And today we actually spoke about two particular studies that address this. One is FAMSA, which is a study looking at and partnering with communities, our spaza shops, and explaining to them, improving health literacy about healthy food, but also doing this in a way that does not impact upon their own revenue, and therefore doing it in community partnership. And another study that we discussed this morning was Her Story, which was a 3-part study that's been going since 2016, where we looked at adolescent girls and young women with a lot of work in terms of not only trying to prevent HIV incidents, but creating of resilience and infrastructural components such as job preparing for a job, interviews, etc. Within that is also built a module around healthy nutrition prior to pregnancy, during and after, as well as exercise, wellness, and mental health. So I hope I've answered a few other questions. I'm going to hand over to my colleague, Ms. Pham.
Thank you, Lisa. Honorable Chair and honorable members, good afternoon. On the question of transformation, the struggle continues. As you can see, from 2020 to 2023, we have moved by 10%, from 51% down to 41% for senior management. The executive committee, as mentioned, we have done a good job in strides in terms of transforming the profile. The feeder to the senior management, to add to what Professor Gray was saying earlier on, that we are going to make major strides to change the demographics in the next few years, because the feeder to the senior management, we have been working very hard as an organization to build that talent pipeline that will be able to move when the opportunity arises, to be able to competently compete or get promoted to be at the senior management level. We have in place deliberate structured talent management programs that we have put in place that make sure that we are representative of all population groups when we train and develop staff. We've been getting very good grants or additional grants from the CETA to help us do the work of creating a conducive environment for people to be able to develop and to learn. Therefore, to add to what Professor Gray was saying, we are with the succession planning that we have put in place with the colleagues due to natural attrition that is taking place in the next 2 to 3 years, the gaps that are going to be created, we deliberately look at making sure that we appoint people according to the employment equity plan of the organization. So I think I'll end there, Chair, just to say that the management practices have already been in place since we managed to move from 51 to 41 in that cohort of senior management. As I'm saying, other areas or other occupational categories of the organization are doing well with the transformation issues. So we are going to continue also with the management practices where when we appoint people outside our own employment equity plan, the line manager does not do the approval. It is done by the executive management committee that looks closely to say, why are we unable to appoint people according to our own targets? Those operational day-to-day or kind of practices are going to continue. Thank you, Chair.
Thank you. So, Chair, I can just quickly touch on the Honorable Gela's question around the targets. Honorable Gela, and I like the analogy about a soft landing. So the targets were set up when we set up the strategic planning, which was around 2018-19. And at that period, honorable member, we have to look at the projection in terms of the MTF. And at that point, it showed a decrease in our baseline budget. So surely, I mean, one publication costs about 50 to 80,000 rand. So we had to set the targets in line with our budget available. But, COVID came around 2020, 2021, and Philip, when he did the presentation, showed an increase in our baseline budget. That's where we could allocate a lot of money to many researchers, and we could then end up with the publications. So these publications that you see now, some of them are the remnants that came as far back as 2020, because research takes a little bit of time. And then there was a question around the indicator on innovation. That again, it's the same. The answer is similar to what I've given around the publications. Our collaboration, as the President has indicated, with the TIA, the DSI, and other stakeholders enabled us to issue a lot of grants in terms of the innovation, and most of them were around COVID and other areas. I'll now hand over to Philip just to talk to the issues around cost containment. Thanks.
Thank you, Mngezi. Yes, on the cost containment at this stage, we have not received any formal communication from the National Department of Health, but we internally, as management, we've already started identifying areas that we can reduce expenditure to be able to fit within the 2023-24 financial year, to ensure that we come in within budget. For 2024-25, this is something that we will still have to discuss within MRC. But the source of funding that can be used is to increase our recovery on our research grants. As you can see, there is a substantial increase on research grants, and for that, the organization have indirect costs that needs to be covered. So we will definitely look at those areas to increase the recovery rate of indirect costs from our research grants. Thank you.
So I just want to address the issue of obstetric violence and neonatal mortality rate. So we've been looking at neonatal mortality rate, which is the death that occurs from the first day of life to 28 days of life, and we've been charting this over time. So in fact, our neonatal mortality rate hasn't changed. So it hasn't gone up and it hasn't got less. And so what are the factors that affect in neonatal mortality? So one of the biggest factors is prematurity, and that's caused by chorioamnionitis and other factors as such. So we have to address the issue of prematurity before you address the issues of neonatal mortality rate. The other issue that drives neonatal mortality rate is group B strep septicemia. And we've made a lot of strides. Hopefully there will be a group B strep vaccine that we can give to moms. And another way of preventing group B strep is to try and screen for GBS during late pregnancy. Other drivers of neonatal mortality rates are nosocomial infections. So when kids are born young, they may be infected by a Klebsiella, which is a nosocomial infection, which is sometimes resistant to antibiotics. Other drivers of neonatal or stillborn deaths are things like hypoxic ischemic encephalopathy. Now, we have high rates of HIE, and that's related to a lot of things that we're trying to uncover. And that's why we've got this study going to see why do we in South Africa have high rates of HIE, irrespective of the labor and delivery care that we get in hospitals. It seems to be high, and it could be related to nutritional issues, intergenerational nutritional deficiencies, so we're investigating this. It's a very important factor. Cesarean sections are an important innovation to prevent stillbirths and early neonatal mortality. So I think they are important interventions, and we need to make sure that our hospitals are equipped with the ability to do cesarean sections, because those are life-saving interventions. There are high rates of CPD, cephalopelvic disproportion in South Africa, so we will have high rates of cesarean section, and that's to prevent birth asphyxia, which is very important for preventing neonatal mortality rate. So the good news is a neonatal mortality rate hasn't gone up, but it also hasn't declined, which means we have to work much harder in dealing with that. Women in labor die of three H's: hemorrhage, hypertension, and HIV. And we have to address the issues of hypertension, preeclampsia, which is a leading cause of maternal death, hemorrhage, which we are dealing with, trying to find ways of preventing postpartum hemorrhage, and then the issue of HIV that we have to address. In some area, around 30% of women who book into antenatal care are women living with HIV. It's important for them to get the intervention so that they don't die. So in terms of obstetric violence, I hope I've answered the question around cesarean section. It's an important and necessary intervention. And sometimes, it's an important reason to try and prevent stillbirth and that. What we also try to do in MRC is develop interventions to pick up high-risk pregnancies using a Doppler ultrasound and trying to look at placental blood flow and using this as a triage to get women who have decreased placental blood flow to tertiary care centers so there can be an intervention. Other causes of neonatal mortality, as I've mentioned before, are related to stillbirth, prematurity, infections, and things that we need to continue to strive to change in our obstetrical practices as we go ahead. So, Chair, I'm not sure if we've answered all your questions. If we've missed something, I don't know if Angie, if you want to say anything from the Transformation Committee.
No, I think Ntoza has covered everything. I just wanted to instead make a comment on the Honourable Member's question about the weekly mortality data. As Professor Gray mentioned, we have seen some spikes in mortality, especially in the elderly, and some of those spikes have coincided with extremely cold spells in our country. And that is borne out by a major study that our small but very active climate and health team has undertaken. They looked at over 8 million records and found that at the moment, we are concerned about climate change, but it's actually cold weather that's causing mortality, in particular in our elderly population. So going forward, I think a range of factors, in a range of health concerns, we are going to have to apply a climate lens. And for our elderly population in particular, we will need interventions to keep them safe and healthy during these extremely cold spells that we are experiencing. Thank you.
Chair, I'm not sure if we've lost you.
Oh, I thought you still had one or two more. No, you haven't lost.
Yeah.
Thank you very
Yeah.
much. Internet
Yeah.
is a bit unstable. I think I should just switch off my camera for now. So thank you very much for the answers to all of the questions. I don't think mine has been answered so well, but as a recommendation, I should say you should stop the decline of scholarships to certain categories of races. I think, and yeah, I'm talking about the one that is specifically mentioned. And so I'm picking up on it again. I'm making that a recommendation to, as I said, I'm brave enough to speak about it because it's mentioned like that. Scholarship allocation for colored students should not be declined any further. And I think you need to just work a bit harder to get more money and get as many of our students who would like to do research or want to have scholarships and grants that we're able to afford or to assist them. Thank you very much once again for coming to give us, again, a wonderful presentation, apart from what I mentioned. But I'm sure we will still see you. We will still see you early next year with the APPs and budget. And I'm sure in the future we will also see you because you will still be affiliated with SAMRC. To the whole team, thank you very much. Honorable members, so you want to say something, Prof. Grace? Prof. Gray,
Yes, yeah, I just wanted to say thank you to the NDOH. Our executive authority we work very closely with, so I want to just acknowledge them, and I wanted to say thank you to the parliamentary committee and to my board members and the executive management committee that are on. So we appreciate your interventions, and we are scientists. We like provocation.
Oh, wonderful. So, with that having said, we look forward to the next presentation, which should be at 16:30 by the NHLS. I've not been able to look if they were here, but I think, honorable members, we can take a break until 16:30 and come back for the next presentation. You are welcome to stay, Professor Gray and your team. You're also welcome to leave because I'm sure you have a lot of other work to do. Thanks. Bye.
Thank you very much. Bye-bye.
Is there any life here?
Good afternoon, everybody. We are right back. I hope all the members are still here. We will continue with the
We are here,
presentation.
Chair, don't worry. We are here, Chair.
Thank you. So we are here to continue with the presentation by the entities on the annual reports. And we will now receive an annual report from the National Health Laboratory Services, led by its chair, Professor Eric Book. I hope he is here. I've been looking and I did see Dr. Kabi Chetty, the CEO. So I will hand straight over to them. You are all very welcome. Just a reminder that this is a virtual meeting. Assembly.
Good afternoon, Dr. Jacobs. Just to ask first whether you're going to share the presentation from your side or whether we're going to share it.
We'll be sharing. I think Dr. Chetty has been made a host.
Okay, we'll share. Thank you.
Dr. Chetty?
Great.
All right, so
Yeah.
I thank you, and this is a continuation of a meeting, and that all the rules of the virtual meeting, virtual sitting of a committee of the National Assembly will apply, and that is for official purposes only. I've already read through the rules this morning, so the same rule, being the same meeting, will apply in this meeting. And I think even yourselves, Professor Book and Dr. Chet, have heard these rules many times. So I'll hand straight to you so that we can proceed. Be mindful of the time allocated. We were hoping to finish by 7 o'clock tonight. If it's a bit early, it's fine with us. So you have a lot of time to continue. Thank you very much. Handing over to you, Prof.
Thank you very much, Dr. Jacobs. I would just like to confirm that you're able to hear me and to see the presentation.
Yes, we can see the presentation. We can hear you. Also saw the Springbok jersey in the background there. It's good to see.
Thank you very much. Great. Thank you very much for the opportunity to present our annual report to you this evening or this late afternoon. Just to say that in the boardroom with me behind is the sort of top management team of the NHLS. I'm not going to introduce all of them to you so that I don't get accused of taking too long on my part of the presentation. But just to say that members of the executive of the board, what we call the governance committee, are joining online. Professor Tanyani Mariba, the chair of our National Academic Pathology Committee, is online. I can't see all the members online, but also Sekwena and Koko, is the chair of our Audit and Risk Committee. Professor Michael Sachs is the chairperson of the Finance Committee, and he may join a little bit late, but Professor Jeffrey Mpachlele is the vice chair of the board and the chair of the Research and Innovation Committee of the board. I'm going to, how do I go to the next one? Is it not a quicker way? So I won't state the purpose. I think we all know that, but I'd like to give a little bit of background to the NHLS. I think we've, as you said, we've presented many times before. We're used to this. Maybe I should say it's probably my last time to present, given that my term of office as chair of the board ends in April next year. It'll be the end of my second term, which is the limit for what is allowed. Just to say, of course, that we do provide services to 80% of the population of the country. We've emphasized many times that we do not go where the money is, we go where our people are and where the need is, and we deliver services deep into rural areas and in the poorest areas of the country, even though it's much more costly, obviously, to do so. You'll see that, of course, the forensic chemistry laboratories are now part of the NHLS. It's been a tough call to try and address and advance the challenges. The CEO will outline some more of them. But the state in which we receive them, both the levels, the numbers and quality of staff, the facilities, the equipment, the information systems, all of those were, I don't want to use too many difficult words, but to simply say that they were well short of where they needed to be. And we'll share with you some of, even though this is the annual report going backwards, we know that this is an issue that has been of considerable concern to the Portfolio Committee, and therefore we'll just touch on some of the key areas where we're working on our developments. Of course, remember that the NHLS sits on three legs in terms of our act. It's laboratory services, but also research, in which we're a pioneer, as well as teaching and training in support of expertise there, and also of course, the production of life-saving anti-snake and other life-saving anti-venoms. Again, we had a challenge earlier in the year in that regard in terms of our production line, but we pretty well sorted that out, and distribution has not 100% of what we like quite at the moment, but pretty well as close to that. And certainly, even during the time where there was a shortage, there was still anti-venom in every province, widely available for anyone who did get a bite, even though that wasn't the impression created. Just to say that we believe that when you look at our performance, that the NHLS has done well. A couple of times there where we've affected our annual performance plan well, in spite of real challenges. Where laboratories are very electricity dependent. So obviously we've taken measures to ensure stability of electricity or generation in our labs. And remember, we have well over 200 of them around the country. But where we haven't quite met our target, most of them were 1% or 2% sort of off, rather than far off. So we continue to provide a very strong laboratory service. But I think what's important about it is we've spoken about our resilience and our adaptability. But what we also want to emphasize is that we've been able to do this in a way that, yes, so I've spoken to the forensic chemistry laboratories. You'll see that we have laboratories in 4 areas, 4 cities, but the CEO will tell you that we're going to be expanding our services in Pretoria and Durban to deal with, in particular, the toxicology backlog and additional staff. And we've worked quite hard in key areas. So we've constantly worked at improving our clinical efficacy and efficiency and providing a high quality service and services at low cost. And I think I want to just stop for a moment at the question of low cost. And of course, maintaining good governance. Today is not so much the day to provide you with an update, but one of the things that I can mention to you, you'd asked us about it before, is there was a complaint against us in 2017 by some of the executives that we had suspended and then dismissed on corruption-related activities. They were behind reporting us to the public protector to try and paint the board and a couple of the and the company secretary in a bad light. I'm very pleased to inform you that the public protector did publish the report, which was reported on in the media, and we felt that the report was wrong in fact and in substance and in law, and that the public protector had gone beyond, or the then public protector, I apologize to the new one, had gone beyond her mandate, and we had therefore gone to the High Court to have the report set aside. And I'm pleased to report to you that the public protector has indicated that she will not defend her report. So the new public protector accepts that. The court case is set for January, and we will present our case, which will not be opposed by the public protector. And I think that is really, in my view, indicative of the good governance in the NHLS and the exceptional work by the board over the nearly 6 years that I've been chairing it. I think I've been very fortunate to have committed board members over 2 particular board periods with integrity and a commitment to the NHLS. And I do believe that we've displayed good governance. But I want to come back for a moment to the question of providing services at low cost. I think we mentioned before that our annual increases each year have been well below. We do not go for the double-digit type increases. We tended to go to about 5% or less, in spite of being able to offer reasonable increases to our staff, who we value enormously and who put in great commitment. We have about 8,000 staff. And also, as you know, medical inflation is higher than regular inflation. A lot of our equipment and our laboratory materials, our reagents come from overseas, and therefore, as the rand comes under pressure, so our costs also go up. But you will recall that back in 2017, the NHLS was in a situation where we were always able, in the end, to pay our staff every month. But you'll recall at the time, those of you members who were on the portfolio committee at the time will recall that we had very little money in the bank. We often had only 150, 200, 300 million in the bank at the beginning of the month. With an expenditure at the time of about 700 million or so a month. and we were struggling. We had a 1 billion debt to our suppliers. Today we sit with a very, very healthy bank balance. And in fact, it looks even, we look a little bit even better than we should in the financial statements, because our auditors have made a change to our auditing standards, which makes our financial statements actually look a little better, somewhat better than they would have on a like-for-like basis against last year, but still a very solid overall financial performance. And we continue to provide services well below, our basket is well below that of the private sector, and we're able to continue to provide, even though we have higher cost demands because we move into rural areas, areas where the private sector would not show an interest because it's more higher costs and lower profits and margins. So we're very proud of that aspect. I think we also play a very significant role in supporting public health in South Africa. Professor Purin will tell you that the National Institute for Communicable Diseases is one of the jewels in the country. I think the whole country knows the NICD now after the COVID-19 pandemic in particular, but we do a huge amount of other work that is there, including the antiretroviral rollout program and some really innovative work there in terms of the AIDS program in the country, a lot of work on tuberculosis as well, non-communicable diseases, cervical cancer, and also our National Institute for Occupational Health. Molo was there, and she, in terms of the role that the NIOH provides. We continue to strongly support these two entities of the NHLS to ensure that they remain fully functional, even if the grants, the conditional grants, don't quite provide all we need to deliver the exceptional services that they do. We certainly make sure that they are well resourced. We work quite hard on our partnerships with key stakeholders. We are very highly regarded, in particular in the World Health Organization. We have a number of our staff members that are on expert committees of the WHO, as well as in very high regard with the African Center for Disease Control and Prevention. We've played a number of key pivotal roles in the CDC, which you can find in our report, and we work on that. So during the financial year under review, we appointed two new executives. The first one is Ms. Phumeza Mayekiso as our Chief Financial Officer. Phumeza, maybe you can put your hand up so that the Parliamentary Portfolio Committee can see you, together with Dr. Clotilde Oliphant as the Chief Operating Officer for Strategic Initiatives. Clotilde will put her hand up there. So if you look at our executive team, you'll see that it's a very transformed team, and it's largely a team. The NHLS is largely led by women. I think sitting just behind me, you can see Prof. Koleka and Isano, who I think everyone knows well as well in that regard. So obviously we have the board members, but before I step aside and invite the CEO to take you through the annual report in more detail, I just want to make the first public announcement in this regard. We have informed the minister already some time back, but we will be putting out a statement in the media. But we wanted to first make this as a report to the Parliamentary Portfolio Committee that our NHLS CEO, Dr. Kami Chetty, has announced her retirement in 2024. So she will be retiring in 2024, and I wanted to. We have tried to twist her arm, but she is due for retirement. And I think her period as CEO will really, her retirement will sort of bring to the conclusion a remarkable chapter within the NHLS. I think Dr. Jacobs, yourself as the chair, and others have seen the performance of the NHLS, and I think we're all aware how critical the CEO is to the success of the organization. And you've seen how we've advanced a number of areas in terms of good governance. We're trying to build a clean organization that delivers cost-effective and efficient services to all our people. And I think you're all aware of how we responded during the COVID-19 pandemic. And I just wanted to pay tribute as I announce her impending retirement next year. I just wanted to recognize what she has brought to the NHLS over her period of about 6 years as the CEO of the NHLS. Thanks very much.
Thank you very much, Chair. Honourable members of the Portfolio Committee, I will just take you through some of the operational aspects. And thank you, Chair, for those kind words. The Chair has introduced the Executive Committee, and all the members of the Executive Committee are here today. Just to say that Advocate Inko Mpelo has also resigned about 3 months. He gave us 3 months notice, and he's now joined another public entity. So we're quite proud of the fact that his skills will be used in the public entity. He's had 2 terms, and the policy that we have is executives normally have 2 terms in their contract, and his term had come to an end.
So maybe we should just say that Advocate Mpilo will be the company secretary at the South African Health Products Regulatory Authority, SAMRC. I'm not sure if they have presented to you yet and whether he was part of their team. So if you thought you were seeing him in the wrong place, that's his new home, because he was coming to the end of his 2nd term at the NHLS.
So this is the organizational structure of the NHLS, and I'm not going to go into details. And maybe just to look at the operating model, my apologies, it's a bit fuzzy. So we've got 9 provinces. We've the only laboratory service in the country that's got a national presence. We reach every corner of the country. We've got 6 regions, and we've got individual business units within each region. So this gives you an overview of the number of labs we've got in each province, the number of health facilities that we're servicing. It gives you information of the population in those provinces, what our revenue is for each one of those provinces, our total test volumes for those provinces. So that will be of interest to the Portfolio Committee, but I'm not going to go into details with regard to that. Our institutes and our subsidiaries, the chair of the board has mentioned the National Institute for Occupational Health, which provides occupational health services in order to support occupational health. The National Institute for Communicable Diseases, which is responsible for the surveillance and monitoring of communicable diseases, also responsible for the National Cancer Registry. We've spoken about the Forensic Chemistry Lab, whose functions are threefold. That's analyzing anti and post-mortem blood for alcohol content, It's also testing of biological fluids and tissues in cases of unnatural deaths, and responsible for sampling of foods and cosmetics under the Foodstuffs Act. We've also got the South African Vaccine Producers, which produces equine antivenom for snake bites, spiders, and scorpion stings. Chair, I'm not going to go through all the details of our legislative and other mandates, but basically we govern by all the acts, all the health acts, as well as all the finance acts as well. Our governance structure, the board serves as the accounting authority in terms of Section 49 of the Public Finance Management Act. It's responsible for providing strategic direction and leadership. And we have 6 subcommittees which support the board to meet its mandate. The responsibility for risk management rests with the management, and the board plays an oversight role. We make sure that our risk management processes are embedded throughout the organization, not just at the board level, but to all employees. And we've got a dedicated risk management and internal audit department to look at the implementation of our risk management strategy. The board is responsible for approving that strategy, and the board also has the Audit and Risk Committee, which is chaired by Mr. Kwena. And we continuously monitor our risk management strategy through the board meetings as well as in the executive committee. We've also got an anonymous tip-off platform for reporting fraud, corruption, and unethical behavior. This is outsourced to a private firm so that we can keep the independence of that hotline. I'm just going to highlight some of the financial performances and then the non-financial performance highlights. So, Chair, we've maintained an unqualified audit opinion for the 22-23 financial year. We've maintained this unqualified audit for the last 5 years. We know that the systems that we've put into place will assist us in being able to achieve a clean audit in the future. The NHLS creditors' days have decreased to 34 days, and whilst this hasn't reached the target, it is a decrease from previous creditors' days. Our assets increased from 7.8 billion to 10.5 billion. Our current liabilities have decreased from a restated 2.2 billion to 1.9 billion. And we generated an accounting surplus of 3.2 billion for the financial year. So, Chair, the Chair of the board has mentioned that previously, when we calculated the doubtful debt, we did it according to any debt that was over 90 days. So this was according to our accounting policy. There's been a new generally recognized accounting practice, GAP 104, which came in September 2022, which has stated that we need to recalculate the doubtful debt according to whatever debt we recover. So where we have been recovering debts, we needed to recalculate it, which has then resulted in a surplus of an extra 1 billion, which meant then that the doubtful debt went down by 1 billion, which meant that our surplus increased by another 1 billion, and that's how we've got the accounting surplus of 3.2 billion. But Chair, our cash flow has improved tremendously. The cash flow ratio is 6:1, which represents cash reserves for 6 months. And previously, our cash reserves were quite low, whereas now we do have a healthy cash reserve. We've administered over 110 million tests. In the previous year, we had 106 million tests. We've also had 24 laboratories accredited through SAMRC, compared to 18 in the previous financial year. So we've been doing quite well with the accreditation of our laboratories. We've had about 664 articles in peer-reviewed journals. We've also, one of the achievements has been, we have a new service provider for the multi-protocol label switching system, which is MTN, and we've managed to cut over 277 sites, which has vastly improved our bandwidth and improved the connectivity for the NHLS. We do have some problem sites. These are sites that we are addressing actively, but this has improved our whole IT network. Also, just to say, the NHLS board has approved a number of major tenders so that we could fulfill our objective of a modernized laboratory service, and we've approved over 5 billion rands. The board has approved over 5 billion rands worth of tenders for the next 5 years. Our TB test volumes have increased. We're very pleased with that because you know that TB is one of the biggest risks that we have. We work very closely with the National Department of Health on the TB recovery plan, and our TB test volumes have increased by 17%. It's also a priority for the National Department of Health on the TB recovery plan, and we make sure that we're able to deliver on that. Our National Cancer Registry was designated as a collaborating center for childhood cancers and monitoring cervical cancer elimination in sub-Saharan Africa by the International Agency for Global Initiative for Cancer Registries. So that is quite an honor. Our internal audit function, we're very proud, was independently assessed and achieved general conformance to the quality assurance. So they've been voted as one of the best public sector internal audit units. NICD continues to play a pivotal role in outbreaks such as cholera, typhoid fever, and measles. And we've got a very robust occupational health and safety information system that is now the property of the NHLS, which is a very valuable tool in monitoring and management in health and safety. And a number of organizations are now starting to use that. I've said already that we've achieved an unqualified audit opinion and findings, and we achieved 70% of our set targets for 22-23. A lot of our overall achievements was impacted on negatively by extended load shedding. It has a huge impact on our systems. We do have generators, but the switch over in our systems, some of our platforms, if there's a switch over, you've got to start again with some of the tests that need to be done, which is a big problem. It's also had a sort of an impact on our IT systems and the downtime on our IT systems. But we are in mitigation. We've bought more UPS systems as well as generators. We're in the process of going out on tender for installing of solar power. And as I said, we've awarded more than 5 billion in tenders to purchase laboratory equipment over a 5-year period. Just quickly to run through the programs, we're focusing mainly on the ones that we have not achieved. Program 1, which is laboratory service, we didn't achieve, we achieved 5 out of our 10 targets, but they were quite close. So for example, the TB turnaround time was 91% versus 93%. The CD4 turnaround time was 93% versus 94%. The same with cervical smear screening, the urea and electrolytes turnaround time, and the feasibility and cost benefit report on the point of care. A lot of these, the reasons for not achieving these targets is because of the extended load shedding, but we also had a global shortage of both gene expert test kits as well as the CD4 test kits. The gene expert has recovered. We're still having a problem with the CD4 kits, and that's an international shortage, so that becomes a bit problematic. But we've also replaced our old equipment with new ones. So we've gone out on a tender and awarded a whole molecular TB tender, and there is competitiveness in that tender now. We also have implemented point of care, and so from that point of view, we have mitigated some of the risks. In Program 2, which is Academic Affairs, Research and Quality Assurance, we achieved 8 out of the 11 targets. We didn't achieve the number of tertiary provincial laboratories that we wanted to have SAMRC accredited, but we missed it by 1. We got 16 versus 17. And with the regional laboratories, we got 34 instead of 35. And the number of ISO 9001 certified departments was 4 instead of 5. The laboratories were due for assessments, but they couldn't be assessed in the year under review, but they'll be assessed in the current financial year. And then our diagnostics media product, we're busy renovating the building, and therefore the certification was suspended because renovations were taking place. In Program 3, National Institute for Communicable Diseases, we achieved 100% of our targets. And in Program 4, the National Institute for Occupational Health, we also received 100% of our targets. In Forensic Chemistry Lab, the chair has already mentioned there are major challenges. So the blood alcohol test turnaround time, we didn't achieve that. The backlog in the toxicology case, we also didn't achieve that target, nor did we achieve the target around perishable food samples. But Chair, it's just to say we've put in an extensive effort into trying to sort out the challenges in the forensic chemistry lab. The blood alcohol test, for example, when we inherited it in the 1st of April 2022, we had backlogs in the most of the labs. We have cleared the backlog in Cape Town, Pretoria, and Durban, but we haven't managed to clear the backlog in Johannesburg. As you know, there's 4 labs, so that's the majority of labs where we clear the blood alcohol backlog. We're now redirecting some of the blood alcohol from the Johannesburg lab to the Pretoria lab, and we're confident that we'll be able to clear that backlog quite soon. There's been major problems with the infrastructure, so we've now, in order to clear the toxicology backlogs, we've in the process of renting additional laboratory space in Durban to open up a new toxicology lab, which will deal with all the KZN toxicology cases. We know that will make a major impact. We've also rented extra laboratory space in the CSIR in the Pretoria labs in order to address the backlogs in the Gauteng area, and we know that that will make a difference. So we're investing a lot of the NHLS money in trying to make sure that these get corrected. We've also investing in, we've already invested, but we're investing further in the buying of equipment and the analyzers. And I've spoken about the backlogs. So there's quite a bit that we're doing with the forensic chemistry labs, Chair, in order to address all of those problems, working closely with the SAPS as well as the forensic pathology services. Under Program 6 at administration, we didn't achieve the number of creditors' days. It was 34 versus 30. Part of the problem is because our sales have gone down, and so that impacts on the creditors' days. The number of debtors days.
Jacobs, I may be a bit naughty here, but I think that there are many public entities who would be proud of 30 or 34-day creditor days, and many of the others that we're achieving. So I think the point I made earlier, I think you've seen when my introduction I mentioned that where we're slightly off our targets, and you saw those with the turnaround times, we're not too far off. We're close, but yes, we didn't achieve them.
Thanks, Chair. Our debtors days have we didn't reach the target of 100. It's at 146, and Chair, this is an indication of the financial difficulties that some of the provinces are having. We are seeing a trend that the debt is accumulating, and this is something that we are trying to address with the provinces. But we think that going forward, this is going to become more and more difficult. So that's something that we're looking at very carefully. The turnaround time for tenders that are above 10 million, we didn't reach that target. It is a long process, but we're hoping that with building capacity in the supply chain unit, we will improve on that. Our BEE rating, so that's the rating as NHLS itself. We haven't been allocated a rating as yet, but we have achieved the requirement of the skills development portion of the requirements. And then the number of evaluated performance agreements was a target of 98%. We only reached 95%, but even that for an organization our size is commendable. I'm going to just quickly go through the overview of the HR environment. We had the total number of staff was 8,193, very low turnover rate. It shows that the NHLS is a employer of choice. We've had about 351 learners who were placed at the NHLS through learnership and internship program. Our personnel expenditure is about 4.7 billion, and we remain the largest training provider for registrars, scientists, technologists, technicians, and laboratory assistants in the country. The registrars are the pathology registrars. This gives a breakdown of our staff headcount according to the program and activity. The majority are the skilled and semi-skilled levels. And then again, I know that the portfolio committee likes the employment equity targets, and just to say that this gives you an indication of the employment equity for males and the targets, and for females. And you can see we're doing pretty well when it comes to females. So we are a female-driven organization, and we have done quite well with regard to that. So, Chair, with regard to our financial performance, I've said that we've got an accounting surplus of 3.2 billion as compared to a 77 million surplus in 21-22. And that surplus was because of the expenditure that we had to make on the COVID-19. I've spoken about the recalculation of the provision for doubtful debt, and that's the reason for that accounting surplus. Our revenue declined because of the drop in the COVID-19 revenue. So it declined from 12.8 to 12.7. It's a small decline. COVID-19, it was 450 million, and previously it was 1.9 billion. Our total expenses also declined from 12.8 billion to 9.5 billion. Our labor costs increased from 4.7 to 4.9. That's not too big an increase with regard to that. Our production costs decreased from 10.1 billion to 9.1 billion. and our direct material costs constituted 51% of the total cost of sales, compared to 54% in the previous financial year. I've spoken about our assets, our restated assets increasing to 10.5 billion. Our inventory has been reduced with the use of COVID-19 inventory that was procured. Our cash in bank was 5.1 billion at the end of 22-23, compared to 3.5 billion in 21-22, which is a net cash inflow of about 1.6 billion. And our test volumes increased by 3.6 billion.
6%.
3.6%, sorry. That may be a Freudian slip. 3.6%. And this is because of the TB recovery plan as well, and a recovery of the other tests. And our revenue collection amounted to 10.3 billion compared to 10 billion in the previous financial year. So we've maintained a very strong financial viability, and we've consolidated and enhanced our cash reserves. So, Chair, this gives you the overall picture for the different years, and you can see that our net surplus has increased, as I've explained, and the same gets reflected with our operating surplus. You can also see that our revenue has been steadily increasing, but dropped from the previous year because of the COVID-19. Chair, one of our concerns is the conditional grant and the government subsidies that we receive from the National Department of Health. There has been a decrease, a slight increase in 22-23, but we are informed that there will be a decrease in the next financial year. So this gives you an indication then of, it's the NICD which gets a conditional grant, and you can see that there's been a steady decrease. The NIOH, this is the Teaching, Training and Research Grant, and the Cancer Registry. The FCLs has been added as an additional. Just to say that with all of these conditional grants, the NHLS is heavily subsidizing these institutes from the NHLS funds. I've spoken about creditors' days, Chair. This gives you an overview over the years. I've spoken about debtors' days. You can see that there's a slight increase now in debtors' days. So Chair, that
Okay,
so the conclusion will be done by the Chair.
Well, I think in many ways, Dr. Jacobs and members of the Portfolio Committee, I think that, I think I'm pleased as the chair of the board to present to you the annual report that I believe shows that we continue to perform well as an NHLS and serve our country, and in particular the poorest and most rural in our country who would otherwise be without a decent service. I think our service delivery and our financial performance have been good, and we will continue to strive to maintain and enhance that going forwards. Dr. Chetty mentioned internal audit, but our internal controls have been enhanced across a wide number of areas, and will continue to enhance internal controls both in the delivery of laboratory services, but also in other areas such as finance, human resources, and obviously procurement. Makapela will say, as our Executive Director of Human Resources, that we've worked to improve our systems there as well. I think we've accelerated implementation of a number of projects in the period under review, and we do believe that cost efficiency has been achieved, and of course we will remain with that, as well as operational efficiency and effectiveness. So I think that that brings us to the conclusion. I think maybe just to mention, in the forensic chemistry laboratories, we are in the process now of opening a new facility in Pretoria. One of the problems we had was, of course, amongst many others, there were no proper working generators, fridges, and so on. We're investing in capital there. We're going to open additional laboratories to expand the capability, because certainly more of the same is not going to get us to deliver a service in the forensic chemistry laboratories comparable to what we offer across the NHLS, and we are in the process of employing additional staff. So I think that's the one area from a board perspective that has remained a real concern, but we've approved the additional investments and expenditure, and we're very pleased with the progress that's being made by the CEO and the CEO of Strategic Operations in if I could say, fixing and advancing the forensic chemistry laboratories. Thank you.
Thank you, Chair.
Thank you very much, Professor Brown. And
if I may just, sorry, Dr. Jacobson. Yes, sorry, Dr. Jacobson. I just wanted to not leave without making some acknowledgements. I think it's very, very important, to recognize a public entity, the support we've had from the Minister, the Deputy Minister, and the Director General. They've really looked after the NHLS and supported us, and we want to really appreciate the efforts of the MECs of health in the provinces and the HODs. I think we're all aware they're under a financial pressure, and they have maintained payment levels. Although we have quite big debtor days and not every payment is made, the way they've continued to fund and pay for the services that they've procured. We don't charge them unless the provinces ask for the laboratory services, but we're worried about the headwinds ahead. That's something that we're working on in terms of our risk management, because of the budget pressures that the provinces are under, but we wanted to appreciate the fact that their payment levels have been good, and then also just to say to the Portfolio Committee, I think you've kept us on our toes over the years, and those of you who still have your notes from last year and the year before, I think you'll see in here that we take the feedback from yourselves and the questions both now and when we present our strategic plan and our annual performance plan very seriously, and I trust you will have noticed that many of the points that you have raised with us have been attended to over the period. Thank you very much.
thank you very much, Professor and Dr. Chetty. Yes, there I see all of you. Before I take the hands of my members, let me say we're quite saddened to hear that most of you are leaving. And you seem to be leaving soon after each other. And I hope that you will live that ship in a good state with whoever takes over from you. It's been wonderful working with you for quite some time now.
That's very kind of you, Dr. Jacobs,
I'm sure
but
we will
unfortunately,
not stop seeing each other in the future.
yes, thanks very much, Dr. Jacobs, but unfortunately for Dr. Chetty, time has caught up, and in my case, I've reached the limit of the period that I'm entitled to serve on the board of the NHLS. But thank you very much for the kind words.
All right. Dr. Chetty, you're still very young. I hope you're going to stay active. Eat well, exercise maybe, sleep enough, take care of the grandkids. That's it. Should keep you moving. But just to take us to a few things apart from that, before I give to the other members an opportunity. After all of these years, I'm getting an unqualified audit with findings. Was a bit worrisome, but I guess you'd be able to explain that. And then the AG had raised very strongly this thing of application for condonement of the, I think it was, which expenditure was that now again? And I know that we actually raised it last year. I myself raised the fact that you needed to apply. And I'm hoping that you would actually do that soon. And I think that is what probably also led to you getting the fine. But I know you will know exactly what. And then also, you know, the developmental agenda of our country is very important to us, and you have a critical role to play. So your monitoring and improvement and hours of the NHLS is very important so that we can improve the health ecosystem and health outcomes in our country. And just the other day, one of our specialist physicians developed COVID, so you still have a critical role to play in that, in supporting public health through surveillance and outbreak response activities. So, and then the the AG also noted your positive contribution towards updating the influenza vaccination guidelines, conducting a range of COVID-19 related research activities, cholera investigation, HIV research, etc. So we are very thankful to you for that. And you also, I also commend you for your improvement in procurement and contract management compliance, as there were no material findings in that regard. So I think with having given that start to the members, I'm going to take questions from the members, and I will probably come back about what I had just spoken about the application for condonement when I speak lastly. So I'm going to take the members in the following order: Clark, Hickland, and if the members ask fewer questions and not all of them ask questions, you must remember it's been a very long day. Kaba, Gela, Tlengwa, any others? Clark, Hickland, Kaba, Gela, Tlengwa, in that order. Thank you.
Thank you, Chair. Yes, to the Prof and to Dr. Chetty, I very much understand time catches up with us because I'm very much in the same situation. But thank you for your contribution throughout the years, and I wish you well in your new endeavors. There's just a couple of questions that I'd like to ask, and the first one is to please explain the financial implications incurred for the restatement of the financial statements, and also the findings of the audit, as it paints quite a bad picture in financial control, although your financial position is very strong, and I'm impressed that you're able to pay your creditors at 30 during 36 days, your debtors within 36 days. But the following questions I also would like to ask is, what are the plans for addressing backlogs at the forensic chemistry lab? Where are the what are these plans, and what infrastructure solutions are added to these plans? I'd also like to know, what is the amount of specimens that go, that's expiry date comes to an end, and you have to then dispose of those specimens because of this issue. Surely, you say that, the backlog in blood tests is 34% versus should be 60%. Your toxicology is 7% versus 20%. So that must have a major influence on forensic testing. Regarding the TB recovery plan, how does the number of the tests compare to pre-COVID? What is the cost implication of load shedding in terms of purchasing UPS systems and solar power, but also in terms of time loss during these power cuts? What is the current situation regarding the shortages of Genie Expert test kits and CD4 test kits? Please expand on the irregular and fruitless and wasteful expenditure mentioned in the annual report. Thank you.
Thank you, Chair. Good afternoon, everybody. I'm new to the portfolio, so please indulge me just for a moment if you don't mind. The gentleman who said he was very pleased with the way in which the provincial departments are paying, I'm quite surprised to hear that, bearing in mind that you're sitting on a bill of 5.89 billion rand outstanding from provincial departments of health, 70% of which, 4.17 billion, is over 90 days overdue. I don't understand any business, whether it's government funded or not, that can withstand that kind of financial constraint. I understand that you're in a healthy financial position in that you have cash reserves for 6 months. But that kind of a bill, to anybody's mind, would seem extreme to me. I also believe, looking at the figures in the finances, that the NICD, the NIOH, the Forensic Chemistry Labs, and the National Cancer Registry could be called unfunded mandates because they don't get any funding from National Treasury. And you, as the NHLS, are actually carrying that. That must have a really, really, really detrimental effect on your decreasing conditional grant from the National Treasury. What are you going to do to mitigate that? I think that that's it's quite extreme to expect the NHLS to carry that. Load shedding has been touched on by Honourable Clark, but this must have a severe impact on your ability to perform the functions that you're expected to perform. And I don't think it can be overemphasized. I think it's quite heinous, the implications for you, not only in terms of having to go out on tender for solar panels and generators, but the fact the tests have to be restarted and samples must perish because of load shedding is really quite devastating. The attrition of staff, pathologists, including heads of department, to the private sector, how are you addressing that? Are you able to address it? What mitigation strategies do you have? Or are you thinking of trying to bring into being? What limitations is POPIA having on your ability to do surveillance of public health in an emergency? And one last thing, how do you think that you're going to be able to mitigate the stringent deficit that is coming from a decreased conditional grant from the NDOH? I will leave it there. Thank you so much, Chair.
Honorable Kaba, sorry. Honorable Kaba.
Yes. Thank you, Chair. Chair, let me welcome the presentation as made by the NHLS. Mine, Chair, will be just one question in understanding that how effective are the proposed corrective measures towards improving the percentage of TB Genie Expert tests performed within 40 hours and other energy targets affected by the energy crisis? I think it's critical for us to understand that, the effectiveness. Thank you, Chair.
I assume it's me. Thank you very much, Chairperson. Let me also welcome the presentation. Thank you very much, Prof. and Dr. Chiti. Chair, I've got a few questions that I want to ask from the presentation. One, Chair, is that some of the key weaknesses of reoccurring findings from the AG are on the areas of quality financial management and prevention of irregular, unauthorized, and fruitless and wasteful expenditure. What constraints are affecting management and the board in resolving these outcomes, and how are these going to be addressed? Secondly, Chair, how will the board audit and risk division be capacitated to improve audit outcomes? And lastly, Chair, what improved measures ill management adopted to its the risk mitigation action plan to improve performance and compliance? Thank you, Chair.
Thank you. Honorable Slengwa.
Thank you very much, Chair. First of all, let me welcome the presentation from the NHLS. And let me support Makela about the money that unused, whereas the country is on crisis, more especially in load shedding. But I'm not there. My question is that, considering that forensic chemistry laboratories struggled to keep up with the growing backlog of toxicology cases earlier this year, how has your agreement to allocate additional resources to speed up its work affected the budgetary allocation? Two, even today, the board is wait for DNA in the Phoenix in Durban. What is your recommendation of a body found in 2015? Up to now, no one claimed, no one came up. What is your recommendation? What is what must be done about that body, because that body is long overdue? From 15, no one claim it, and they need to be helped, people who work in Phoenix. And the other one of this DNA, if you have somebody with accident or whatever, you are in crisis because you won't get DNA. Thank you.
Thank you very much, honorable members. I see the hand of Honorable Gela still raised. And the
Yes,
hand
Chair.
Honorable Slengwa. So, Honorable Gela.
Chairperson, I'm going to ask a question on behalf of Honorable Muruane Lydia. It seems as if she's got the problem of network. She just sent me questions to ask on her behalf. Chair, what plan are in place to improve the NHLS footprint in the Northern Cape and Free State? The second question is that the target to develop and implement a POCT plan was not met in the financial year. How are the feasibility and cost benefit assessment strategies being implemented in 2023-2024 in preparation for the rollout of the POCT? Thank you, Chair.
Thank you very much, Honorable Gela. So the point I was making earlier was on the regular expenditure, and that the AG is awaiting the application for procurement to the tune of 4.089 billion rand. I'm sure you're very much aware of that. And then further also, the reasons for those who are mentioned as being breach of the 5 pillars of procurement of equitable, fair, cost-effective, transparent, and competitiveness. And how is this to be addressed in the current financial year? And then I also have a couple of recommendations to make, and I hope you will also speak to those recommendations. And that's the board and management to reflect on the root cause of recurring challenges and provide sustainable mitigation strategies. And I've just mentioned one, so I don't think there are many, but just that you can possibly look at that. And to encourage you to ensure compliance with, in terms of the rules and regulations, so that is why this point keeps coming up. And then also to recommend that measures be taken to prevent irregular expenditure. And management must improve its preparations and review of annual financial statements, because apparently these were handed, forwarded, and then corrections were made, and unfortunately received an unqualified audit. But I guess the point here is that maybe it should be done up front, and also to strengthen your consequence management. And we ourselves, in general, and I think that's what we're trying to do now. We raise more difficult questions. We have more vibrant discussions. I was saying to many of the entities which came to present today, it's actually very nice to come to towards the end of a term, and you see how all members, including myself, have just grasped what this is all about, and that we're able to have such discussions, high-level discussions with the entities, with the board chairs and the boards, and the CEOs and everyone involved in the entities, and of course also with the department. Meaning that my recommendation to our portfolio committee is that we strengthen our oversight role, and that we work harder at asking very pertinent, important questions which will improve the outcomes of all services for all of our people in South Africa. So I will hand over to you, Professor Bo and Dr. Chetty. Thank you very much.
Thanks very much, Honourable Dr. Jacobs. I'll just comment on a few things at a higher level from the board perspective. And then, as I mentioned earlier, the Vice Chair of the Board, Professor Jeffrey Pachlele, is in the meeting, and there are a number of financial and audit and risk questions, and Professor Michael Sachs, the Chairperson of our Finance Committee, and Kwenan Koko, the Chairperson of our Audit and Risk Committee, are online, as well as Professor Tanyani Mariba, the Chairperson of our National Academic Pathology Committee, which incorporates the matter of pathologists. Of course, the executives are all here themselves, and the CEO will answer those. But after I've made a few initial responses, I'll just defer first to my fellow board executive members or governance committee members to add any comments that they would like before I hand over to the CEO. So I think that the first question was around the outstanding debt from the provincial payments, and I think we have gone into this a number of times before, and I apologize to Honourable Hicklin that we didn't explain that in greater detail, because we've had history with the committee on that. So I think there is the historic debt, and there are various reasons for it going back. But I think the important thing for us is that in the financial year, if we compare not so much how much of the outstanding debt was cleared and how much of this year's bills were paid, if we talk about the amount that we've delivered of services to the provinces this year, the amount that they've paid us. So in other words, we've expended a certain amount on those services, and then they've paid us, some of it for last year, but some of it this year, but the money that we're getting in is not too far off the amount of services we're providing. So we're in a situation where this debt has been a long-term debt, but it's relatively stable. But we are concerned that with the increased financial pressures in the provinces, that we may have some headwinds up ahead. So I think that is the issue on the question of the 90 days. I hope that's clear. What we're referring to, or the debt, some of it more than 90 days, we're saying, broadly speaking, the amount that the provinces are paying us is dealing with the current year's costs. Whether the payment is for old debt or new debt, it covers the current, what we're spending. The cash flow perspective is reasonable. Then the question about the forensic chemistry laboratories and the costs, it's there. I think, and I think there's a similar question about the funding of the NICD and the NIOH. Now, my board's view is that we have a responsibility to deliver. And we've managed the NHLS well, we've governed it, we believe, as a board. The executive team that's in front of you here around the table have done an excellent job under the CEO of running the organization. And as I said earlier, you've seen our tariff increases are very, very low, under 5%. We've managed to continually enhance our efficiency. We've built up some reserves. And the answer is, well, we can either sit on those reserves and build up a bit more money, or we can make sure that national jewels like the NIOH and the NICD are maintained and fully functional. And similarly, we can make sure that our training and teaching roles, that our responsibility in educating pathologists and laboratory technologists and others is maintained at a high level. Or we can simply say, well, this is the conditional grant we get, so we're only going to let them have that amount of money, and then we'll see those organizations crumble. And we do not want exceptional national assets to crumble. And that's why, as a board, we've been committed over time to making sure that our entities and our teaching responsibilities are properly met, and we deliver for the nation. And the same thing applies to the forensic chemistry laboratories. You asked us, in the long term, one of the questions we will ask is whether, in fact, the SAPS or the Department of Justice should be paying us for the services that we fulfill for them, or whether we work through the conditional grant. Now, we have one of two options. We can spend what we get on the conditional grant on the forensic chemistry laboratories, and we'll come back next year and we'll present to you and things will be worse. or we've got the funding, we can make the investment, and we can solve the problem. And our approach is that forensic chemistry laboratories are part of the national responsibilities of service provision of the NHLS now, and we are going to make the investment in the staff, the facilities, the power, which they didn't have, the equipment, and the levels of skills, and things like proper storage facilities, refrigeration, all of these things. Because if we just use the conditional grant, we'll come back next year and we'll give you a worse situation. We want to fix the problem in the interest of the country, and that's why we will continue to invest beyond the conditional grant. At the same time, we will lobby for increases in the conditional grant. But I don't think that it would be responsible of my board to sort of say, well, we've lobbied for more funds for the conditional grant, we haven't got it, and so we'll just let these things kind of decay and crumble. That's not been our approach. In terms of, I think that we have made efforts on, you mentioned load shedding, and I think there's no question about it. Like everybody else in the country, we are impacted by load shedding. But I think that, yes, it's correct. A number of those turnaround times that we just missed the targets. We probably would have exceeded the targets if there was no load shedding. We accept that, but we have taken measures of various kinds to deal with that, including samples that go into it. But maybe I'll just conclude from my side. I won't go into all the other areas because I've got my colleagues from the governance committee of the board and the CEO and executives are here. But I think that from our perspective as the board, we are governed by the Act. We have responsibilities in the Act. And we want to develop them. We've taken a wide number of measures around the issues of the irregular expenditure, the audit of financial statements. I'm not going to go into that because my colleagues are here as well, and so maybe I could hand over first to Prof. Mphahlele to see if he has anything that he'd like to respond to, and then I'll go to Professor Michael Sachs, then to Kwena Nkoko, and then to Professor Tanyani Mariba, and then hand over to the CEO. Professor Mphahlele.
Good afternoon, honorable members. I think you actually done a wonderful job on the side of governance. From my side, I don't think I've got much to add. Maybe the rest can be handled by the CEO.
Great, thanks a lot. Professor Sachs?
In the interest of time, I think I will defer to the management team who are more able to answer some of the technical questions that have been posed. I will just say that I wanted to strengthen the chair's, what I think he's alluding to, which is that saying, government, obviously the rest of the public service in which the NHLS operates faces a fiscal squeeze. And the danger is that we're seeing in the entity is that government might have, when government has ambitious plans, but those plans are not backed by financial resources, it does impose pressures on an institution like the NHLS. And that goes for both the kind of institutional arrangements and the reforms that are being made as part of NHI to the institutional arrangements, the public entities. If we want these institutions to function well and work and deliver NHI, we have to fund them. And if we're not willing to fund them, it's very dangerous to place that pressure on the institution like the NHLS. These are responsibilities of government. And if we place it on the NHLS, which is about providing excellent laboratory services, we're asking them to take on a burden that is a bit unfair. So that would be my comment. Thank you.
Thanks very much. Kwena Nkoko. Kwena is the chairperson of our Audit and Risk Committee.
Thank you very much, Chair. Am I audible?
Yes, you are.
Am I audible?
Yes.
Thank you. Thank you
Yes,
very
you
much.
are audible.
Thanks. I wouldn't be saying much except just to say from the Audit and Risk Committee, we take note of the issues that are raised by this committee. And just to emphasize the fact that all issues raised in the Auditor General's report are on our radar, and we will be looking at that in terms of ensuring that as the entity, there is an added effort and speed with which we address those things. But so far, in as far as the internal audit function and risk function, we are happy as the committee, and we hope to keep making sure that this unit is independent of management, and management respond to the issues raised through this governance structure. Over to you, Chair. Thank you.
Thanks very much. Professor Tanyani Mariba is the chair of the National Academic Pathology Committee.
Thank you, Professor Buch. I have a problem with my camera, but I think on the whole, you covered most of the aspects adequately. And I think the more technical aspects will be covered by the management team. But thank you so much.
Thanks very much. And just to say, Honourable Chair, this is a well-timed meeting because later this month we have our board strategic planning and annual performance plan strategy meeting where we're going to work on these things, and we will certainly take these key issues that your committee have raised into that meeting as well. So thanks very much for that. And so I'll hand over to Dr. Chetty and the executive team.
Thanks very much, Chair. I think one of the key issues that has been raised by a number of members is the issue around irregular expenditure. And Chair, I thought it might just be useful for us to just very quickly show a slide in order to explain it. I'm just going to go back and share this slide with your permission, Chair.
So to just go to the presentation mode. Over here, can we onto this presentation mode so it's a bit bigger?
So Chair, we thought it might be quite useful to show the portfolio committee just a high-level picture of the irregular expenditure and how we have been managing it over the years, because we've got a very active plan and very sort of detailed account knowing what the issues are. So from and we've categorized it according to all the different types of contracts. So in 2016, you can see that the irregular expenditure is about 990 million. And then what happened in 2017, 2018, we discovered that the problem that we've had is that previously, when tenders were procured, the tenders only paid for the equipment and didn't take the reagents into account. And so what happened is that over the years, the NHLS has been building up what we call catalog items. So for example, the reagents that go with the equipment became a catalog item. Stationery became a catalog item. So that was a big problem. And so the irregular expenditure in declaring all of the catalog items then increased that. Plus, we also had a problem then in 2017 and 2018 with a number of contracts where there was an overspend. This was part of the disciplinary process for the previous CEO and CFO, as well as the supply chain staff that the chair has often spoken about. There were contracts that were expired, and so that was a huge irregular expenditure. And what we've been doing over the years is trying to regularize it. So you can see, apart from the 21-22 financial year, that's because of the COVID-19, we've been steadily reducing the irregular expenditure, so that in the last financial year, there's a small amount for expired contracts. This related to the expired contract of AfriRent that we spoke about before, that we had to settle that small amount. That's the AfriRent contract. The expired contracts, I can give you more details around that. Most of it has been regularized. And then we've reduced the catalogue items quite tremendously, and that we know that over the next year or 2 years, we'll be able to eliminate that completely. And then we added on. What the catalogue items are. So the catalogue items are the ones where I said it's the reagents that go with the machines. So we have to wait for a tender to expire in order to be able to regularize the future reagents. So that's quite tricky. We're balancing it quite well. And then for the last financial year, we added the external testing. So what has been happening is that over the years, there's certain tests that gets outsourced through to the private sector. That didn't go through a tender process. And for the last financial year, we added that as the irregular expenditure, and we're busy regularizing it. So from that, Chair, your question, we've had these amounts that have been condoned by Treasury. So that's the condonement over these years have amounted to 6.6 billion. The amount that's not been condoned is an outstanding amount of 1.8 billion, and we're in the process of taking that through to the board. The Treasury has condoned just more recently an amount of 700 million. So we will look at how we regularize that. And then the board has derecognized an amount of 179 million. So what we haven't submitted for condonation is 931 million, which we're in the process, that's from the current year, and we're in the process of submitting that. So we have taken the points that you have made, Chair. And just to say, from the expired contracts, it's the courier services which we've gone out on tender on, and so that's been regularized. Laboratory services are currently being advertised, and document storage and retrieval is also in the process of going out on tender. The messenger services has been terminated. So, and the final payments, as I said, to AfriRent has been concluded. So we're quite confident that that amount. We have noted the AGSA's comments, but we're a much bigger organization than most of the other public entities. But you can see we've got a very concrete plan in place in order to sort out that irregular expenditure. Chair, I'm going to ask maybe just to talk around the provincial debt. Most of the historic debt is from KZN prior to 2016. And Chair, the provinces have been doing, over the years, the tactic that we have been using is to get most provinces to clear up historic debt. So Free State, Limpopo, Mpumalanga, Northwest, and Western Cape didn't have any debt right up to so it's got cleared up all the debt right up to the financial year of 2021-22. We admittedly have got problems with Eastern Cape and with Northern Cape, and Gauteng has also been attempting to pay its historic debt. What we are concerned about, however, is that in the last financial year that debt has increased. It shows that the provinces are struggling. You know, as I've said, that we're busy having discussions with them with regard to it. Chair, I'm going to ask that the executives come forward to this chair. Can you deal with the financial ones, please? So whilst we are waiting for the executives,
good afternoon, Chair, and good afternoon to the honourable members. So as was introduced by our chairperson, I'm Phumeza Mayekiso. I'm the recently appointed CFO for NHLS. So I'm going to be responding to the question on the financial implications in respect of the restatements that were done in relation to the 2021-2022 financial year in our annual report. So the corrections that were done were twofold. There was a correction of error, or what we term correction of error, and then there were items that are called reclassifications that were done. So in respect of the correction of error, the adjustments mainly, they were coming through as a result of corrections that were identified together with our auditors in respect of tax in relation to our subsidiary, which is SAVP. And then in relation to the reclassification, we process an amount to reclassify an item from provisions which we record under our liabilities of 334.8, and we moved that particular item under employment benefit. So in respect of the correction of error that we made in relation to SAVP, the amount amounted to just under 4 million rand. That was a correction in relation to tax. Thanks, Chair.
Can you take the issue of the risk mitigation strategy for private sector pathologists? Yeah. Okay. All right.
Good afternoon, members of the Portfolio Committee. My name is Kollega Mlisana, as was introduced by the Chair, and I look after the Academic Affairs, Research and Quality Assurance Unit of the NHLS. So I will take us through the question and concern that was raised by Honourable Hicklin around pathologists and the attrition thereof, specifically, as everybody will be knowing by now, that we've got a lot of challenge wherein a significant number of pathologists actually get attracted to the private sector. So just looking at pathologists, and I want us to look at it in three areas. Firstly, how we have managed to address the challenge we had of having difficulties in attracting heads of departments. I was actually just looking at where we were around June, where if one looked at the country across, the number of HODs that vacant posts that we had, we're sitting at around 15. And we actually have managed to appoint a few HODs, about 7 of those, if I look at now, the 1st of October. And some we have managed to attract from the private sector, because one thing that was changed is that we moved away from fixed-term contracts for heads of departments, and we have made those positions to be permanent. As a result, we managed to attract a few more. The second method that we used was that we created what we call HOD developmental post, wherein we take people who may not necessarily be at a point to be to fit in the criteria for heads of departments, but we allow them 3 years or so where we provide support, and meanwhile, whilst providing that support and they develop, they take the positions of HODs. So right now we have got just about 8 vacant positions within HODs across the country. Now, if we look at pathologists, that continues to be a challenge in that, we know that a significant percentage, especially those that are recently qualified, tend to migrate to the private sector. And the attraction there, obviously, is the fact that the salaries in the private sector, there is no way, as the NHLS as an entity, we can match those salaries. But what we have then done is we are now exploring having a retainer, having a 2-year retention for every registrar that has been trained by the NHLS to give us 2 years post-qualification and remain on the NHS platform. And we're hoping that that is then going to make sure that people, when they qualify, they do service the NHLS for a minimum of 2 years. And secondly, we continue to see how we can increase the number of registrars that we train. Because we are the only training body in the country, you find that once a registrar is qualified, they then can choose to go to the private sector. So we then have a challenge of ensuring how do we therefore increase the numbers of registrars that we're training so that we can get to a point, I don't know if we'll ever get to that, where we can saturate the private sector and then ensure that we have got a reasonable number of pathologists that remain. And meanwhile, we continue to explore our HR policies and see how we can make them flexible so that we're able to retain, especially the pathologists who have got the experience, and some of them are retiring. So we do have a policy that's looking at post-retirement pathologists. So I think those are the main, plans that we have in retaining. But I mean, as we say, we still continue to see a significant number actually leaving the country, and we'll continue to find various ways and methods of retaining the pathologists. Thank you, Chair.
Thanks, Dr. Musana. Dr. Clotilda Oliphant will talk to the forensic chemistry next.
Thank you. Good afternoon, Chair and honourable members. The CEO has introduced me, Clotilda Oliphant. I'm the CEO of Strategic Initiatives and responsible for forensic chemistry laboratories. The Chair of the NHLS and CEO have already mentioned some of the strategies that we intend to implement. I will maybe just briefly touch on them again. The aim of our strategy is to increase our service offering and increase the processing capacity of the laboratories. So in terms of infrastructure, the CEO has mentioned the additional space and laboratory capacity that's being created. We've secured additional space at the CSIR in Victoria, which would accommodate an expansion in the blood alcohol as section, and will also be the site for a new toxicology section. So this new toxicology will be commissioned and will process all the new toxicology requests at Victoria. The expansion in blood alcohol will also support some of the Johannesburg HCL service areas. Some of the same process is being followed for the Durban FCL, where we are looking at creating additional space and laboratory capacity to deal with the processing of toxicology in addition to the service that's currently being offered. There is a challenge with cold room infrastructure at 2 of our FCLs, and we are in the process of procuring additional mobile cold rooms to ensure that our storage facilities are in line with the requirements. In terms of equipment, analytic instruments, there were significant delays caused in the past by frequent breakdowns of aging and obsolete equipment. So significant investments have been made in the replacement of aging and obsolete equipment. We are also procuring additional instruments to expand the service, and there's of course ongoing maintenance and repair in that regard. Human resources, we do ensure that there's effective staff complement at each of the FCLs, and that all of the vacant positions are filled, and we've instituted shift systems and overtime work. So that's mainly our strategies. There was a question.
Generators.
Yes. There was a question around DNA testing and conditions at the mortuaries. Just to reiterate, I think at the beginning the CEO identified the responsibilities of the FCL, which relates to testing of blood samples for blood alcohol content, and toxicology testing, and then analysis of foodstuffs. DNA testing in the cases of unnatural deaths fall under the responsibilities of Forensic Sciences Division of the South African Police Service, and then mortuaries and unclaimed bodies, issues related to that are managed by the South African Forensic Pathology Services of the Department of Health.
We're going to talk about the number of posts planned for Pretoria. Sorry? Number of posts for Pretoria. Chair, with regard to the expiry dates for specimens, we have been meeting, as I said, with a number of role players, which includes the forensic pathologists, as well as the South African Police Services, and we had initial meetings with the National Prosecuting Authority. We're looking at a plan. We are concerned, and this is what we inherited, that there are specimens that are very old, and so we're looking at a plan of trying to deal with those specimens to see whether they're viable or not, and where there aren't any identifiers, then we will have a discussion with the forensic pathologist so that we can work out as to what we do with regard to those specimens. So it's a major plan, but and there's a lot to be done, but we're putting all our energy into that. And we've been, the forensic pathology and forensic chemistry services didn't have any support staff. We employed support staff. We had to employ security staff. We tried to fill all the posts with the analysts, and we're also looking at additional posts for both the new labs as well as the existing labs. So all of those efforts are being made. Experts. Yes. So, Chair, with regards to the issue around the TB recovery plan and the numbers with regards to the TB, just to give you an example, during 2020, at the height of COVID, we had about 2 million tests that were being done. In 2023, with the TB recovery plan, we've got about 2.5 million tests. So you can see how the number of tests have been increasing. With regard to the test kits, there was a problem, and as I've said, it's now recovered. But the portfolio committee, as I've indicated, told the portfolio committee that we have awarded a new TB molecular tender that's in the process of being implemented, which will be shared amongst 3 major companies, because the WHO now has accredited some of the other companies to be part of the TB screening, which will mean that there'll be sort of more companies with a diversified platform, so we don't need to be reliant on just one company alone. With regard to the implications of solar, we think the average price from the business case that we did will be about 65 million. Huge investment. This is just for the head office, and it's something we're going to have to look at in all of our laboratories. Chair, also just to say, we haven't had any fruitless expenditure. And I've spoken around the irregular expenditure. The issue around load shedding and samples perishing, that's the reason as to why we've increased the generator power, but we also are using some of the biosafety fridges in some of our other labs in order to store that. We are concerned, but we try to mitigate the risk as far as possible. The issue around Popia, there are issues around, there's a number of issues that have been raised around patient information in emergencies. I know that there's a parliamentary question with regard to that, but we have got a whole manual around Popia. We're very careful about ensuring that there's adherence to Popia, whilst at the same time being able to balance it with the need for research. And I've spoken about the TB, and then Chair, then maybe just also to say that with regards to our footprint in Northern Cape, we've been increasing our capacity in Northern Cape. We've now got services in Northern Cape that we didn't have before. In addition, we've capacitated Greenpoint to be able to do the anatomical pathology samples for Northern Cape. But we cover all of the facilities, all 228 facilities in the Northern Cape, and we're quite happy with the capacity that we do have there. The issue around the review of the annual financial statements, we accept the point made by the Auditor General that there were big changes from the unaudited financial statements to the audited financial statements. But as I explained, that was because of the change in Graph 104, in that we had to restate our doubtful debt. And that's what made a big difference in the changes. And as the CFO has also said, there were issues around plants and equipment and with the grants funding. But being aware of that, we also confident that our unaudited financial statements, that is our aim, to be as close as possible to our audited financial statements so that there is no material findings around that. So Chair, I think we've covered about, sorry?
Point of care testing.
Oh, so and point of care testing, we've raised donor funding for point of care testing, and we've have already started implementing it. So we've got the middleware that interfaces between the point of care and our lab information system, which is extremely important because when it gets done by the provinces, those results don't go into an information system. Whereas with the point of care system that we've got, it goes into the lab information system. So we're rolling out blood gas, we're rolling out HbA1c, we are rolling out with regard to troponin, and it's a project with the donor funding that we've received. We're hoping to, we put in some of our own funding in order to utilize point of care much more effectively. Yes, I think we've covered most of it, Chair. Thank you.
Thank you very much, Professor Buch and Dr. Chetty and the entire team, the board that is present, the officials and senior management of NHLS. I think we've had a wonderful time listening to you, and both your presentations and your answers to the concerns which were raised by the members. It has been a very long day for us. I like saying to my children or my wife, when I'm tired, I say, "Can you see my eyes hanging?" hope you cannot see that my eyes are hanging. But yeah, I wish you all a wonderful evening. Thank you for coming so late and being willing to come so late, and to my members also for being willing to sit so late, and for us to be able to get through this work. If we don't do it, then we wouldn't get the budget approved either. So thank you very much for your help. We are looking forward to seeing you again. I'm sure before you depart, Prof. Book and Dr. Chetty will have another presentation early next year. And yeah, that means we've come to the end of our meeting for today. Maybe if you want to make a closing remark, you're very welcome, Prof. Book, Dr. Chetty. And we will close this meeting.
Thank you very much for your time, Dr. Jacobson, for the questions and inputs from the committee. It's always very, very valuable to us. The questions come with lots of insight. And, I always say to the team afterwards when you're not there that, these are really good questions that we need to go back and have a careful look at. So thank you very much.
Thank you very much. I think this meeting is then called to a close. Honorable members, just to be reminded, we start tomorrow at 1400 hours. We will have 2 presentations by 2 entities. We will go until 7 o'clock tomorrow evening. And please make sure that you attend. Good night, everyone. This meeting is adjourned.
Thank you very much. Good night, everyone.
Thank you very much. Good night, everyone.
Thank you, bye.
Recording stopped.
Thank you,
Thank
Chair.
you very
Good
much,
night.
Chair. Thanks.
Bye.
Dr.
Bye-bye.
Chetty. Bye.